टाइप के हिसाब से डिजाइंड है और रिकवरी टाइम भी कम है। ये तो बहुत खेलना बाकी है। अच्छा चलता हूँ।
स्टैच्यू।
अभी बहुत जीना बाकी है, इसीलिए ट्रीटमेंट जरूरी है।
Issued in public interest for you and your loved ones by Merrill.
Sir, I won't be able to travel for work. कोई desk job दिलवा देते तो।
क्यों भाई?
Actually sir, वो chest में पेन हो रहा था। कार्डियोलॉजिस्ट से चेक करवाया तो पता चला कि ब्लड वेसल में ब्लॉकेज है। स्टेंट लगवाना पड़ेगा।
तो
सर उसके बाद पता नहीं ना कि फील्ड जॉब कर पाऊंगा भी या नहीं।
दोस्त, ट्रीटमेंट जरूरी है और टेक्नोलॉजी भी बहुत आगे बढ़ गई है। कार्डियोलॉजिस्ट का कहना है कि ब्लॉकेज के लिए अब डिसॉल्वेबल स्टेंट्स हैं, जो 2 से 3 साल में खुद ब खुद डिसॉल्व हो जाते हैं और रिकवरी टाइम भी कम है। तुम दुनिया घूमो, कुर्सियां घुमाने वाले बहुत हैं। अभी बहुत जीना बाकी है, इसीलिए ट्रीटमेंट जरूरी है।
Issued in public interest for you and your loved ones by Merrill.
देख, कोई ना आया।
क्यों अंकल, कुछ दिनों से आपकी म्यूजिक प्रैक्टिस ने जगाया नहीं?
बेच रहा हूँ सर, उठा तक नहीं पा रहा हूँ। बजाना तो बहुत दूर की बात है। कार्डियोलॉजिस्ट का कहना है कि मेरे हार्ट का वॉल्व खराब हो गया है, तभी करवाना पड़ेगा।
तो
अब इस उम्र में इतना बड़ा ऑपरेशन करवाऊंगा तो रिकवर नहीं कर पाऊंगा।
अंकल, ट्रीटमेंट जरूरी है और कार्डियोलॉजिस्ट का कहना है तभी मिनिमली इन्वेसिव प्रोसीजर है और रिकवरी भी 2 से 3 दिनों में हो जाती है। अभी तो बहुत गाना बजाना बाकी है। वैसे ये वाला ले लूं?
क्यों भाई, फ्री का है।
अभी तो बहुत जीना बाकी है, इसीलिए ट्रीटमेंट जरूरी है।
Issued in public interest for you and your loved ones by Merrill.
RG Institute of Robotic Surgeries, India's largest chain with 14 urology and laparoscopy centers across the nation. Pioneering excellence in comprehensive urological care, RG Institute of General and Minimally Invasive Surgery. Backed by highly experienced surgeons, support staff, advanced medical equipment, and instruments. NABH accredited centers to assure quality and safety in every aspect. RG Hospitals. Exceptional care.
Good morning, sir.
Morning. The tomatoes look good. What should I grow next year though? How can my farm adapt to climate change?
You only progress when you ask better questions. Mint. Think ahead. Think growth.
Delhi is a super speciality hospital looking after the health needs of the people of Ghaziabad and nearby areas. Yashoda believes that just dispensing medicines to the sick is not enough.
On the 6th Foundation Day of All India Institute of Ayurveda, we are thankful to Honorable Minister Sri Sarvanand Sonowal ji, Dr. Mahendra Bhai Munjapara and our Secretary Vaidya Rajesh Koteja ji and all the senior officials for their ever-time support. On the 6th Foundation Day of All India Institute of Ayurveda, we are thankful to Honorable Minister Sri Sarvanand Sonowal ji, Dr. Mahendra Bhai Munjapara and our Secretary Vaidya Rajesh Koteja ji and all the senior officials for their ever-time support.
The All India Institute of Ayurveda, AIIA Sarita Vihar, New Delhi, stands as a testament to India's commitment to preserve and promote its ancient holistic healing tradition. dedicated to the nation by Honorable PM Shri Narendra Modi ji in 2017. The institute has emerged as a pioneering center dedicated to education, research and tertiary healthcare in the field of Ayurveda. Within the short span, AIIA has grown rapidly and achieved numerous milestones, solidifying its place as an exceptional institution in the field of traditional Indian medicine. Thus, care with compassion has been AIIA's motto since the beginning.
Very good morning, ladies and gentlemen. I would request all the guests who are at the back of the hall to kindly take your seats, please. I would request all the guests to please be seated. We are almost set to begin the summit. I also request all our guests to please keep your mobile phones on silent mode. Thank you.
In the Ayush public sector. Furthermore, it holds the ISO 9001-2015 certification for quality management, showcasing its commitment to delivering high-quality care to its patients. The hospital operates various specialty clinics addressing a wide array of conditions, including diabetes, respiratory disorders, musculoskeletal issues, obesity, psoriasis, neurology, nephrology, infertility, PCOD, menopause, anorectal conditions, old age-related pathologies, and many more. AIIA boasts comprehensive inpatient facilities offering treatments such as Panchakarma, leech therapy, Ksharasutra, Kriyakalpa, and various surgical interventions. Healthcare impact.
Very good morning, ladies and gentlemen, and welcome you all to Mint Healthcare Summit 2023. I'm your host today. My name is Ayush, and it's a pleasure to be hosting this wonderful summit on this beautiful day. Ladies and gentlemen, as we all know, healthcare in India has two faces, one of plush and high-tech private hospitals and healthcare centers in metros and large towns, and the other of government-run healthcare centers all over the country. With a population of 1.4 billion, a sizable proportion cannot afford healthcare or insurance. In India, providing timely healthcare is a challenge. The state of public infrastructure in rural and urban areas is deteriorating, exacerbating the doctor shortage. Inadequate funding, disparities in quality, low insurance coverage, and a lack of preventing care awareness all contribute to the system's shortcomings. Today, at the 7th edition of the Mint Healthcare Summit, policymakers, healthcare leaders, industry captains, startups, medical experts, and various stakeholders in the health ecosystem from across the country will convene on a single platform to discuss sector challenges, opportunities, the boom in the healthcare startup space, and technological advancements. Before starting, I'll take a moment to thank all our partners without whose support this summit would not have been possible. I would like to thank our associate partners, All India Institute of Ayurveda, Yashoda Super Speciality Hospital, Kaushambi, RG Stone Urology and Laparoscopy Hospital, Merrill Life Sciences, and Center for Sight. I would also request all our guests to keep tweeting about the event, about the sessions, about the summit using the hashtag Mint Healthcare Summit, and please do tag us on Twitter at LiveMint. Now to begin a beautiful start to Mint Healthcare Summit 2023, I would like to invite to dais Ravi Krishnan, Editor-in-Chief, Mint, to kindly come up and address the audience. Let's give him a louder round of applause. Thank you.
Ladies and gentlemen, esteemed guests, distinguished participants, Secretary of Ayush, Vaidya Rajesh Kotija ji. It's my honor and privilege to extend a warm welcome to each and every one of you to Mint's Healthcare Summit. This is the 7th edition of the Healthcare Summit, and while much has changed since we started this journey, a lot of things still remain the same in India. We have one of the youngest populations in the world and count on our demographic dividend to become a developed nation by 2047. but we might just fritter away that advantage if we don't pay attention to the health of our citizens. To set the context for today's discussions, I would like to highlight 3 challenges which I think we face as a country. One is we confront the reality of a rising toll from non-communicable diseases. We have the unenviable label of being the diabetes capital of the world. Over 100 million Indians suffer from diabetes, for example. This is just one example. The rising burden from cancer, cardiovascular diseases, and respiratory diseases. I mean, think about the air we breathe in Delhi today. These all emphasize the urgent need for a comprehensive approach to healthcare. We should move away from a treatment-based approach to preventive care, early detection, and so on. The second issue is access to healthcare and its equity. That leaves much to be desired. Total government health expenditure is around 2.1% of GDP, which is not enough when you compare it to a lot of other comparable nations at a comparable stage of development. There is a shortage of infrastructure and manpower, particularly in rural areas. The doctor-patient ratio remains a concern, impacting the quality and timely delivery of healthcare services. There is disparity between states, between urban and rural, and between the private and the public sector. Third is the challenge of increasing insurance coverage for Indians. Out-of-pocket expenditure on healthcare as a percentage of total healthcare spends is estimated at around 47% today. It's a decline from 62%, which was there, I think, around 2016. But, it's much higher than the world average of 18%. We have all heard stories of even middle-class families being pushed to poverty, because someone in the family fell sick and had to be admitted to hospitals for a long time, etc. Well, much has been done, in the past few years with initiatives like Ayushman Bharat. A significant percentage of Indians remain uninsured and are facing the burdens of these diseases. I mean, but I don't mean to sound negative because, we have got a lot of things right. So although COVID-19 exposed the soft underbelly of our healthcare system, we rose to the challenge with our successful vaccination program. Our achievements in reducing infant mortality and maternal mortality rates also demonstrate that positive change is possible when we put our hearts and mind to it. It's important to draw lessons from these successes and apply it to our broader health framework. And also new technologies like artificial intelligence now offer much hope for the future. We have a large number of startups now trying to solve big problems in healthcare and also in health tech. So may our discussions and questions, asking better questions is a USP of Mint, and collaborations, may these pave the way for a brighter and healthier future for India. Thank you very much.
Thank you very much, sir, for your welcome address and for setting the context of the day. Now it's time to have our first keynote address of the day on Ayush, India's gift to the world. And to deliver this keynote address, may I please invite on stage Vaidya Rajesh Kotecha, Secretary, Ministry of Ayush. Can we please give him a huge round of applause?
The team Mint, and thanks for setting the contest, and all other participants came from diverse areas like industry and the civil society and experts and all policy makers. So thank you for coming and thank you for inviting me. Actually, I want to mention a small correction into the statements that doctor-patient ratio is no more less than 1,000, is now 1.8 per 1,000. So we are almost much ahead of doctor-patient ratio standards of WHO, because 3 years back, Government of India has decided to include Ayush workforce into doctor-patient ratio. So it was notified by MOSPI, and now it is formally, in public domain that it is no more a concern because Ayush workforce is huge, almost 700,000. This is one thing. And, from the perspective of what Ravi ji mentioned, it is true that we all need to collectively think about how we can collectively think about resolving these, issues of the healthcare sector into our country. But everything is not grey. And then I'm happy that he also has mentioned that in last few years, a lot of things has happened. And that is one of the thing. One of the area that I'm representing is Ayush. And in our country, it's a very special thing that we have a separate federal ministry of Ayush in our country. And this ministry is working with the health ministry together and then delivering a lot. I will have some examples and some discussions. So I'll focus mainly on Ayush, looking at these contexts, what Ravi ji has mentioned, but I will be speaking more of Ayush, what Ayush is doing into these areas of health and how we are contributing. So this is that I want to do. If somebody can help me to how to do this, Okay. So we have in 95 it became a department. Before that it was a small section into the ministry. In 2003 it was renamed as an Ayush, and on 9th November 2014, immediately after our Honorable Prime Minister became the Prime Minister, in few months the Ministry of Ayush is now it was a full-fledged ministry. There is a later development also. For first few years it was headed by a minister having independent charge, a state minister. But in 2019, this ministry has been given a cabinet minister, a minister of state. So it's a full-fledged big ministry. And then because of this status, this ministry has delivered a lot, not only into the policy, but into actual area of research, education, public health delivery system. Everywhere there is a lot of delivery. I was just talking with one of the team member, and she was asking me that what is about your budgetary allocation, of ministry. I said that it is more than 5 times. So in 9 years, no ministry has 5 times, more than 5 times. Of course, our kitty was small, but still from 700 crore to 3,600 crore in 8 years, 9 years is big. So that also has happened, and then there are a lot of such things has happened in last few years. And so from different perspective, I would like to speak. Like for example, for policy support mechanism, we have different enactments. So one of the act is National Commission for Indian System of Medicine. So it has replaced earlier act CCIM, Indian Medicine Central Council Act. So after enactment of these two acts, homeopathy and national medicine, Indian medicine. So all of the education sector has a lot of reform, lot of transparency, and this is being reflected now that the new generation people who is coming out as a product of Ayush, they are world class, they are delivering. So this is one of the area. Then another is we have this legal support from Drug and Cosmetic Act. Now we all know that there is a new drug act coming up and it is in public domain, and in maybe this year or maybe later part of this year, next year it will be cleared. So in new drug act also we have, together with Ministry of Health, we worked hard and we are trying to bring in lot of transparency and ease of doing business. Also with BIS we are working with Indian standards, and later we want to take it to the ISO for products and services of Ayush. With Quality Council of India we are working, and then a lot of quality certifications like NABH and other things are happening. May I have the next? In education sector, other than these two acts, we also have another two achievements. One is that Institute of Teaching and Research in Ayurveda Jamnagar is the first institute by act of the Parliament was upgraded as an institute of national importance. It's like IIT, IIM, AIMS. So this is first ever Ayush Institute upgraded, and now it is working at that level. This is one thing. Another thing is our National Institute of Ayurveda at Jaipur. It's also became a de novo category university in last few years. Next. whenever we have some discussion on Ayush, the Ayush people are advised that you people are good, but you ought to bring evidences. You need to generate evidences, but we don't know what is going on. So this is very specific that I want to mention, and I would request all of the participants to go to Google and then type Ayush Research Portal. We have started an index services of Ayush publications, and at that portal we have put more than 40,000 publications, which is index journals or peer-reviewed journal publications, and all those Ayush-related publications are published across the globe in the best journals of the globe, including Indian journals, which is UGC Care List journals. So specifically, there are some interesting evidences that we have created, like we are working with CSIR, IGIB, Institute of Genomics and Integrative Biology, and there we have a 3-Sutra program, Ayush Genomics. So we all know that in Ayurveda there is a Prakriti, Vata, Pitta, Kapha, Prakriti, and according to the Prakriti we customize our lifestyle and our aptitude, and lot of things are there. There is a huge knowledge being in practice. So we wanted to understand whether there is a genetic connection of, phenotypes, of connection of our human genome with the Prakriti principle. So this unit is a center of excellence, and they did a lot of work about that, and they have contributed a lot of publications, lot of translations of Prakriti analysis and then its practical applications. Another is InsureTech at IIT Jodhpur. So at IIT Jodhpur, they are looking at the medical devices area of Ayush, and there is a lot of development into that area. Another is CIMR AIMS. In AIMS, there is a Center of Integrative Medicine and Research. So this center is in Delhi, is working on Ayush researches, high-end Ayush researches. So I want to cite a couple of examples that this center has published. One of the publication is that adding yoga into migraine management, and then if somebody is having severe migraine, they are supposed to take a lot of medicine. So this work has was able to establish that if we add yoga, there is less need of medicine and there is a less frequency and intensity of the migraine attacks. So this is something. Another publication that I want to cite is very unusual, publication coming from the AIMS. This publication is talking about assessment and comparison of the yoga practitioners and people going to the gym for the exercise. So from the physical parameter perspective, the outcome was the same. But they did assess on the functional MRI, they did assess the guna, sattva, rajas, tamas guna, that if somebody is practicing yoga, their sattva is up, and if somebody is going to the gym, their sattva is down. And that publication came from the CIMR AIMS. Then we are working with ILBS, Institute of Liver and Biliary Sciences, that in Panchakarma, Ayurveda offers Panchakarma is a detoxification, different kind of detoxification. One of the Panchakarma is Virechana Chikitsa, in which the chikitsak, the physicians give lot of ghee and then do purge. So mechanism, how it works, the doctors would know that if we do Virechana, this would happen, this kind of outcome would happen. But then how it works. So in this ILBS list, recently we found out that by doing Virechana, actually the gut is completely clean and new colony of microbiome is being regenerated, and that is providing lot of solutions of lot of different types of inflammations. So that kind of research is going on. In Nimhans, there is a Department of Integrative Medicine. Their professor is from Ayurveda, associate professor is from Yoga, and assistant professor is from Psychiatry. So this is a model for future model of our country. So based on this model, now all AIMS have decided to have a department, Integrative Medicine department with faculties, education faculty of professor and the entire academic department is going to be there in all AIMS. Then we have also supporting scheme through extramural research, public health initiative research, collaborative research. We are doing a lot of collaboration. One of the example is that we are doing with National Health Services, NHS UK, and one of the university in UK, London School of Traditional Medicine and Hygiene. And we are working on ashwagandha, long COVID effect of ashwagandha in UK on sample size of 2,500 people, is a double-blind placebo-controlled study which is going on. So those kind of things we are doing, and there are a lot of such things. Last thing is about Ayush ICMR Advanced Center of Integrative Medicine Research in all AIMS. We have decided with ICMR that together we will do this, and it is already happening. Next. About the public health, we have National Ayush Mission. We have also co-located facility across the country. So I'm just citing some numbers. More than 25,000 facilities across the country, including district hospitals, including PSCs, CSCs. There is a co-location of Ayush. There are more than 12,500 standalone Ayush health and wellness centers being operational. Or from that 12,500, almost 9,000 is operational. By June next year, we are committed to finish this 12,500. And the patients are coming in a big way. So this is an example that from 1st January 2022 to 31st December, in these 7,000 entry-level health and wellness centers, we have seen 8.42 crore patients. So it's huge. Average footfall is 40 to 50 per a small center which is catering 3,000 population. So it is huge. So that is happening, and there are a lot of different programs addressing non-communicable diseases, addressing mental health care from Ayush, addressing school health children. Different names we have given, the Supraja and Ayurveda and Ayush mobile medical units, etc. Next. We also work in the area of medicinal plant, promotion of medicinal plant, because the feeder from Ayush medicine is from medicinal plants. So we are also taking care of that more and more medicinal plants are cultivated, and we have less and less dependency on the forest resources. That is happening also. Then in National Ayush Mission, I already spoke about that, but other than that, there are 113 Ayush education institutions upgraded in last 8 years. 315 Ayush hospitals and 5,000 plus dispensaries were upgraded. 137 50-bedded hospitals across the country has been supported, and then there are different co-locations, etc. that I already mentioned. Next. There is another important area of Ayush, that is Ayush Grid. So we are working on having digital solutions for all of the things about Ayush, not only research and education, but public health and all of the other solutions. So we have found, already we have established more than 22 such solutions, including AIM Yoga application, Namaste Yoga, Ayush-based health management information system, eCharak is a marketplace for medicinal plant, or eSanjeevani mobile application, Ayush Next. So just to mention one interesting thing which is highly appreciated is Vibreak application. In Vibreak, like we all work hard and we believe that we work hard, but we have no physical activity. We just sit and doing mental exercise, but no physical exercise. So this Vibreak application gives the room for everybody of us of having 5 minutes capsule of some stretching and some yoga and some meditation, sitting on the chair or by just standing up on our desk and then doing some stretching. So this application is available on both platform, on Apple and then on Google platform. So there are so many such things are happening in the area, but lastly I want to mention that we are working with ITO, WHO joint initiative of AI in health. So in AI in health, we have proposed that there should be AI in traditional medicine, and Government of India is leading this initiative. So we are working with them and then creating AI solutions for health. Next. This is something very interesting, because when we talk about Ayush, we always have this narrative that there is a problem with the products, there is a problem with the services, and we don't know what they are giving. So that's a narrative. It's largely not true, but more of a narrative. So what we want to do authentically, we want to record if there is any adverse drug reaction, it should be recorded. So we have created this mechanism of Ayush pharmacovigilance program, where across the country we have pharmacovigilance centers, and they formally record the adverse drug reaction, if any, from Ayush drugs intervention, and it is largely successfully working. More than 10,000 ADRs were reported in last few years, and none of them were fatal. So all of them were very mild and self-limiting. And then also we are working with this Pharmacopoeia Commission. We have Pharmacopoeia Commission of Indian Medicine, which works on publishing monographs. So these pharmacopoeial monographs, all industry is supposed to follow this pharmacopoeial monograph, and we are working with the states. So states ensure that this is complied by the industry. Next. Then already I mentioned about BIS and ISO, that we are also working with them, but there is one perspective that I should mention is there is a huge business about that, for the country, because we were so innocent that we were sending our products across the globe, But then, when the regulators, usually some of the hostile regulators, they would ask us, "Aap standard bataiye, what is the standard of these products?" So we were so innocent that we will send the pharmacopoeia monograph. So when we sent pharmacopoeia monograph, they said, "This is medicine. It should come under chapter 30. It is not it is prohibited. So you are sending us medicine." Actually, lot of our products are being sent as a supplement because they are so simple. But then this was prohibition. So we are working with BIS, and BIS has already published 50 such Indian standards, which we are willing to convert into ISO standard, because we already have applied to ISO for a sectional committee of Ayush. So once it happens, then in more than 150 countries, such our products and services are allowed based on these ISO standards. So this is very interesting strategy for the industry to understand. Next. There are lot of MOUs and country-to-country partnership that I just want to mention in numbers. But then, this is not just MOU, but we are working hard with the other countries in bilateral talks and in different negotiation platforms, etc. Like, for example, with European Union, we have a joint working group for Ayurveda products to be introduced into or to be approved into European Union. So there is a joint working group there. We have also requests from different countries. Like we got a request from Colombia that we have approved Ayurveda, but we don't know what to do next. So we are helping them to do regulatory framework for Ayurveda products and services. Like in Switzerland, they have approved Ayurveda, but then they have a self-regulatory mechanism. So we are helping them to come up with a model where self-regulation is very robust, and then practitioners from India are allowed to practice there. So a lot of such things are happening. And the last couple of things I will talk about the WHO collaboration with Ministry of Ayush, Government of India. We all know that there was recent development about establishment of WHO Global Center for Traditional Medicine in India. It is very significant because this is first UN outpost or UN office established in any developing country. Because before that, there was no UN office established in any developing country. It was all established in developed countries. So this is first. And then because of this coming in India, we are able to provide leadership to the globe about the traditional medicine. And then lot of things we are working with WHO, like benchmark documents of practice and training of Ayurveda, Unani, Yoga, Panchakarma, or working with them with ICD-11 inclusion of morbidity codes of Ayurveda, Siddha and Unani. This is important from the science perspective, because once this happens, then across the globe, these practices are understood by modern medicine practitioners also, because it talks about a convergence of understanding of morbidity codes of Ayurveda and modern medicine, and then it can be captured. It is also beneficial for insurance sector to understand and standardize the insurance packages. Lot of such things are in pipeline. It is finalized, and now in January we are together, WHO and Government of India is going to release this ICD-11 inclusion of ICD-11 traditional medicine. It will be released. Another thing is about COVID-19. So we did a lot of studies with the WHO also, and independently Ministry of Ayush and other universities. I will not speak a lot because we all know, we have multiple times heard about contribution of Ayush in COVID-19. Lot of such publications are there. There is 88.9% of Indian population reported that they have used Ayush by an independent study, and it is also published. Next. I already mentioned about Global Center for Traditional Medicine, but there is an interesting thing that based on this platform of WHO Global Center and Government of India together, they have jointly hosted a first ever WHO Global Summit for Traditional Medicine in Gujarat, in Gandhinagar, as a co-branded event of G20. And in that, there are more than 75 country participation was there. And together, they deliberated on a lot of things, what should be done across the globe for traditional medicine. And they came out with a declaration, which is known as Gujarat Declaration. You can find it on WHO website also. The Gujarat Declaration talks about what is next for the traditional medicine for next 10 years. So we are also contributing, as India is also leading for creating the WHO traditional medicine strategy for 2025 to 2034, 10-year strategy. So lot of such things are happening. Next. These are some interesting figures. One of the interesting figures that I want to mention is that the sector size of Ayush industry, manufacturing, grew by 8 times in 9 years. This study was done by RIS, and based on 2014, it was only $3 billion, but then in 2020, it became 18 billion, and now as per the projection, it is $24 billion. So huge potential. It is believed that it is a very nascent sector, but it is not nascent anymore. We are also having a service sector study. The first initial outcome is there with us, and it says that the service sector size is also almost similar. Almost 165,000 crore rupee is the service sector size. So together, this becomes 3,40,000 crore rupee of size of the sector, Ayush industry, manufacturing and services together. And it is spread in 100 plus countries. More than 24 countries have already approved formally the Ayush sciences, either Ayurveda or Yoga is everywhere, but Siddha or Unani, etc. Next. Thank you so much. So I think I have complied with my time. Thank you.
Thank you very much, sir, for sharing all the wonderful insights with us. Once again, we would like to thank Shri Vaidya Rajesh Kotecha ji for joining us today. Thank you so much, sir. Up next is the session of the day, Super Speciality Hospitals, Challenges and the Way Forward. I would like to invite the moderator for this session, Alokesh Bhattacharya, Deputy Managing Editor, Mint. And the speaker on this session will be joining us online, Dr. Upasana Arora, CEO and Managing Director, Yashoda Super Speciality Hospitals.
Upasana ji, welcome. Can you hear me?
Yes, good afternoon.
Good afternoon. Thank you. We have quite a few people here in the hall. I don't know if you can see them. They are here.
No, I can see you only. Yeah.
A lot of people are here listening to you. And we'll have a short and sharp session like we discussed yesterday. So Yashoda Super Speciality Hospitals has been doing quite a lot of interesting things in recent times. You have a robotic surgery department now with AI, right? A lot of work on the technology side. You're also getting into genomic testing with another analytics partner. All very, very exciting things, which I'm sure must be costing you a lot of money also. We'll come to that a little later. But first, if you could tell us, super specialty hospitals like yours, typically we tend to look at them as highly expensive and, super specialty hai, let's stay away, go to some, more affordable places. Is that a right kind of perception, or what is the role really that hospitals like yours fill, and what is the gap that you fill in Indian healthcare?
So I would like to tell you there are few diseases which you cannot treat everywhere. There are, like when patient is serious or he need really quaternary care or tertiary care, you need to go to super specialty hospital. And if you see, my name and my hospital name is known for affordability, because what we try to give best quality care, all cutting edge technology with affordable prices. Because it's a family run hospital, Yashoda is a family run hospital, and we are actually trying to help people, especially those who cannot afford, because India is a thickly populated country, and lots of people who are not having much money and they are not saving any money for their healthcare. So there have to be some hospitals where they can go and they can get quality care with the, with that kind of rates where they can afford. So we are known for that, and in Yashoda, if anybody visits, they can find that we are trying to create atmosphere that nobody can feel lost. As when you are in a hospital, you all time feeling scared and lost. We are trying to create an atmosphere that you are at home. So Yashoda is trying to create a difference in with other hospital and my hospital. Yeah, over to you.
I feel very scared when I go into hospitals. So trying to lose my way. All the corridors look the same, right? I think a lot of people will relate to that. Now, if you could also tell us what are the challenges you face, right, as a hospital, both from policy side and in terms of making your services affordable, because it must be costing you quite a bit of money to have some of these high-tech equipment and services up and ready, right? So maybe you could tell us a little bit about the challenges that you face and what sort of support you think is needed, right, to meet those challenges.
I would like to tell you that before a few years back, if we talk about, there was a big challenge of talented doctors, talented staff, because in a hospital, if you are trying to give right treatment, good treatment, then you not only need good doctors, qualified doctors, but you need paramedical staff also who has to be trained. So there was a big gap between bed capacity and talent. But now, if you can see, our government is taking so much interest in healthcare. So now there are many medical colleges are on, and if you see last year budget also, that lots of nursing colleges are now placed in different places, as well as DNB courses are also playing a major role for closing this gap of manpower, talented manpower, and hospitals. So this was a big challenge that time. But now things are actually better than before. And if you see policy, then there was no insurance for anyone. But when Ayushman came into the picture, so I am really happy for who are not having any kind of, they cannot go for any super specialty work. I can give you an example of kidney transplant. We have done first kidney transplant of Uttar Pradesh. That girl was a 16-year-old Muslim girl, and her mother gave her kidney, and she went her home happily on Eid. So such kind of we can introduce such kind of schemes to the nation, and I think after some time this insurance companies will also give concessional rate to premium. So everybody has to cover their self for some or other policy, because out of pocket expenses for private patients are really painful, because nobody think about that. Everybody is keeping money for their car, for their home, but nobody think if we will get sick, then how we are going to treat ourselves. So mediclaim is very important, and I think after some time everybody will be covered under some or other policy, so it will not be a problem. Over to you.
Okay. There's also an interesting thing I read up on your hospital as to how you are actually working with corporates to provide healthcare services, affordable healthcare services to employees based on their CSR funds, right? Now, we have, of course, all of us are well aware of insurance companies tying up with corporates and enterprises to offer insurance solutions, but this is not so common, what you are doing. You want to tell us a little bit about that, and also how other corporates can also do this in terms of working with hospitals to offer affordable healthcare, especially to the blue collar workers or workers who have less salaries and all.
Yeah, actually, we are from a very, very normal background. My husband and me both were from a service class family. And we started this hospital in memory of my mother-in-law, Yashoda ji. So she was a cancer patient. So when she expired, so my husband and my family decided to start a hospital in 1990. We started our first hospital. So we understand the pain of, a middle class person who is not having lots of money, or that time there was no, insurance or something like that. I also lost my parents because of not very good care was that time available, as well as technology was not there. So we try to put our, try to fit in other shoes, how they feel we should also feel. So this is our thought process, I should say, and whatever I am saying, that is my personal views. So I work with the, TB Mukt Bharat Abhiyan. So we have adopted whole Ghaziabad. We are providing them not only nutritional food, rather we are keeping their track also. We are providing them counseling, That is how our hospital has called as a step center. So these are small things which any other hospital or corporate can create. These small things can create a difference in others' life, and which is not going to affect you. I mean to say that corporate or that hospital. So this is our just a gesture to others that we want to, provide something to them which they are not getting easily on other places.
Like I was saying in the beginning, a lot of high-tech news about Yashoda hospitals these days. And so maybe you could tell us a little bit about technology and what you're doing on that front. You have this genomic testing partnership that you have got into with HealthTech Analytics. You launched a department of robotics and robotic surgery and AI. Like our editor said in the beginning, AI is going to be a big force in healthcare going forward. So it's interesting to note that you have already launched an initiative on that front. So maybe you could tell us a little bit about that.
Actually, I would like to tell you when I started my career. So that time we were having only one hospital in Ghaziabad that is located in Nehru Nagar. So our hospital was also issuing reports manually. So when I joined, I thought I should, because my family was fully involved in that and I wanted to do something different as well as latest. So I adopted this computerization of the hospital and then different kind of things like internet connection, and we were doing lots of different things. So then when these latest technology has entered into healthcare, like telemedicine, like you can see, like we have now started hub and spoke model. We have different places. There are small clinics and we are providing them consultation as well as so I thought I should do whatever is required for a patient need. Robotic surgery is really helpful, especially for critical cases. So patients are very, very happy with the surgery because they are discharging next day, very fast healing, no blood loss, very minimal blood loss. So that is how we try to do it. And luckily, touch wood, our rates of outcome is very high and everyone is happy. My doctors are very competent and they have adopted so well. I was really surprised to see that when I sent them for training and when they came back and they started doing surgeries. So first case was very, very difficult and they have done it successfully. So my team is also enthusiastic. You can say young doctors, enthusiastic doctors. With if management is also try to do all the new things and everybody has the same vision, then you can achieve your goal. So that is how we could do it. And same time, genomics, I really want to do something for future. Like if you go for this test, you can understand what are the problems your parents had, what problems right now you have, and what can be done with you, what problems you can face in future. So at least when you are aware what has to be going with you, you are taking some precautions. So that is how we started this, and now we are trying to do teleradiology we are doing, but now we are going for telepathology also. And I want to create a digital hospital where, like in my hospital, you need not to come back. You can see your report online. You can get appointment online. You can talk to doctor online. But still, I believe healthcare has a different kind of, emotional touch with the doctor. Nowadays, it is missing. But if you see my age, I am 50s, 54 years. So we really love to see our doctor and we have an emotional connection with our doctor. This should not be lost because of technology. That is my, request to everybody. Go for technology, but with human touch. And same thing I want to tell for business model also. If somebody wants to start some business, then he has not started a hospital. Hospital, you cannot run on a business model because in hospital, there are lots of emotion involved. You need some empathy, sympathy with others. Yes, over to you.
Upasana ji, if there is one change or one improvement in any healthcare policy, you spoke about Ayushman Bharat and how it has helped the industry. Is there anything specific that you would like to see change?
Yeah, actually, if you see, not big hospitals are not adopting Ayushman Bharat. I want everybody has to adopt because, you know, a segment of people are not getting proper care. So they have to also adopt this. And everybody is talking all the time about that money is very less, packages are very less. That is why we are not taking. So my request to everyone that government is also trying to do whatever best. Even they have increased CGHS rates also. They will improve this also. But this is something, if you are into healthcare industry, we are supposed to provide healthcare to all, and we cannot differentiate between persons, between our patients, just according to their packages. So this is a difference which Ayushman Bharat doesn't has to change. Our corporates has to change their mindset, and they should also come forward to help poor.
Well said, Upasana ji. Thank you so much for your patience and for joining us here today. It was really wonderful speaking with you. Thank you very much. Let's have a round of applause, please.
Thank you so much for calling me. Thank you.
Thank you.
Thank you, Dr. Upasana Arora, for joining us online, and we thank our moderator, Alokesh Bhattacharya, for driving this session.
Recording start.
We're all set to begin with our first panel discussion of the day. We'll take just a couple of seconds to set up the stage. The topic for our first panel discussion of the day is ensuring the uninsured health insurance's penetration challenge. First up, I would like to call on the moderator on stage, Aparajita Sharma, Assistant Editor, Mint. And now I have the pleasure of inviting on stage our panelists, Mayank Gupta, COO and co-founder, Zopper; Dr. Bhabatosh Mishra, Director, Product Underwriting and Claims, Niva Bupa Health Insurance; Shilpa Arora, co-founder and COO, Insurance Samadhan; and Rishi Mathur, Chief Distribution Officer, Alternate Channels and Chief Strategy Officer, Canara HSBC Life Insurance. Welcome all the panelists. Over to you, Aparajita.
Good evening, everyone. Can you hear me? Yeah. Thank you so much for joining us here at MILT Healthcare Summit. I am here to start off with our very first panel discussion. Warm welcome to all my panelists here. So the topic that is under discussion is really very important, under-penetration of health insurance in the country. So I'll begin with a small data. The latest report by IRDA, which is for FY22, it says that total insurance penetration in the country is just 4.2%. Just 4.2%. It is premium to GDP ratio. Now, 3.2 is for life, 1% is non-life, and within non-life, just less than 1% for health insurance. So really sorry figure to have. I'll start off with Dr. Bhabatosh. You representing health insurance company here. Then you have been a veteran in the industry. So according to you, what are some challenges that you have observed in your journey, that why this figure is so low, and how to have better penetration of health insurance in the country?
Thank you, Aparajita. Thank you, Mint. And thank you, everyone. Numbers, statistics are like very interesting things, no? As Ravi Sastry said in one of the commentaries. They reveal less than they hide. The other way to look at the figure is that roughly about 52 crores, 520 million individuals in India today have some form of health insurance, which is a combination of, let's say, privately purchased health insurance. It could be centrally sponsored health insurance. It could be state government health insurance. Right. So that's a good number to have. It's not as bad as it appears sometimes. So it's roughly about 36-37% of the population of this country having some form of health insurance. But that's not adequate. That's certainly not adequate. And secondly, the extent of health insurance coverage these 37% people have is perhaps grossly inadequate. And some of the challenges is one, I think we are a very young country. Our average age is 29. 46% of the population is below 35, below 40. And you talk to a 25, 27, 30-year-old who has started working maybe 5 years into the first career and ask them about health insurance. There is no perceived need. I am healthy, hearty, everything that is going to happen to others, not to me, and I'll buy it when I need it. Look at it in context of what is happening around us also. I don't know how many of you are as old as or older than me. I hope I would have company. But there were days when my parents will go to the grocery market to buy the monthly grocery and stock it at home. Nobody does it anymore. At least no younger generation guy is doing that anymore because it's instant. You do it 16 minutes, things come to your house and people have stopped storing. So the world is changing towards consumption as and when I need it. And we are talking about a concept to a predominantly young population, healthy population, about something you do right now so that your future 5 year, 10 year down the line will be better. So conceptually it is not connecting with them. So health insurance has to take a different context altogether for this generation. Then comes the question of awareness. We are not one country, we are many countries in one country. So there is, you call it Bharat, you call it India, you call it rural, semi-urban, mofussil, cities, metropolitan, etc. Disease patterns also are diverse across the geography of this country. So when we talk to go little down further to tier 3, tier 4, locations, simply the awareness of health insurance doesn't exist. And to top it up, health insurance, fortunately, unfortunately, is a conjoined twin with healthcare. Now, if you do not have, if your predominant healthcare need fulfillment is through the government setup in rural areas, which is PHCs, CHCs, and district headquarter hospitals and teaching hospitals, why would you need, and if you don't have enough number of private healthcare available,
then
how would you consume a health insurance policy you will have? So there is awareness. And finally, India is at a stage in health insurance which is still not a product differentiation stage. True real product differentiation doesn't exist so much. It is at a distribution differentiation stage, and then it will be followed by product. Lot of distribution does not reach the entire length and breadth of country. One may argue banks, NBFCs, etc., but that's grossly inadequate. They are designed primarily not for insurance, but designed for banking, and that pressure remains always higher on them than to promote health insurance there. So this big link between availability of product, availability of places to consume the product, and availability of either some form of technology or a human being to purchase it from. These three are large challenges. On top of it, the overarching thing is the very low awareness that exists.
All right, so health insurance is very much a push product. Post-COVID, things changed a bit, but still very much a push product is what you're talking about.
So I will divide it into pre-COVID, COVID, and post-COVID. COVID did help. And that purchase, and I continued saying wherever I met and discussed, was that it is not awareness that COVID is building, it is panic and fear that it's building. Of that community, some of them will turn out to be more insurance or risk aware, right? But COVID essentially made people panic buy health insurance, and during that time, funnily, all the insurers also offered COVID product, Corona Kavach and Rakshak policies, and a lot of uptake on that one. That's panic and fear based buying. So post-COVID, many of them didn't renew. Ideally, what you'd expect is somebody going through a basic COVID protection product, becoming aware, would have moved to a more comprehensive product, whereas a lot of them did not. And God forbid, what happens is, pandemics, one thing we forget about pandemics is that the frequency is much more than the Spanish flu we talk about in 1914. It's much more frequent. Last 2.5, 3 decades, we had 3 pandemics. COVID was much bigger in scale, so we know about it. But there was, MERS and SARS pandemics that also did happen. And that could potentially continue. So again, there could come a wave when there is panic buying. So this entire thing about being ready for future as a concept has not been well understood or well sold or well made aware of to people. Again, in a country which is predominantly very young, 45-year-olds, you talk to them, they will say that yes, of course, health insurance, and the penetration will be much higher. The overall pan-country level penetration looks also lower because it's the 25 to a 35 who do not come forward to buy. Again, I will buy it when I need it. As long as I'm healthy, I don't need it.
Right, correct. So Mayank, you have founded a digital distribution firm. So according to you, the problems that Dr. Bhabatosh talked about, so what have you observed in your journey?
No, I agree with most part that Dr. Mishra outlined. And I think we talk about InsureTech. I represent an InsureTech in India. And InsureTech as a segment is growing very fast, not just in India, but globally. And I think gone are the days when InsureTech just meant, putting all the insurance plans on a platform, aggregating them and presenting to an end customer. Today, InsureTechs are changing every aspect of the insurance sales and claims process. Starting from product creation, underwriting, sales journey, servicing, claims, analytics. InsureTechs are, adding value everywhere. In fact, purely from a distribution perspective, the world is attaching insurance everywhere. Be it travel, taking loan, investment, banking, even if you are hospitalized or checking out of the hospital. So insurance is being sold everywhere. But, I agree that the biggest problem is not really use of technology and to what extent technology can help in increasing penetration. I think the biggest issue to tackle is awareness. And, echoing the sentiments that Dr. Bhabatosh, mentioned, I believe that there is a general level of non-acceptance in people about insurance. They feel like, mujhe nahi hoga, I will not be impacted by, something. And, if you press them further, they will say, dekh lenge. If it happens, I'll figure out. And that's the mentality that we need to move away from. Our insurance density is also very low. We have a average density of $80 to $90, which means that what is the amount of premium that people pay as compared to, similar countries, developing countries. I'll not compare with the US, but in developing countries, it's about $500 to $600. So even if we have taken insurance, it is low. Like most of us have insurance from our corporate, employers, and it would be 3 lakh, 5 lakh, 7 lakh rupees worth of cover. But if you are in a situation where you have to spend a lot of days in the hospital, or if you have a critical illness, that cover will fall short, and then you resort to dipping into your savings or reaching out to your friends, and therefore awareness is a problem. One. Other is that I feel when we think about insurance and we talk to any lay person, the first thought that comes into mind is that complicated long-term health insurance product. But there are innovations that have been done by the health insurance industry, thanks to leading insurers that we have in the forum today. We have plans like HospiCash. We have plans like OPD cover. We have plans like top-up insurance, super top-up insurance. And I believe that if we make enough education and awareness about these kind of plans, then there will be more acceptance amongst different sets of people about buying such plans. And that is where technology can help in making the entire experience seamless. And I think that should be the point on which both the public and private sector should come together and co-execute.
So technology can help in distribution, but how will it help in awareness? And at your company, what are you doing to spread that awareness?
Sure. So technology can definitely help in awareness as well. Today, most of the education awareness happens through social media and likewise.
But then we also have Bharat and India. And I see a lot of awareness now, at least in metro cities and among people that I talk to. But when we go to far off places, then it's really sorry state of affairs. So.
Yeah, you'll be surprised to know that number of people on Facebook and YouTube from rural India is more than the number of people on these portals from urban India.
But are they consuming this content?
Yeah, I think it's about time that we stop thinking about rural India as away from technology. I think the smartphone and internet penetration has gone beyond those boundaries. And today, if you go to any village, you will find internet connectivity, smartphone connectivity, and you will find many people carrying smartphones with them. In fact, we have a lot of regional level social media networks and OTT platforms today mushrooming because of the acceptance and adoption of internet and technology in rural areas. But again, I would like to take a divergent view here. When we talk about insurance penetration being low, it is not just the rural India, but also the urban segments that need attention. For example, if you look at college-going kids, or if you look at people who are in early few years of their career, how much insurance do they have? If we look at people who are laborers, blue-collar workers, how much insurance do they have? If we look at drivers who drive, or the gig economy workers, are they insured? So those are the areas where technology can play a significant role because they're anyway connected to a device or a set of devices. And if we can do any campaign, like if you think about the AMFI's campaign of mutual funds Sahi Hai, it was largely delivered via television and social media, and there was a lot of buzz about the campaign, and as a result, the SIP adoption and SIP infusion in the country has seen never before growth in the last 5 years. Lifebuoy, many years back they came with an ad of washing hands with a liquid soap,
Right.
and because physical soap is unhygienic. It took them 4 to 5 years of sustained effort to make it a habit of people to buy a liquid soap rather than a physical soap, like a solid soap. I think a sustained effort is required. Technology can help aid the distribution of the education, but I think it is for the public and private sector to come together to increase the awareness. Only then the goals of improving our penetration, improving our density, improving our coverage will see the light of the day. Technology alone can enable, it can bring efficiency, it can take us to a certain level, but technology alone cannot, as a standalone, cannot really do the magic. Probably you find it strange coming from an InsureTech, company, but in the spirit of how our country should grow, I think that's the hard truth that I want to communicate.
All right. So now coming to Rishi, so you are Chief Distribution Officer at Canada HSBC Life Insurance. So life insurance companies in general have had better insurance penetration compared to health insurance companies. So what is working out well for life insurance companies and something that health insurance can duplicate maybe? Your suggestions for health insurance?
Thanks, Prajita. So I think for life insurance companies and health insurance companies, I think as Dr. Bhabatosh mentioned, there is obviously a component of savings and protection that is there in every life insurance product. So there is, a bit of a difference there. But yes, there are some common themes which can be, leveraged.
From distribution
From a
side.
distribution perspective, I think it's important to consider how distribution goes to the last mile. So that is, an area which in India at least we have seen a lot of success with the PMJJBY schemes, where banks have been actually able to kind of go and penetrate to the last mile. I think from 2019 onwards and even earlier, last 5 to 6 years, the insurance penetration has increased a lot. Simply because of the fact that we have had a simple standardized product which has been, kind of cascaded in a straightforward manner by, across all banks in the country. So I think it is possible to find and leverage upon last mile distribution, particularly in the context of increasing penetration. So that is definitely one area where we can, look at leveraging some of the insights from life insurance. The other area in distribution at the end of the day does depend upon the product that you are selling. And I think one thing that life insurers have been doing, is that thinking more about longer term, coverage and, having coverage which actually extends for a longer period. And that is something which, again, is health is already kind of taking some steps around that. So that is another area of where more things can be explored. And finally, I think it is important to note that increasingly everything is going digital. Digital infrastructure, digital penetration is moving far faster than physical penetration, and therefore a combination of physical and digital infrastructure leveraging in what is already existing is in my mind the better bet to try and penetrate further than purely leveraging on existing physical infrastructure. And I think what my panelist said here, that that there is opportunity for us to leverage on digital awareness creation, and then also a combination of digital and physical distribution that can actually help us gain faster penetration into the population at large. So I think all of these things, not one thing will not contribute, but I think all of them taken together is what will kind of help us in increasing distribution and penetration to the last mile. And I think these are some of the I wouldn't say lessons, but some of the the insights that have been gained from the life industry over a period of time, and I'm sure they will need some tweaking. Everything is not directly attributable, but with some tweaks, the same paths can be
Model can.
followed by health insurance in the country.
All right. Now, coming to Shilpa, so you have founded Insurance Samadhan, company that helps in claims resolution. So awareness is one side of it, that why health insurance penetration is low. But another side of it is also that mistrust. People don't trust insurance companies. They have this perception that they will reject claims. And when the moment of truth comes, nothing comes out. Nobody helps them. And you have addressed a lot of complaints and you have helped a lot of people. So what are your observations? You think that this mistrust towards insurance companies is also a major reason why penetration is low?
Thank you, Aparajita and Mint. So I will not say it's a major reason for insurance low penetration. Here we need to understand, as Rishi said, that we need to leverage both digital as well as physical connects. I was in sales earlier, so I know that insurance is never bought, it is sold. That is what we were taught, that you have to talk it out, you have to explain the benefits of the product and then the person buy. So what the government is doing through state-run and central-run products, that is a very good initiative. I'm very excited with the IRDA launch of Bima Vahak and activation of the bank, because now everybody has a bank account and we trust our bankers. So banking will be a good channel where the sales can happen. And also this Bima Vahak, which I read is a female oriented, where these female in the rural area will go and talk about the products to the people and convince them to buy. So that is also important. Coming back to mistrust, yes, the real truth is claim. While most of us are focusing on the sales and the penetration, we also need to look at what the customer is experiencing with the product at the time of claim. For example, we get a lot of claim rejection because of non-disclosure of PD or non-disclosure of material fact in life. So this is something which I feel even the seller is not much trained or aware. If I talk about health insurance, there is a confusion with the 4-year waiting period, even in the seller mind as well, where they feel that, okay, 4 years is the period that needs to be disclosed. If it is a 10-year-old surgery or an illness, they don't disclose it. So whereas the insurance company wants the complete disclosure, then it is on the underwriter to decide whether they want to put an exclusion or a waiting period, whatever is their decision. So I think there is a requirement to train the field staff regularly on the product, on the reason why the claim can get rejected. In life, I see a lot of rejection happening because people have not disclosed their earlier policies. Now, this is something which was surprising to me. I came from life background, and when these rejection came to me, I thought, is it so relevant? I was on the sales side. But then I realized, yes, this is important for the insurer. But as an advisor, we never asked. We never made that entry into the proposal form. We just got the signature done. So that is the Indian tendency, that we don't fill the proposal form on our own and we depend on the advisor. We just get the sign and we just get the check, and that's how the sales process is happening in India. The training is happening as, you need to quickly get the proposal form signed and the check and come back, So nobody is focusing on the claim side. In the hospitals, we get a lot of complaints that, there is an urgent surgery. Now, I have bought a product, health insurance, for my financial security. Now, a patient of stroke is there who needs immediate attention. And now we are waiting for the authorization. The hospital will not start the surgery unless the authorization comes. And maybe I don't have that amount of money to immediately deposit and start the surgery, because a neurosurgery will cost 4 to 5 lakh anywhere in the metro city. How will a person have immediate access to that amount and, that surgery? So somewhere the insurance company also has to see there are urgent requirement of the customer which needs to be addressed. At the time of discharge, there is a struggle that, final authorization is taking about 6-7 hours and this patient is into problem, maybe goes to the next day as well in certain areas. So we need to improve the claim experience for which the insurance product is bought. If we are able to deliver that, obviously in marketing, earlier we used to say that, one will refer to many. Now it is a digital world where the reviews will matter, the rating will matter, and they are seeing that. So I think if we are working towards the claim size and improving the experience of the policy holder, then obviously the penetration, at least in the metro, will increase. Somewhere you need to work both physically and digitally. Somewhere the educated class, the younger generation will understand and will buy the product.
Right, and sadly, on the claim side, we don't see a lot of InsureTechs coming in. They all are into distribution and not so many in the claim side of it. So that is something that in the audience, I would like to highlight that we need more InsureTechs on the claim side and not so many in the distribution side. And now, Dr. Bhabatosh, coming to you about increase in health insurance premium. It's a major problem post-COVID. We have seen that a lot of insurance products have had price hike of 30-35% also. So your take on it. And price point is really important, and it's a major hindrance in insurance penetration. So how to make products more affordable?
It's a big problem. I agree with that. Let me start with that. Affordability is a hugely important subject in country, irrespective of which segment we are talking about. And any substantial premium increase of the kind that you are saying in any product is a big impediment in growth and penetration of health insurance as such. But it's a complex problem at the same time. It's the average increase across the industry is not 30-35%. It might be some products, some may not have changed price, and it's a mixed bag, I would say. But wherever it has happened, we need to understand this in a little detail. We are talking about healthcare and health insurance, and I see it's a mixed participating population. In healthcare, as I said, we are a conjoined twin. We are inseparable from healthcare. But unfortunately, we are talking about apple and oranges despite being joined together. Health insurance and insurance in general, heavily regulated subject. You can't change premium at your whims and fancies, a minimum 1 year, then sometimes regulatory questions, etc. Healthcare, I can change price at my will. Some of the hospitals change their prices twice a year. Some have gone to the level of changing it thrice a year. No regulation. So one, regulated industry versus unregulated industry. Secondly, tell me how many big hospitals are a part of CGHS today, comprehensively part of government sponsored schemes? I don't see them in the list of PMJ. If at all there is a big hospital, one department which possibly does not have too many beds or general ward only is a part of it. But comprehensively, all big groups are out of this. Healthcare in India is a subsidy-based subject. As they say, single room subsidizes for twin sharing subsidizes for the general ward. Otherwise, why would the same doctor's consultation cost 1800 rupees in a single room and possibly 600 rupees in a general ward? Same X-ray done in a general ward will cost you 180 rupees, will cost you $1,000 when it is done in a single room patient. It's a subsidy built. Similarly, the same subsidy is a problem for health insurance. Whichever hospital is treating, let's say, part of government business which is forced upon them, or doing bit of CGHS, or doing more of other subsidy cases, that burden is passed across to private health insurance, including cash-paying consumers today in many hospitals enjoy better rates than health insurers do, because there is also this concept of abuse and overtreatment. That's when a consumer doesn't have to discuss, argue and negotiate about the cost, then the giver has ability to manage cost on their own. And that's a big problem. The reality is with many hospitals, that's a big problem. If you look at average claim size in reimbursement compared to cashless, there is a huge difference. Average case claim size for the same severity, same condition in the same hospital, in the same room class, a cash paying patient versus an insured patient, there is a huge difference. But we enjoy better tariff than cash paying patient. It's the overusage of services. I heard robotic surgeries, for example, great thing, but who knows? There is no HTA equivalent done, no health technology assessment, no health economic evaluation. You start doing simple procedures like mymectomy, fibroid removal with robot, because there is little blood loss with that one. I mean, we should put it in context. Economically, if it is going to cost you 3 times, and the blood loss in a lab is, let's say, randomly speaking, 60 ml and reduces to 30 ml with a 20 ml with a robot, what incremental benefit to the patient? And I don't see early ambulation reality becoming a reality. Including robots being used on knees, Robots are used on knees only to make a cut. The implant is nothing that robot manages. So point is the healthcare inflation has gone so much that talking about this price increase in isolation of the loss ratios experience of health insurers and their products will be incomplete. Has the claim ratio of those products become way better after price increase? Or before a price increase, were they still very profitable and still insurers increase the price? That's a question to ask. The answer is no, because we are a very heavily regulated industry. And the reality is, the price you pay for health insurance is driven 65-70% by the cost, which is just simply the claim healthcare cost. If I have exceptionally high medical inflationary trend in the country, which we have seen, never seen before in the last 3 years, you expect that to have rub-off effect on claim ratios, which will translate into a price to the consumer, unfortunately. We don't talk about during COVID, health insurers in India paid more than 20,000 crore worth of claims. You show me which country it was not a sovereign risk, in which country this burden was borne by insurers. We do speak about problems at claims, and I'm not denying there are problems, there are a lot of things to be done. But you tell me in which part of the globe, if you are aware of, that insurers, private insurers, bore the burden, larger burden of the cost of COVID. And yet, we do not believe in health insurance. Yet we think the prices are going up. Yet we believe this concept works or not and questions. We need to have some mechanism to bring in affordable health care. You tell me how many of the big hospitals in Delhi NCR you can walk in and get a cardiac surgery or even a dengue treatment done, paying out of pocket without really worrying about it, including people in this room. At least for myself, I'm poorer, so I can't. Maybe some of you can, but that's the reality. And in that reality, we exist, and private insurers have to bear the cost of burden of healthcare at some level, because unfortunately, government from a healthcare provision side has moved to a role which is not provision, but becoming a health insurance buyer. Today, the biggest health insurance buyer in India is the governments, state governments and the central government through PMJ scheme and state schemes. Whereas primary role of government used to be building primary health centers, CHCs, district health hospitals, tertiary care, medical college hospitals, etc., which is currently being done by private. And cost of healthcare is prohibitively going up. It's already at a tipping point. Unfortunately, unless you rein in some cost there by putting protocols.
So the way we have GIPSA for public insurers, so something together, if private insurance can come together and have common standardized price points of surgeries. So do you get into this discussion with hospitals?
Yes, we are in continuous consultation discussions with hospitals. Anything of that nature has to be mutually agreed upon by both the payers and the providers. So those discussions are on, but that alone is not going to solve. See, unfortunately, we get a lot of cases where the platelet count is 90,000, 1 lakh, and the patient is to be admitted, right? Patients do not understand there is massive information asymmetry in medicine. Your treating doctor has so much of information that even if told, you will not be able to understand, so you have to trust your doctor. But how do you know? One doctor says your platelet is 1 lakh now, you get admitted. The other said that you can wait till 50,000. The other says 120 is where you get admitted. How do you know? Theoretically, not theoretically, practically, you don't need an admission even with a 10,000 or 20,000 platelet count. That's one of the indicators only. And there are protocols that exist. WHO has guidelines, Government of India has guidelines. Why can't we have one single protocol for the whole country's healthcare to operate on, at least for the common conditions? That way, even patients will be aware, will not panic. I'll tell you the small anecdote. A few years back, a family, a husband and wife in Delhi NCR jumped to death from their 4th floor house. Because whole day they ran from hospital to hospital taking their 8 or 10-year-old kid who was with severe dengue hemorrhagic fever, didn't simply manage to get a bed because beds were filled by people who could have been treated at home. So there is a social impact, emotional impact also. Make it clear to people. Avoidable things should be treated at home. It's not good for us. And honestly speaking, health insurers are the only ones who are sitting there praying that, God, please, whatever disease comes, let my customers not get affected. Let them not need any treatment. Let them be healthy always. So we are the ones wanting people to be healthy always, right? So some level of protocols to be driven will be together with price standardization is important, and not just price standardization, price predictability. You're charging ₹1,00,000 for a treatment today. Give us some indication of inflation that we should expect next year. It cannot jump to a 1,20,000 for whatever reasons. We don't price products to remain the premium to stay stable perpetually. We have to react to what is changing in healthcare costs.
Right. Okay, so coming to distribution side of it and commission that goes to agents, maybe tweaking there, can products be made more affordable? Or your take on affordability? How do you think products can be made more affordable?
Sure. So there's a ray of hope, Dr. Mishra, in what you expressed. I think technology helps in reducing the cost significantly on many fronts. First of all, specifically in the model in which we operate, we partner with large B2C companies who already have a very large captive audience. So imagine a bank, an NBFC, a microfinance company, a travel portal, a retail chain, a housing finance company who already have probably millions of captive audience. So when an insurance company tries to offer their product through these distribution ecosystems, their cost of customer acquisition reduces. Okay. Because you already have a captive audience to whom you can advertise and you can get the interest. So your cost of marketing reduces. Secondly, the number of people you have to deploy per acquisition is also lower when you use technology. Because, as Shilpa mentioned, that you have to fill a proposal form and it's a long form. By use of technology, you can reduce the number of fields that you need to fill, and therefore your sales process becomes less complicated, so your cost of distribution also reduces. And thirdly, if you are able to integrate technology into your core operations, like policy issuance and servicing endorsement, your cost of operations also reduces. So these are the three fronts on which technology can help insurers in reducing their non-claim cost. Also, another advantage is that in a lot of insurance companies' cases, they have to do the same tech integrations over and over again with every partner that they onboard. So if you have 100 agents, you will do the same integration with 100 agents. But when you work with an InsureTech partner and you create a single API to integrate with all the agents, then the same API can be used multiple times over, also saving you a lot of technology cost because you are not investing in manpower for doing the same integrations again and again. So these are 3 or 4 areas where technology can help insurers in generally reducing their non-claim cost. From the point of view of customer, how do we bring in affordability? I think first is the capability to create sachet products. Because the operating cost is low, you can afford to sell, and as an insurer, you can afford to sell a lower ticket size product, which you cannot if you are operating in a fully offline model. In a fully offline model, if you sell a premium of, let's say, less than 10,000 rupees per annum, it may not be even profitable on a unit economics basis. But if you are using technology to embed your insurance product with a home loan or with a travel ticket, then you can even sell a product at as low as 100 rupee premium because there is no variable cost of sales there. That is why when you use technology, you can create affordable sachet-sized products for which the acceptance of the customer will be really high. The friction or the resistance to purchase will be very low. And therefore, you are bringing more people into the fold of insurance who were otherwise not willing to pay premium to buy insurance. I'll give you an example, more of an urban example. I can give you like 2 or 3 examples how technology has solved a certain problem of affordability. So during COVID, we all saw the kind of terror it spread, and there were a certain management institute who was particularly concerned about their alum base. They have few thousand alumni, and a lot of alumni had faced COVID, and due to that, they had to do crowdsourcing of money to pay for their hospital bills. And the alumni committee wanted to create some kind of proposition which can prevent any such scenario in the future if any situation arises. So we worked out a super top-up health insurance plan for the entire alum base of that management institution, wherein we knew that most of the alumni are working professionals and they have a 5 to 10 lakh rupee health insurance which is given by their employer. But what if they have an expense which is exceeding 10 lakh rupee? Now, one option is that all alumni are encouraged to purchase a 20, 30, 40 lakh rupees sum assured base plan. But the cost of that may be a deterrent for everybody to enroll for that. Therefore, the thought that we arrived at was, why don't we offer a super top-up plan so that the initial expense of 5, 10, 15 lakh can be borne by the employer's insurance or by own funds, but anything exceeding 10 lakh, 15 lakh rupee as a deductible could be funded by the super top-up health insurance plan. We launched this plan fully using technology. We integrated with the alumni platform. And with zero cost of distribution, we were able to enroll approximately 50% of the entire alum base in this program. And by seeing the success of one of such program, multiple institutions have come forward, and today we work with almost 12 management and technology universities in the country to offer a super top-up health insurance for their alumni base. And this plan is coming at a relatively lower cost because there is no cost of distribution, marketing. The operating cost is low because we have done API integrations, and that's why it is finding a lot of adoption amongst the customers, as well as a win-win scenario for the insurer because they are finding another channel to sell their insurance product at a much lower cost of acquisition and high profitability potentially.
Right. Now, Rishi, life insurance companies also sell fixed benefit health plans. And IRDA has been talking about composite insurance licenses. And in the past, life insurance companies used to sell even indemnity plans also. So your take on it, should life insurance companies be allowed to sell health as well? Will it help in better distribution, better penetration?
Yeah, I think globally, if you look at it, life and health is essentially one business line. I think if you look at the entire industry, of course there are a number of life insurance companies and there is a equally large number of non-life companies and now standalone health insurance companies as well. So I think there is definitely if you go by the global example, there is opportunity for everybody to offer all kinds of insurance, and I think it's not just for life to offer health plans, but also for health to offer some added life covers as well. So I think there is an overall optimization which can happen in this manner. So I am in favor of all kinds of plans to be offered by the same.
But it was already there and then it was rolled back. So why did it happen?
So I think at some point of time only fixed benefit was working. But if you look at where the insurance maturity for the Indian populace is right now, I would say like 99% or 95% plus of health insurance is actually pure indemnity, because people want a reimbursement for the expenses that they have incurred, right? And a fixed benefit plan is typically an add-on or a critical cover plan,
right? As a rider,
that is typically what you add on to it. So therefore, simply saying fixed benefit won't always help in that situation. It is more important to first address the core health insurance from a consumer's mindset. What does the consumer think when he says health insurance? That I'm getting hospitalized, I'm getting impacted as a result of cost which I'm incurring. At least from a financial perspective, I should get covered. So at a very basic level, that's the expectation. So therefore, I think it's important that the core benefit of health insurance, which itself is not yet fully penetrated, is something which all should be allowed to kind of offer. So that's why it's important that we talk about health insurance in its full gamut. So that's why it's critical for all companies to be able to offer it. Yes, life insurance companies have over a number of decades now built more extensive distribution. So I think that is definitely an area where they can leverage to offer more solutions to the consuming public. So I think that's the reason why I think it's a good idea to kind of look at all insurers to offer, and then over a period of time I also think that would lead to optimization, because there are many companies in the industry which have or many groups which have both life, non-life health available, and then there is definitely opportunity to integrate and therefore be more efficient, and then if there is more efficiency in the system, eventually those cost savings will get passed on to consumers. So I think in the longer run it will also be beneficial to consumers. You'll have higher competition and you will have optimization in terms of costs that are being saved across the industry.
Okay, so any update what is happening on composite license front or?
No, I think that's something for the government to decide and how that's going to kind of get taken forward. I think various draft resolutions and various draft regulations have been put forward by the industry, and I think now depending upon the regulators' final view and how the revision to the act kind of proceeds, that I think we are all hoping for the fact that over a period of time it will kind of pan out, and then this can become a reality.
And insurance regulator has also been talking about state level insurance. So tell the audience more about it. What is state level insurance and how will it help in health insurance segment or in general insurance industry?
Yeah, thank you for that. I think the IRDA has definitely, kind of come out with this scheme where they would like to look at state level, penetration of insurance. And therefore, what it has done is to create increased focus while most insurance companies are present across all states, just to make sure that certain insurers have a particular ownership, have a particular, higher engagement with the state machinery. They have identified lead insurers. So the regulator has identified lead insurers in each state, life and non-life. In many cases, more than 2 as well have been identified. And then in each of these states, awareness creation, engaging with the last mile, trying to find out more avenues for promoting, life insurance, health insurance, non-life insurance is the objective of this. The other thing which I strongly believe in is that whatever gets measured, kind of gets done. So by having these state level insurance plans, the regulator is also keeping a quick eye on, what is the level of effort that is going in, and, what is the level of engagement that various insurers are having with various government machinery as well. Okay. So this is a new initiative, I think.
It is already on. And
it's already on. I think all insurers, including ours, are currently working on state level insurance plans. There are, I think most insurers have now moved on from pure awareness creation initiatives at the last mile, which included, various activities, marketing activities, awareness creation activities which were happening at the last mile, to actually now looking at last mile distribution. How are we actually going to, onboard more lives in insurance in the particular state? And I think those steps are now already taking shape. I would think that over the next 1 or 2 years, some of these will actually lead to much higher penetration in states. And in particular, it gives a platform for the government infrastructure which is present on a state and a district level to engage closely with insurers and therefore be able to drive, joint programs, joint schemes. Right. And that would be really helpful in meeting the overall objective of penetration to all, which is the ideal objective of insurance for all in 2047.
All right. And Shilpa, now that you understand pulse of people, so talking more about product innovation or process innovation, that you think what sort of product should be designed, or your suggestions for insurance industry, that how to make product more feasible to understand, because health insurance is very complex. So what to do to simplify it?
So I think IRDA has already taken an initiative of simplifying the product. So we need to talk about benefits in the policy rather than the technical jargons like a copay or sublimit, which a common person will not understand. So that initiative IRDA has already taken. I think health insurers are working on that front. Talking about innovation, or when we are talking to doctors, so as a policy holder, I'm also, because I'm on the policy holder side, we are talking to doctors in hospitals. We also feel there is a problem with the acceptance of modern therapy, as Dr. Bapatosh said, that robotic surgeries or targeted therapies, which are now technological advancement, which policy holder wants to avail, but there are problems. There are claim rejection in cancer. There are claim rejection in intravitreal usage, the retina treatment. So as a policy holder, if I am buying a policy for 30 lakhs coverage, I would like to have those benefits as well of the modern technologies usage. If the doctor thinks that they can prolong my life by 6 months or a year, I would want to go for a targeted therapy since I have the cover. So if we cannot include them, then maybe a rider explaining the customer that a little more you have to pay and this will cover it all can be taken up, because there are certain critical illness like cancer or where actually, like my mother is having glioblastoma, and so I will do everything. I have gone for CyberKnife, whereas my hospital told me that it may get rejected. I said never mind, I want to prolong my mother's life. So it is important for the insurance company also to understand that if there are technological advancement that needs to be included, you ask for the premium, you can add the riders and remove that sublimit on the products, because these treatments are really, really expensive, especially the critical illness part. So,
yeah.
And
just for public's information and attendees' information, in cancer, including intravitreal injections, is mandatorily covered by regulation in India. What regulator allows is to put limits, but it is mandatory cover, including oral.
Sublimits like 20%, 30%. So a cyber knife costing about 5 lakhs means insurer will pay about 1 lakh rupees, and 4 lakh falls on the customer, policy holder side. So that will be
that is a true challenge, and that is why it is very important. See, insurance in India is uninvolved buying. People do not research, people do not spend time in buying. You spend much more time researching which camera, what megapixel front, how many back cameras, etc. on your 20,000 rupees mobile phone. Insurance is a less involved buying. People do not read. And there are policies, including lot that we sell today, which are written in plain colloquial English, no jargons. Large part of the document anyway is regulated, you can't change. But as far as possible, we have simplified policy what is. Get involved, and that is what I was talking about, awareness. Awareness is not just about I need health insurance. It's about how much I need. It's about what is the right product for me. What are the provisions of this? Are there promotive features of wellness? What does it cover, what does it not cover, etc. So yes, somebody looking for, and this benefit and price are definitively linked. So you have to take a calculated, optimized decision, what is the best suited product at which price point of affordability for you. Each has to make that decision. If I want to suit only a price point, then inherently I'll have limits in a product. There are products available with, there are no limits on modern treatments, no limits on anything, no capping on room, you go to a suit also available. But then these cost much higher, and only a very select few buy those, a small percentage. So yes, today the number of health insurance products exceeds 500 products available in the market. So pretty much everything that you want, starting from OPD to maternity to all open, everything is available. But then again, it's linked to a premium, right? So get involved in the buying process. And it's not very difficult. It's fairly easy, get a little more involved. Small banking transaction, we get more involvement than health insurance, where we are talking about an emotive issue as well. Health is not just a financial issue or a medical issue, it's also an emotive issue, right? That is why you hear, despite paying 90+% of the claims, possibly noise is 9 times more for the claims not paid than the noise, good noise for the 90 claims paid. So get involved a little bit, that's very important.
So any closing comments from your end for the audience here, because the idea behind such summits is to have more discussion among all stakeholders. So any closing comments for people, a message, support that you need? Dr. Babatosh, you can go ahead with closing comment, then I can move to him and one by one.
Sure, thank you. My closing comments I think I have already made. One is there are all variety of products available at different price points. Get involved with the buying process, that is one. Secondly, health insurance works. It's the most potent health risk, at least the financial risk mitigation tool available anywhere in the world. So believe in it. Third is, somewhere I need support from everybody around here and people, not just from Mint, but the fraternity, is that we fail to showcase the positive stories, where millions of lives have been able to be saved because somebody came to finance that high cost treatment he or she or that family could not have afforded, or could have afforded with a lot of difficulty, pushing them financially backward. If 52 crore population people in this country are insured, even with a modest 6 to 10% frequency, we are talking about millions of households saved, creating access for healthcare. And last but not the least, please recognize this problem, that we are joined with healthcare. Healthcare inflation is a reality. Information asymmetry does not make us understand robotic in this case is right for me or not. Does it really prolong my life? What benefit it gives? Make it transparent. Make healthcare itself a transparent process first, because that's the most complex thing that I have known so far. Coming from the other side table to this side of the table, I've been there on the healthcare side. And I'm here on the financing side, so I can tell you it's a very complex subject. Make it as transparent and clear to consumers as you can.
Right. Mayank?
I think I have voiced my opinion very loudly in the first 5 minutes. I think I'm a very big believer that we have to increase awareness at all levels in the country about health insurance. And if all of us can take a pledge that, in the next 1 year, we will convince at least 5 people to buy health insurance who have not bought health insurance in the past, I think that could be, one momentum we can build as healthcare professionals, insurance professionals. And if this can, WhatsApp, maybe we have seen forward, send it to 10 people, otherwise bad luck will hit you. So if you say, okay, have 5 people buy health insurance in the next 1 year, I think our health insurance penetration issue or the coverage issue will automatically get sorted. It needs to be done at a mission level, and I'm sure that all of us are trying to do our level best at our respective levels. So yeah, that's my closing remarks. Thank you.
Thank you. Rishi, in your closing comments, I want you to touch upon the point we discussed before on the sidelines about data. So just touch upon this aspect and then your closing comments for the audience.
Yeah, I think you're right that, we talked about data and, about how we frame some of these, challenges. I think that...
Yeah, I started off with saying 4.2% insurance penetration.
Correct.
So,
yeah.
about
so I think
this
it's an important thing to note. We've been talking about 4.2% penetration, and when we talk about penetration, most people perceive and they frame it in their mind as that, out of 100 people, 4.2 people are covered. But that's what, me and Dr. Babatosh just talked about before this session, that actually we need to look at lives covered as a proportion of the total population of the country. So while that is a good start to, kind of talk about from health insurance penetration, but yes, it is also important, and that's true for life as well as for health, that the level of cover and the level of understanding which we talked about is still abysmally low. So, penetration is not only about penetration in terms of numbers, but it is penetration in terms of understanding, in terms of appreciating that what is the value that insurance brings to the table. So I think that is the real penetration which we have to focus on. So the takeaways from my side would be that awareness and distribution is the key. So as they say in Hindi, tali do haath se bajti hai. So it's like, you need 2 hands to clap. So while it is important to create consumer awareness, it's important for consumers to be more aware, read, understand the nuances. At the same point, there is a very significant responsibility on all of us as insurers, to be able to kind of explain it in a very simple manner, to be able to, manage our distribution, in the way that they can explain it, to be able to train people that they can actually explain what is covered, what is not covered, to be able to go to the last mile. And when we come to distribution, to be able to leverage on people who are already there, who are already, serving the last mile of people. And, that's where I think both awareness and distribution go hand in hand. And finally, I think the government is taking a lot of important steps. I think many of these initiatives deserve far wider coverage and awareness than, what we have been able to kind of see. And I think that the more of that awareness happens about government schemes, about the fact that, there are opportunities at the state level, to kind of have more insurance, and then those will actually help in increasing the penetration. So that should, help overall.
Thank you. Yeah, Shilpa.
So as everyone said, I strongly feel that financial literacy for the customer is important. Get more involved when you are buying an insurance policy, that is right. But also I would ask the industry to train the sales people as well, because selecting a product is a complicated thing. How do I know whether, what kind of treatment going forward will be required or not? So that sales decision taking steps needs to be there. Say for example, again, modern therapy, I am not aware that in the future, when I go to the hospital, then I hear all these modern therapies. But otherwise, I am not aware as a policy holder that I may be required to use this kind of a product. And also, I will request the hospitals as well to collaborate and understand that for a policy holder, it is important that you also be very transparent in terms of treatment and the cost that you are charging from the product, because obviously this is my coverage for some time, and and there may be a rejection or there may be a deduction. So have that consideration of not charging too much, so as a policyholder, I have experienced that also in the hospitals, that suddenly a lot of tests has been, you have to undergo a lot of tests because it's covered in the policy, then we can't even object to that. Though we do question, as an aware person, I do question why these tests, but yes, there is a problem which is resulting into issues with the policyholder. It's between insurer and the hospital actually to settle all these things so that the policyholder is comfortable and is able to take the treatment for which he has come. And to the insurer, I will also request for at least emergency services. Approval needs to be faster, because hospital does not start the treatment unless you pay the amount to the hospital. No surgery begins unless policyholder pays. So that also you both have to look so that the policyholder is comfortable in the future.
Yeah, Mayank, you have to say.
Yeah, I think this panel is on talking about how to insure the uninsured, and it will be incomplete without acknowledging and applauding the efforts of the regulator in this regard. Of late, there has been a talk about Bima Trinity being launched by the regulator, which consists of Bima Vahak, Bima Vistar, and Bima Sugam. And I think it's a very, very powerful and ambitious step in the right direction. Because if this initiative becomes successful, which it will, with all the might of the regulator and the insurance companies who are involved, this will accelerate the adoption of insurance, at least in the rural areas. And I'm personally, closely watching how the story unfolds with these three initiatives. So I just wanted to bring that to the fore.
Yeah, thank you so much for highlighting that. Yeah, Bima Sugam, Bima Vahak, and Bima Vistar, and then state level insurance. These are really interesting initiatives going on, and we should keep a watch at it.
Absolutely.
Do we have time to take questions from audience? Do we have time to take questions? Yeah, any questions from the audience? Yeah.
Myself, Dr. R.K. Sharma from ESI Corporation. First of all, I must congratulate Dr. Mishra talking about role reversal between corporate hospital and Government of India. Very relevant, you have raised that issue, that health infrastructure is being built by the corporate hospital, and whereas the CHCs and PHCs should have been strengthened. Another is, my point is that what about insurance above 60 years of age? It's very costly. Very few companies are providing, but it's very costly. And one more point about costly dental procedures. Most of the insurance companies don't offer that also. Thank you.
Let me take the dental one first. It's an evolution, so more and more products will come, and I'm sure dental insurance will come someday, sooner than later. That's one. Coming to the former question about 60 plus, that senior segment, premium in general is very high. Today I renewed my father's policy paying 1,87,000 rupees premium per annum, and it's not a small amount. Problem is, when I look at data at an industry level I'm talking about, and including the company I work with, above 60, above 65, the frequency of claim is 20-25%. 1 out of 4, 1 out of 5 people make a claim every year. The average claim size for those claiming in that age group is twice that size of a 40-year-old or a 45 or a 50-year-old claiming. And I go back to the same thing. Health insurance at a very core, if you dissect it, is a very simple concept of pricing. It has only two elements. One is called the frequency. How many people out of 100 will fall sick? The other is called severity. Every time somebody goes and falls sick and gets a treatment, how much on an average it will cost? You take that, and that's the basic building block of the cost of the insurance premium. And then comes your distribution cost, management expense, etc. I wouldn't even add profit because most of the health insurers are not profitable. So that itself is very high for certain cohorts like seniors. So unfortunately, unless, excuse me, you bring in some elements of cost control, that premium will not go down. But I'm not a big fan of putting co-pays, deductibles, room class maybe to some extent okay, but ultimately that cost is borne not at a premium level, but at a treatment level, which is even more difficult. When you are getting a treatment, if I have to bear 20% of cost of a 10 lakh treatment, then it's an even bigger amount. The real solution is, again, is there a way to make the inherent basic building block, which is healthcare cost, if not very affordable, predictable? 70%, 65 to 70% of the health insurance premium that you pay goes towards claims alone. So whatever you do on the remainder 35% or 40% is a very small, minuscule improvement in price that will happen as compared to managing healthcare cost. Healthcare cost can be managed by product restrictions, which I said I'm not a fan of, or by doing something together with provider setup. The way they subsidize a general ward by a single room, can they subsidize for the seniors of this country, which really need it the most when the income is the least? And you and me will be there sooner for me than for you perhaps, but will be there. And it's a big segment of our country. Can you subsidize for sick? So these are conversations that need to happen.
Thank you so much, Dr. Babatosh, Mayank, Shilpa and Rishi.
Madam, just I would like to supplement that there should be some provision, those who have paid income tax for in their life up to 60 years of age. There should be some provision in that also.
Sir, absolutely valid point. Unfortunately, I am not the finance minister. I am the wrong guy. But certainly very valid point. It is given depending on the company. In a network hospital, the definition of hospital is standard for whether it is Ayurveda, homeopathy or for that matter modern stream of medicine or any alternative stream of medicine. But Ayurveda is covered to start with. In those network hospitals of Ayurveda, it is available. Cashless is available. Might be lower in number because the density of such hospitals in India is lower to start with, where they have licensed, etc., etc. But it is available. And this is one area, at least as a company, we are working more and more on to expand the footprint of these network hospitals so that it is available. In some states, the density is more, like you may have heard of Kerala for sure. But if you look at my state, I come from Odisha, the density is very low. Depending on the state and depending on the network, it is available.
Yeah, we can take up questions maybe on the sidelines, otherwise other sessions will get delayed. Thank you so much, everyone. Thank you for being an attentive audience.
Thank you very much to all the panelists for a very informative session. Thank you, Mayank Gupta, Dr. Bhabatosh Mishra, Shilpa Arora, Rishi Mathur, and our moderator, Aprajita Sharma. Thank you very much. Up next is our fireside chat on high-tech with SAIL, the future of healthcare. But before introducing the speakers of the fireside chat, I will take a moment to thank our associate partners, All India Institute of Ayurveda, Yashoda Super Speciality Hospital, Kaushambi, RG Stone Urology and Laparoscopy Hospital, Merrill Life Sciences and Center for Sight. And all you guests who are amongst us today, if you are clicking pictures, making videos, taking out notes, you want to say something on social media, please use hashtag #MintHealthcareSummit and please do tag us on Twitter. Our Twitter handle is LiveMint. I hope you're all having a good time. We are having quite informative sessions. Up next is the fireside chat about high-tech with scale, the future of healthcare. May I please invite the moderator for this session, Gautam Das, editor, Long Story Mint Primer. And we would like to invite our guest on stage, Vishal Bali, Executive Chairman, AH Holdings. Over to you, Gautam.
Thank you. Ladies and gentlemen, good evening. And thank you, Vishal, for making time. Pleasure to be talking to you again. Ladies and gentlemen, Vishal is probably one of the best executives in the industry to talk about healthcare services and, most importantly, funding, right? It all ends with money. And hospitals do need money. And Vishal will talk us through this. But Vishal, before we get into money, could you take us through a short history of healthcare services, particularly post-COVID? What exactly has happened? How has the landscape changed? And what are the lessons we have learned during the pandemic? And, well, are we applying it?
So firstly, thank you, Gautam. It's a pleasure to be here. And thank you to the entire Mint fraternity for this invite. Always good to come to the summit and have these conversations. So let's just go back, in the years that the pandemic was there. And I think it was, in more ways than one, an inflection point, Gautam, because it actually created a momentum around that single thought process that in India, healthcare is scarcity in motion. Scarcity from the perspective of infrastructure and beds, scarcity from the perspective of talent, whether it is clinical talent or paraclinical talent, scarcity in supply chain. We saw what really happened during that period of time. And so all these facts just came out glaringly for many years of inaction that has happened behind this sector, which is more in the context of public healthcare spending, private healthcare, actually taking a much larger momentum in terms of providing care. Now let's go back and see, these were the lessons, what has happened post that. Now what has happened post that are a couple of things. And one of the big lessons which came out was that healthcare needs to think differently, adopt technology a lot more. So the entire inflection point of the digital impact in healthcare has just sort of begun to happen over the last couple of years, and the COVID situation was actually the inflection points toward that. Then came the entire indigenization around medical technology and building out medical technology, make in India, make for India, the entire thought process around that India needs to produce its own medical technology because 90% of our medical technology is imported, which we pay in US dollars. So, when I hear these conversations around accessibility and costs going up, you should also think that the rupee depreciates every year, right? So the investment cost behind per bed actually keeps moving up every year. And that is one of the core reasons as to why the cost of healthcare also then keeps on moving. And last but not the least, I think this entire momentum around medical education and that the government needs to do a lot more around medical education and the supply side of the clinical acumen in the country. I think a lot of that also happened in the post-COVID scenario, like, the 154 medical college announcements and the nursing colleges and everything that has sort of is beginning to happen in the medical and the paramedical education. So I think this was a wake-up call in many ways. For years and years together, we have been constantly talking about the fact that India underspends on healthcare on the public side. We keep talking about our goal of 2.5% of GDP. We still have to get public healthcare spending to come to even 2% of GDP, right? So we are largely private-led, and I think the momentum will also be private-led.
Right. You mentioned infrastructure. How has the private infrastructure grown over the last 4-5 years?
So I think a lot has happened, Gautam, from the perspective of the scale that every provider is aspiring to go for, which is basically adding more number of beds. So potentially, we have probably added close to about 10,000 odd beds in the post-COVID scenario. But we must also understand one thing, that an institution of 300, 400 beds actually takes about 3 to 4 years for it to be set up. And I don't think that the functionality over here is only on creating more number of beds. Because what will you do with beds if you don't have the medical talent behind them?
Right.
And that scarcity of medical talent, which is still 4-odd doctors per lakh people, in spite of the fact that there has been almost like 100% increase in the number of medical graduates over the last, say, 7 to 8 years, but a medical graduate, by the time he becomes a specialist and a super specialist, actually ends up spending 15 years. So all these medical colleges that we are talking about have grown in the last couple of years, they will all come into the domain or into the sector and sort of perform their role 15 years from now or 10 years from now. So I think there is a long tail over here of actions that needs to happen for the momentum to pick up on the healthcare sector side.
So it's not really, healthcare is not a demand constrained market at all. It's a supply constrained market. And it's not just beds, it's also labor pool, it's the talent, like you mentioned. What about nursing talent? We often hear of the shortages in nursing, not just doctors, right? And we have one state supplying, 80% of nursing talent in India?
Yep.
Kerala, ladies and gentlemen, supplies 80% of nursing talent. And a lot of this talent actually is meant to be exported, not sort of service the domestic industry. So how are hospitals coping with it?
Yeah, that's a very good question, Gautam, because if it is not clinicians, then the provider side on the nursing, on the nursing talent is even worse, right? So on an overall basis, India now has about 3.5 million nurses who are accredited nurses or certified nurses for a population of 1.3 billion people, right? And for a healthcare sector that is so large. So you can again see that on a per lakh population basis, we are hugely understaffed on the nursing side too. So, at best, if I remember my numbers right, we probably have about 5,200, 5,300 nursing schools and colleges in the country, which is not enough at all. Yeah. And guess what? A couple of years back, the Nursing Council actually eliminated the entire GNM nursing pool because they said that, they are not very well trained, so we will not even have those courses. That took away a large section of the nursing pool out of the ecosystem because, we are now only getting graduate nurses. But the fact of the matter is that within the healthcare, within the healthcare offerings, you do need not just the graduate staff nurses, but you also need lesser qualified nurses so that you can continue to, use and optimize the graduate nurses to their best. So there is an equal problem over there too. So that's the reason why I say that this is scarcity in motion. And until and unless we have an exponential change driving the entire talent creation, we will definitely not get to the kind of proportions that we need as per the WHO norms.
You were the CEO of Fortis and the CEO of Walker before that. Was the nursing talent demand supply situation as bad 10 years back as it is now?
So it was not, and the reason why it was not was basically, those were the growing years of the sector, one. Secondly, there were enough schools and colleges, and also because many of the nursing schools were sitting under the charitable trust institutions and things like that. There was this large group of GNM nurses. And incidentally, in my own profession, I've actually seen some phenomenally good GNM nurses, right? And who can do everything and do it very, very well. So by taking away that entire talent pool, the industry has not done itself any good. In fact, we've created more problems of scarcity in that area of paramedical or in the area of nursing talent, and which is also true for all other, so whether it's technicians, whether it's radiographers, whether it is cath lab technicians, we needed to do this 10 years back. We are almost a decade late in terms of accelerating the entire talent supply pool for medical and paramedical resources in this country.
How does this, the question that comes to my mind is, how does this really impact delivery of healthcare services, particularly in tier 2 and tier 3 cities? Because a larger hospital in metros will probably still be able to access that talent, but what happens to tier 2, tier 3 cities and hospitals there? Where do they access talent?
So another very, very good question, Gautam, because, if you take a look at the industry grows at about 16-17% on a CAGR basis. Our talent cost is today jumping 20-25% year on year. So again, when we come back to the question of affordability, accessibility, when you have talent pool costs going up so exponentially, sustainability does become an issue, right? And now, if that becomes an issue on the metros of the country, which are fairly well supplied, then what will be the situation in the tier 2 cities, right? Because everybody from the tier 2 cities has been gravitating towards the metros. So if we have to go down the path of fulfilling the tier 2 gap, demand supply gap in healthcare, then we definitely need to make sure that there is enough talent in the tier 2 cities to take on all this new infrastructure that will get created in terms of number of beds. And frankly, that is where the next growth driver for healthcare in the country is. I think our metros are almost saturated with the number of beds that we have on a per citizen basis. And there is a massive demand supply gap that exists in the tier 2 and tier 3 cities, which I think is the next frontier of growth.
Well, private equity and private equity players have been interested in this sector, and there's growing interest, and returns have been good, right? And we'll talk a little bit about that, but will private equity be interested in funding hospitals or picking up stakes in hospitals, buying out hospitals in tier 2, tier 3 cities?
Well, that's already happening. And so if you take a look at the number of transactions that are happening today, they are not just happening around the networks which are only placed in the metro cities, but a lot of transactions are now happening around hospitals which are based in the tier 2 cities. Care hospitals, the one which I used to chair, has 90% of its bed capacity in the tier 2 cities of the country. 14 hospitals in some of the larger tier 2 cities. And we have seen some phenomenal growth behind that network. So I think there is a great opportunity, for early movers who've gone in there. Yes, it takes a little bit longer in those markets to sort of establish yourself, to make the brand presence felt. But those are really the markets of future growth.
How does profitability for a hospital differ when you compare a metro to a non-metro situation?
I think from an EBITDA perspective, Gautam, it would be a couple of notches or a couple of percentage points less. But we have to also see that sometimes in the tier 2 cities, your cost of execution is also lower. So, so from a margin profile perspective, it almost sort of touches the same numbers. But I think from a metro, it also depends on the clinical programs that you're able to provide in the tier 2 cities. And if your clinical programs are as intense as you would provide them in the metro cities, then there is no difference in the EBITDA margins.
Would you say talent from tier 1, say a doctor who is in a tier 1 hospital, would he ever sort of go back to his hometown to service hospitals there? Do you see that happening?
I see that happening a lot today. I used to see that happening during my days at Fortis. I used to see that happening during my days at Walkhard. Basically because, when you look at where to all the medical colleges, AIIMS, the PGIs, and all the big, large medical institutions, doctors come or aspirants come from all over the country to come and get educated in these centers of excellence of medical education. And then there was a time when, because technology was not available to them back in their tier 2 cities or the cities where they belong to, they sort of remained in the metros and continued to just practice medicine along with the rest of their colleagues in the large metros. But the moment you provide them technology, and the good thing today, I think from an India perspective, is that you see the number of airports that are coming up in this country, they're all coming up in tier 2 cities. Right. And that's a classic example of where growth is happening. So many of the clinicians now, because there is better quality of infrastructure, better schooling for their children, better social ecosystem, better quality of roads, everything is beginning to get better in the tier 2 cities. So I'm seeing this reverse migration of clinical talent to go from the big cities into the smaller cities, because they also see their future potential opportunities to become leading consultants in those cities, rather than become a number 8 or a number 10 in a large metro.
Great. Talk a little bit about money. Funding, right? Your platform has picked up stake in specialized hospitals, not really the monolith horizontal hospitals, right? Motherhood, the nephrology hospital that you picked up stake in oncology. What is driving driving you as a platform or any other investor to a specialized chains rather than the monolith large hospitals?
So that's again, good question, Gautam. Where do we see the opportunity and why do we see that opportunity? I think that was the question behind when we started Asia Healthcare Holdings. And it goes back to that primary question of demand and supply gap, one, where you can create a faster acceleration of infrastructure creation, accessibility, and also meet the consumer's new demand for healthcare. And I felt that when we started Asia Healthcare Holdings in 2016, we started it with an oncology network, which was just one hospital in the city of Hyderabad, which ended up becoming 16 hospitals in just 4 years. Where do you find that kind of opportunity? Because when you're creating the large format, 250, 300 bedded institutions, as I told you, it takes 3 years to make one. Right? We created 16 of these in a matter of 4 years. Motherhood, again, a classic example. When we invested in Motherhood, it was just 3 hospitals. This is in 2016. We are in 2024. Motherhood is now going to touch about 30 odd hospitals. We are in 16 cities around the country. Nova IVF, when we picked up that chain, it was 19 centers. Today, Nova is 80 centers across 44 cities in the country. So I think the opportunity of vertical healthcare, as I call it, rather than the horizontals, is that you can grow at a much faster pace. You can create your presence at a much faster pace. You can get better return on invested capital in a much faster pace. And more than everything else, you can fulfill the demand-supply gap in a much faster pace too. And now I see that beyond just the vertical creation of infrastructure and going in and creating these small format hospital chains, you start putting now technology on top of that, and it becomes a massive big enabler. So I'll just give you an example. In Motherhood, we looked at neonatology as a big opportunity. That was a women and children hospital network, and we felt that the big thing in India today, again, from a fulfillment perspective, is the number of newborns who die because we don't have good neonatal intensive care services. And so we started building out first the physical beds, and we put about 350 neonatal intensive care beds. And then we said that's not enough. So now we are building out an entire network of electronic neonatal intensive care units with a hub and spoke model. And that's how you then scale using technology, and not just by beds, but also providing care through using last mile connectivity, which is very good in India today.
But does this mean that there will be lesser interest in larger horizontal hospitals going ahead, more and more investments, not just your platform, I'm talking from an industry perspective, be more interested in vertical solutions, vertical healthcare services going ahead?
No, I think there is a place for every vertical or every segment of healthcare delivery, Gautam. I think the large format horizontals, they have their own play, and that's a necessity too. We need multi-specialty hospitals. We can't do without multi-specialty institutions. There are many specialties which actually cannot come out of a large format multi-specialty institution into a single specialty vertical, neurology, neurosurgery being a very important one, because you need all the other specialties to provide and fulfill the care for a neuro patient. So I think there'll be certain specialties that have come out and will come out into the single specialty play. The large format multi-specialty play will continue. And then you will have, the new health tech opportunities that are now coming up. So I see the different segments play out on a consistent basis, because again, the need is so high that you can, almost every segment can place and find an opportunity of their own growth.
What about returns when it comes to specialized hospital chains? Is it faster? Do you get a return on your investment faster?
No. So the ROICs on the large formats are definitely slower, and that's basically because, Gautam, as it takes a long time to build these out. They are very high capex. Plus, by the time they break even, by the time you sort of build it, break even, it's about 5 years up. And then you get into your return cycle after you sort of break even and get to, say, at least a 15 to 20% EBITDA margin. And then you come back to your CapEx redeployment. So I think the longer time frame is required for the multi-specialty institutions to provide ROICs compared to the single specialty institutions, because your initial CapEx is far lower. Having said that, I think if you look at the almost like an $8 billion of investment that has happened in the sector over the last 5 to 6 years, a large portion of it has gone both in the multi-specialty institutions as much as it has gone behind the single specialty institutions. So from an investor's perspective, I think there is an opportunity to sort of invest behind both formats of healthcare. And of course, the third one, which is the health tech side.
Right. So essentially it needs patient capital, which you bring to the table fully, right? I would like this to be interactive and like to see if the audience has any question for Vishal at this point in time. The gentleman over there. Can we get a mic to the gentleman in black jacket?
Good evening. I hope I'm not intruding into your marketing strategies. I'm just asking one question. What are the new standalone vertical specialties that you foresee in the future coming out of the bigger setups?
Yeah, that is a secret, right?
That's why I said the same.
So if you take a look at what we have done in Asia Healthcare Holdings now for close to about 6 years, we have done the oncology specialty. We took that and grew it and made India's second largest oncology chain. We have done the women and children with motherhood. So that takes care of gynecology, obstetrics and pediatrics and neonatology. We have done IVF on a standalone basis, so that takes care of reproductive medicine. We have now recently done AINU, which is Asian Institute of Nephrology and Urology, which takes care of the urology and the nephrology specialty. So 4 done. The next one, which I believe which has an opportunity, is in the GI space, because GI is another area which can be done in a single specialty hospital network. Because a large portion of GI is outpatient care, all the endoscopy work. On the inpatient side, you can do a lot more GI surgeries today through the minimal access route. So you don't really need, sometimes the very large format, big format institutions that you need for the higher end tertiary care, quaternary care procedures like liver transplants and the others, which will continue to happen in the large format institutions or the multi-specialty institutions. Besides that, we've also done ophthalmology. So through our TPG growth investment, we are investors in Dr. Agarwal's, which is now India's largest ophthalmology chain. So that is another investment that has happened. So I think if you take a look at, we've sort of covered a very wide spectrum of single specialties. I can't really think, orthopedics is another one, which I think a couple of chains have already done. My issue with many of the chains is that they start as single specialty and very quickly morph themselves into multi-specialty institutions. And that's basically because they add too many beds too soon. So they can't really stay core to the knitting. But orthopedics is another very classic example, which can be done in a single specialty kind of infrastructure. So I think that's a lot to pull out. Obviously, subspecialties like ENT and others also have a space in the single specialty arena.
Mr. Bali is giving you business ideas. Right. The lady here, please. Front row.
Hello, nice to listen to you. I am Dr. Adrita. I'm representing Clove Dental. So since you say that specialty single specialty investment. So what is your take on, as dentistry is coming up in a very, very big way, so what is your take on that, and how would you guide us, rather?
Firstly, congratulations on the recent round. So my apologies that I did not include dentistry in the, because in the outpatient care, obviously dentistry is the number one, and I think Clove has done a fantastic job in terms of the scale and size that you have created. Like in ophthalmology, Center for Sight is another example. They've done such a fantastic job of growing in this in this region of the country. I think I've led the dentistry life. So during my days in Fortis out of Singapore, we used to own a chain called Dental Co-op in Australia, New Zealand, which had about 250 dentistry sites between those two countries, and we used to own that. I think dentistry consolidation is certainly an opportunity, but as you've also seen in your own business over a period of time, I think it is the average revenue per procedure, which is very low. Insurance is not really a big player in terms of backing dentistry procedures. So that's what limits sometimes the growth opportunity that you have. But if you look at worldwide, there are many dentistry chains, particularly in the developed world, which are all funded, because dentistry is funded through insurance.
That's right. Thank you.
So you're on the right track, not a problem.
Correct. Thank you.
Okay, we have another question. The gentleman back there, yes. Can you identify yourself, sir?
I'm Dr. R.K. Suri. I'm a clinical psychologist and mentor of Talk to Angel, online mental health platform. What do you see an opportunity into the mental health domain?
I think that's the next big one, Doc. And so I forgot to tell when Gautam asked what is our learning out of COVID. I think mental health and mental health awareness is probably one of the biggest opportunities that has opened up in the post-COVID scenario, because it's just come out of the so-called under the carpet thought process around mental health. And I definitely see on an outpatient basis, I do hope that India gets more psychologists and psychiatrists and mental health coaches who can sort of power the growth opportunity that is there in this segment. We sometimes feel that that's the roadblock in terms of the clinical talent that can be behind the growth of a very large-scale mental health opportunity, but that is definitely the big one. Like wellness, fitness, mental health, these are the three broad buckets, which again, post-COVID, have been big accelerators.
What do you think in terms of the regulatory framework, in terms of the psychologists, psychiatrists per se, and what do you think is the penetration and support of insurance in this domain? Anybody can become a coach today. Anybody can become a psychologist today. What do you think is the right path in terms of a regulatory framework?
It's a valid question. So during COVID and post-COVID, we saw a lot of quacks. Everybody was a mental health expert, and it sort of mushroomed all over the net.
No, that's very, very valid. I think in some of these specialties, we need to create new accreditation standards. We need to see clinical outcomes. We need to see insurance actually playing a role on the back of clinical outcomes, right? And which unfortunately, so I was very intently listening to the insurance panel before us, and nobody really talked about that how insurance is innovating around new products and services. Everybody talked about cost and more cost, but nobody really talked about that world over, insurance is actually the healthcare innovation engine. It is not, healthcare providers actually innovate a lot more because they know that there are insurances backing them towards their innovation journey. But I don't see that level of insurance innovation happening behind products and services in India today. And mental health is a classic example. In fact, outpatient insurance coverage is one of the big opportunities. So while I know that certain insurance groups have started doing cashless OPD and stuff like that, but I think a large momentum has to happen behind some of these clinical specialties on the back of very precise clinical outcomes. Otherwise, as Gautam said, everybody is a mental health coach. I could become a mental health coach tomorrow, because I have an ability to talk well to people.
Vishal, on the question of innovation, right? And you spoke about technology. Why has health tech, beyond the initial aggregation model that we saw, right, in both services and pharmacy, why is there a lack of why is health tech not really taken off in India?
So I think, Gautam, the reason for that is basically because unlike e-commerce, where you can get your products very, very quickly, in healthcare, you need to create trust, loyalty of patients before they can sort of come through your door on a consistent basis. And I think what has happened with most of in the health tech space, so there are a few online pharmacy companies which have been there for a long period of time, and you can see in the consistency of their growth, right? Because they have spent a lot of time in building that trust with their consumers. But a very rapid growth trajectory of that sector will not happen because that customer loyalty, that patient support will always take time. I mean, you look at even in hospitals, it takes a long time before the big brands, as we see them today, actually became big brands, where people trust them blindfoldly, right? They just will enter a hospital and say, no, I trust everything which is going on over here, because it takes a very long period of time. Again, good clinical outcomes, good success rates, good clinicians. And I think that is going to be the engine. Just saying that, because I'm funded and I've got $100 million funding behind me, doesn't mean that you will get 100 million consumers coming through your door. Right. So the digital door is open, but it needs a lot of support mechanism around patient care, which also needs to happen simultaneously.
What about Make in India devices, right? During COVID, we had this huge debate on, because there was a shortage of ventilators, right, if you remember, and most of these ventilators were imported, and there was a lot of innovation, quick fix of Indian ventilators. But what happened to all that momentum in Make in India medical devices?
So I think some momentum has started. So there are Indian companies which have started manufacturing, ventilators, CPAP, BiPAP machines. There are some very good Indian companies today on the medical devices side. There are multinationals which have now started producing some of their medical technology goods in the country itself from a manufacturing perspective. But I do not find precision engineering in medicine, in medical technology, still sort of ramping up over here. So there is no manufacturer of MRIs and CT scans which is made in India, right, of that level, which can go and compete with international technology. So I think there is a gap over there which has to be built up, and that gap should provide us with a lot more momentum in the Make in India spirit.
Will Indian hospitals, Indian doctors give startups, medical startups, sort of an entry?
Absolutely yes, because they all know that these are enterprises and institutions which are trying to give them products which are available in rest of the world, and that they all understand that till the time we do not start, anchoring our own medical technology in the country, accessibility to high-end care will always remain a high-cost care. So, if we need to bring prices to some level under the affordability, accessibility umbrella, then you need a lot of this technology being indigenous.
Right. One final question I wanted to ask you, Vishal, was on artificial intelligence, right? And we have heard the role of artificial intelligence in different sectors, and it's been around in healthcare as well, right? With Watson being one of the earliest systems that we saw, right? Particularly with the use case in radiology. But it did not take off. And some Indian hospitals like Manipal actually implemented it, but then gave it away, right? What happened? Was it too early, or it just doesn't work? AI just doesn't work when it comes to healthcare services?
No, I think, Gautam, healthcare is always slow on technology upgradation. fundamentally because the users, which are clinicians, they have to get very comfortable with that technology. I think AI is one of the key drivers for efficiency creation in healthcare. Its use case, radiology. It's absolutely a necessity today to have an AI engine sitting in your radiology department, because with the kind of throughput and the workload that we all have, AI is a big tool to sort of generate productivity. So I think AI will continue, and now with generative AI, we are going to see a lot more opportunity in that space. So I don't think that AI is just another buzzword. I think you will see AI penetrating very deep in the healthcare ecosystem, and there is a lot more that needs to be done using data analytics and the quantum of data that healthcare enterprises are throwing up today. If you look at all the big tech companies, they have all made major bets in healthcare in recent times. Right. And there is a reason as to why. I mean, these companies now go under the MAMA acronym, the Meta and the Microsoft and everybody, the Alphabet. And so I think that's where the future lies, and I think everybody sees it. All the technology companies see it. So I think we are going to see a lot more tech in healthcare.
Right. On that positive note, I think we have to end the session. We are time is up. One final question. Okay. No, we'll get you a mic. Please identify yourself.
I will. My name is Nikita Singh. I'm from Fortis Healthcare. And Mr. Bali, it continues to be a delight to listen to your insights. So thank you for sharing those. Since you did participate as in listen into the session before this, I was curious. Dr. Mishra mentioned something. He said that he talked about the regulation in insurance, but it was almost, and that's just a presumption or perspective from where I was sitting. He seemed upset that, in healthcare, there is absolutely no regulation. So I was curious to know, one, if you have any thoughts on that. That leads me to my second question. Please do bear with me. Leads me to my second question. There is this sense of distrust that I see between healthcare and health insurance. How can we bridge that? Any thoughts on that?
So I don't think, number one, that the healthcare sector is not regulated. I think that's a wrong observation. It is regulated. How did the entire pricing around cardiac issues, stents, and all that come up? Because of the regulatory framework. There is an ART bill which now regulates the IVF sector. So I don't think that the healthcare sector is not regulated. All your accreditation standards that are required for you to get insurance reimbursement, if it was not regulated, you wouldn't need all of that. And there was a time when none of these were in place. So the sector is definitely regulated and will continue to be regulated, which is, I think, very positive for the sector, right? The second thing, in terms of this divide between the insurance and the providers will always continue to be there as long as the single point of conversation remains pricing. And that is the reason why I was saying that till the time insurance doesn't step up and start pushing the entire agenda of innovation, where is Optum of India? United Healthcare in the US created Optum as their health innovation engine, and United Healthcare is the largest insurer in the United States. Where is Optum in any of the insurance companies in India? So I have an issue here in terms of that insurance companies only go after providers with one single point agenda every time, and that is the pricing. Nobody talks about how we can actually create better wellness. Your insurance premium will be less if you stop smoking. Your insurance premium will be multiple times less if you stop having alcohol consumption of a certain literage, right? So I think unless you start looking at all of that and become more comprehensive, then you'll be sitting on this table and looking at more productive solutions, rather than coming every year and saying, drop your price by 10% because I need to offer my companies a better margin. That's not how insurance and the healthcare providers will ever work together.
We are completely out of time.
Thank you.
Vishal, there are a lot of people wanting to ask you questions. I would request ma'am to take it offline, right?
Yeah, I can meet you.
Yeah, take it offline. And thank you so much, Vishal, for your insight. It was lovely listening to you.
Always
and
a pleasure,
I hope the
Gautam.
audience
Thank you
really
very
gained
much.
from it.
Thank you very much, Mr. Vishal Bali and Mr. Gautam Das. That was a very, very informative fireside chat on high-tech with scale, the future of healthcare. Thank you so much once again for joining us here. Ladies and gentlemen, we will now break for tea and refresh yourself, and we'll see you back in 20 minutes. Thank you. Request you all to kindly fill in the feedback forms. Your feedback is very valuable to us. There are feedback forms placed on your table. Also, there are QR codes on the 10 cards that's placed on every table. You can scan the QR code, fill in the feedback form, and submit it to us. That would be very kind of you. I will also take the opportunity to thank our associate partners, All India Institute of Ayurveda, Yashoda Super Speciality Hospital, Kaushambi, RG Stone Urology and Laparoscopy Hospital, Merrill Life Sciences, and Center for Sight. Also, I would request all the guests to keep live tweeting using the hashtag Mint Healthcare Summit and tag us on our Twitter handle LiveMint. Now it's time to begin with our second panel discussion, HealthTech's Cost-Cutting and Scaling Up Imperatives. First up, I would like to invite our moderator for this panel discussion, Ms. Neha Shah, Senior Assistant Editor, Mint. And now I would like to invite our panelist, Mr. Ashish Venkatramani, Partner, 8 Roads Ventures, Mr. Prashant Tandon, CEO and Founder, Tata 1mg, Mr. Shashank ND, Co-Founder and CEO, Practo, Mr. Gautam Chopra, Co-Founder and CEO, Beto. Let's have a round of applause for all the panelists for being with us today. Over to you, Sneha.
Good evening, everyone. It is my pleasure to be moderating this session. You know, healthcare is the hottest, sector today, and within healthcare, the people who are moving, or rather covering most ground are the health tech companies. So, though it is the most underpenetrated sector, the kind of growth that our health tech companies have seen has been phenomenal. If I have to throw in a few numbers, India's health tech segment is expected to grow to 25 billion, essentially doubling by 2025. So, I would like to just, start by saying that almost more than 250 companies, 250 startups in the health tech segments are today funded by private capital. So, Ashish, would you want to take this first? Today the question is not about how big the opportunity is, because that is already established. We have, a really established company in the health tech segment. The main question is, which are the growth pockets that you really see, really taking off from now?
Yeah, I'll attempt to do that, Sneha, and thank you and thanks to Mint for having us on this panel. I think, look, first of all, I'll just frame the market opportunity slightly differently. I think growing to 25 billion is maybe understating the larger opportunity. I think healthcare technology is playing in a pool today. I think the larger healthcare market is truly what we should focus on. 220 billion will be $500 billion by 2030, so it's like 2.5x growth from here. And founders like my fellow panel members and others are essentially, I think targeting that pool, right? And all of these segments, whether it's pharmaceuticals, med tech, healthcare services, diagnostics, are growing in double digits. So the demand is unconstrained. I think the role that we are seeing as investors in companies that are leveraging this landscape is either solving for better clinical outcomes, right? Solving for better patient experience, solving for access, i.e. lower cost to serve, and doing it in a manner that's financially viable, right? And so I think the opportunity is large. The headroom for growth is immense. The problems are very real, and tech and data can play a meaningful role to address all of these three. So I'd say that, any business that solves for one or more of these, fundamental opportunities is certainly, has a very large canvas to look at.
Right. Prashant, 1mg has really it has added adjacent categories to the business, starting from e-pharmacy, now you have diagnostics, there's pharmacy. So how do you really see which are the growth pockets within the segments that you are present in, where you really see that it will transform into a multi-billion-dollar category?
So I think, as Ashish also mentioned, wherever there's a pain point, there's an opportunity to solve that pain point and build a good business around it. And what 1mg is very clearly focused on is the experience of the outpatient as they deal with their day-to-day healthcare. So once they are not in the hospital setting, whether they need their information, medicines, lab tests, consultations, other healthcare services, we provide all of that through the platform that we have. And going ahead, we believe just like our consumers live in an omni-channel world, a lot of the platforms will evolve into omni-channel platforms. There will be offline components, there will be online components. At the end of the day, the healthcare experience, of course, is in a physical setting or a physical delivery, so that is not going to go anywhere. And what we are going to see more and more is that this entire patient journey, whether it is preventative and wellness-oriented healthcare, whether it is curative healthcare, all of that will become omni-channel. They will go to the doctor, they will go to the hospital physically, that is absolutely important. There will be requirements where digitally would be the more efficient channel for them to go at. So now, as a business, we are looking at all the dimensions where, from a patient-centric view, can we integrate whatever that patient requires and provide that? And if that can be done, can that be done over a life cycle? Condition management, outcomes orientation, that's the direction. I think the last 7-8 years of health tech, what we have seen or done ourselves is built the fundamental building blocks, the basic plumbing of healthcare delivery to a consumer. Now that is going to come together to create these long-term care models, these disease management models, integrated experiences, and then the data cycle starts playing, and that's where you get into personalized preventative healthcare. So very, very exciting cusp right now, because the data game has just about started. And what will happen is, and this is, I think, transformative also, because this is a space where India is not copying models that have been developed here or there. We are creating the models in parallel, in conjunction, like work is happening in US, China, there's that. India is creating its own models of data-based AI, machine learning. All those things that we hear about are actually becoming real to finally do what? To create for a patient a better experience of healthcare that is very personalized, preventative, predictive. So where is the opportunity? That's where the big pie is actually.
Right. So, it's very interesting that Prashant touched upon this entire need to be digital, because healthcare, like EdTech, is one sector where, you cannot be either fully digital or, offline. So, Shashank, I would want to hear it from you, this entire, need to be digital. Have models really evolved, post-COVID? What do you think that works and what do you think doesn't work? What has the learning been?
Thank you, Sneha, and also, good evening, everyone, and thanks, Mint, for organizing this and having us here. Just to highlight, the aspect around digital, I think healthcare, the last 15 years that I have done health tech, the two things that I have come to realize is that, it's all about the trust that the consumer has on a particular brand. Now, that's a very important aspect, because whether you're physical, whether you're physical, whether you're digital, whether you're phygital, I think it's all goes to the company that has gained the trust of a consumer, because healthcare finally is the most personal thing for any individual, and with this very important aspect of themselves, nobody wants to take any risk, and when they don't want to take any risk, the option that they turn to is most likely the most trusted option that they want to go to. And so that's very important. And two,
the very important aspect of this trust is that it takes time to build this trust. And so one thing that's been, unfortunately overlooked in health tech, and we were actually also discussing this outside, is that healthcare is one in which you'll see the companies that have actually been built out, they take decades to be built out. Now, whether that's a hospital group, whether that's a diagnostic group, whether that's even a pharma group, right? It takes decades because the trust by every stakeholder takes time. It's through each and every interaction that a consumer has with that brand, the trust keeps building and the word of mouth spreads. And the outcomes then, reinforce the whole loop. So this trust element, feeds itself to a timeline element, which is not clearly understood in health tech. And because health tech has so far been also seen as yet another vertical that's venture funded, the life cycle that a health tech company goes through is very different than other sectors where a brand needs to be created. And so I think the timelines that a health tech company takes is different. And so in this journey, I do believe that, to the point that Prashant made and what you were asking, that to gain the trust of the consumer, the most likely medium is for you to be both online and offline. Because when the consumer needs you, you're there online. At the same time, for a more thorough, beat in terms of a provider, being offline with the touch and feel, the confidence that the consumer gets on your diagnosis is far better. And so I think that digital only feeds the fact that trust gets enhanced. And that's why I do think that it's going to happen. But I think we'll all have to be patient and patiently build it out.
Right. So trust is the key word, says Shashank. So Gautam, I want to, backstage we were talking about, so consumer is one part of it, but doctors, the intermediaries play a very important role. The kind of trust that doctors and these intermediaries need to have in health tech model, how important is that? Because we have seen that in some cases there has been a lot of pushback from doctors as well, where they are probably not yet ready to adopt those models. So what is your thought about that?
No, thanks, first of all, and a very good evening to all of you. I believe and I understood many of you here might already be medical practitioners or from the healthcare industry, so it might be a little bit of a conflicting answer. But I feel in general, of course, I mean the doctors or any healthcare provider is a very key element into the treatment of an individual for most diseases. So you can't build a solution, or whether it is healthcare or health tech, by keeping the doctor out of the solution. And however, of course, it has been an inherent challenge, whether, and most of us over here have been almost a decade old trying to build companies. And the same as it is for customers to build that trust and adopt the product, the same goes true for the healthcare provider as well. I'm just coming just before this from a meeting with a few doctors, where we're trying to also collaborate in terms of a phygital approach, where of course our digital solution is able to complement their physical diabetes clinics. And what was really interesting was that we don't have to go and explain the basics anymore. They all know how to carry out a virtual consultation. They all understand how to make prescriptions online. So the basics which some of us were confronted with back 5-6 years back, definitely periods like COVID and beyond have allowed a progression on at least ensuring that adoption of technology by traditional players of the ecosystem is taking place. Yes, there is a little bit of deficit of trust which has to be overcome, and I feel that is happening with time, because neither the doctors or healthcare providers can exist on their own in silos, and neither can digital health companies or solutions. Because what you see is that, like most businesses, there's a question of adoption, and then there is a question of retention and monetization. So adoption, definitely, to build that upfront trust happens faster in an offline physical setting, especially in the case of healthcare. But when you look at retention, it's largely governed by 3 factors, right? It's about price, it's about convenience, and eventually health outcomes. And digital solutions are able to offer a much better way to be able to get better convenience to the patients, bring better pricing and affordability of the healthcare solution, and eventually it's proven, definitely we've proven it in India, but elsewhere in the world as well, that if you're able to get a digital solution and perhaps complement it with a physical solution in healthcare, you can drive far better health outcomes, far better results for patients that not only impact a person's health, but also their quality of life so they can keep coming back to the ecosystem.
Right, interesting. Shashank, you touched upon, most of these health tech businesses being venture backed. So there is a lot of private capital that has gone into the sector. And suddenly after 21, when the funding boom happened, we are seeing this chatter about stronger unit economics. Each VC event that I attend, people are only talking about how to strengthen balance sheets and, restore health of companies. So how important is, or rather, let me put it this way, as a founder, what kind of dilemma are you in to pursue growth versus stronger unit economics?
Yeah, I think that I founded Practo in 2008. So we've seen a few cycles of excess capital, lack of capital, moderate capital, different types of capital in the market. And as a founder and as a business owner, you have to keep adapting to the environment. When there is, I would not call it easy capital, when interest rates are low and there is maybe in relative terms excess capital, then there is a certain growth expectations that is there in the market. That's there, everyone, and that's relatively judged, and you are supposed to adapt to that. And similarly, when there's a situation where we are in, where there's a lack of capital, and it's not just in health tech, but it's there across the world globally, and nobody can predict when will this change in the near term, then as a company you have to adopt to that. And I think today, for sure, is the time to prove whether you have a business which is truly solving a pain point, which has a value proposition that is differentiated, that captures a particular margin and adds value to all the stakeholders. And are you able to execute that with the operating cost structure that you have and grow at a much more reasonable pace than before? I think that's the proof of the pudding that's expected today. And similarly, when the tides change, the same company, the same team is expected to change their behavior, maybe not to another extreme, but to a point where a certain higher growth rate is expected. So I think it's always required to adapt to the situation. And today, the companies that have the right unit economics are able to prove that not just at a transaction level, but at an EBITDA and then a cash flow level, have the ability to make money for all the stakeholders. That's what's getting valued, and I think rightly so. And I think in the next few years, that's what's going to take place. I think health tech will come out better through these next few years, where the stronger business models come through and the stronger companies and emerge, and that will help the entire ecosystem.
Right. Great. Prashant, if you can come in here and talk about the kind of cost-cutting measures that a company like yours have taken to ensure that the company is on track. Backstage, we were talking about various lines of businesses which are already profitable, and a couple of them which are not are going to hit profitability very soon. So I'm sure you've taken those measures, and if you could share some of those with the audience, it would be great.
Sure. See, I think these cycles, and again, similar to Shashank, having seen so many of these cycles, it's a great thing for the ecosystem, and some of the strongest companies get built during these down cycles, or where the capital is constrained. Similarly, when capital is available, that's where a lot of new innovation and a lot of new things, people try to do all kinds of things. So I think most of the companies, including us, what this phase does is makes you focus on things that really matter, makes you invest all your resources on the business opportunities that are here and now, and get better at that. And I think one of the big movers of the needle actually is where you invest your technology and management bandwidth in. When you are focused on growth, all of that is on more customer acquisition, growth, etc., etc. In phases like this, the same technology resources go towards better automation, better process management, all the leakages that might have been there, all the tech debt you might have incurred when going after growth. You start fixing all of that and the business inherently becomes stronger. So things we did, a lot of automation across the board, a lot of processes got tightened, fixed, a lot of longer term projects that and experimental stuff got put on the back burner. Let's focus on the things that are more here and now. And I think it does give you the opportunity to set your business model right, because it's not only you who is doing it, the entire ecosystem is doing it. So your whether it's the cost of your marketing that generally comes down because the competitive intensity has gone down a little bit. So all of that kind of comes together, and it's remarkable how fast businesses at scale are able to turn around the business models. And what we have seen in sector after sector, and we will see in healthcare for sure, is over the next 2-3 quarters, most of the companies would have moved to profitability.
Right. So over the next 2-3 quarters, Prashant and Shashank, they are expecting things to turn around. But Ashish, do these companies who have, been able to turn around, who have been able to cut costs, who have been able to restore health, do they have better access to capital? Because, you come from the VC world, so you have a view on, what do you really prefer?
No, it's a great point, and I think, I personally worry less about growth, simply for all the reasons we spoke about. I think the opportunity is large enough. And to borrow, what Vishal mentioned in the fireside chat before the break, I think demand in healthcare is generally unconstrained, right? So I actually worry less about growth. And I think to my mind, unit economics or profitability is an output metric, right? I think it is a number or a series of numbers that reflects a tangible value addition that a company is doing for a patient or a consumer of healthcare. And the way simplistically to think about it is, why will the unit economics look good, right? It's either that I have a point solution that is so valuable that a patient or consumer of healthcare is buying this repeatedly, and so the lifetime value is meaningful, and I can offset my customer acquisition cost, and I can, the experience is appropriate enough and valuable enough that someone buys it over an extended period of time and willing to pay for it. Or, I have addressed a problem that is meaningful enough for them, that the margin pool that I can capture is meaningful on a transaction basis, right? And that can be through a mix of an expert opinion, of medication, of surgical procedures, of post-op care. And so, symptomatically as an investor, what you say is, look, if someone is willing to pay a meaningful amount for a transactional case or a meaningful amount over an extended period of time, that is only because they see tremendous value there. The experience is appropriate. There has to be some clinical outcome, right? And when that happens, it reflects on the P&L and in the balance sheet in terms of better cash flows, stronger unit economics, EBITDA positive, etc. So to my mind, I think every investor, or at least I would say sector-focused investors for sure, understand this nuance. And I think worry a little less about the growth and more about how real is the problem you're solving, how well have you solved it, and that will reflect in your numbers, right? And I think there is certainly capital available there. In our own portfolio of companies, we have had companies, even in a year that hasn't seen too many financings, we have had companies raising decent amounts of capital, but all of them have shown meaningful trajectory on these numbers. However, that's an outcome of work that they've done to focus on the core, right? Which is what Shashank and Prashant alluded to. Just the patient experience, the clinical quality, and ultimately, the cost of the healthcare that they're solving.
Right. Ashish touched upon a very important point, margins. And, a lot of, I mean, not just health tech, I mean, across, technology-led companies, we have seen that margins of late have been under pressure. It could be due to various reasons, supply chain issues, and CAC is one, problem that founders often complain about. So, Gautam, if you can touch upon, how have the CACs changed? We saw a period where, post-COVID, there was a lot of discovery that happened, and then, the CACs just went up, and, the businesses became a little unmanageable. And how are you trying to bring down the CAC? How are you trying to, find newer growth areas?
So I think CAC, to Ashish's point, also is a function of the business model. So obviously, if it's a one-point transaction, and you need to break even on that transaction, and you may not see that customer or patient again, you better, not spend as much and make sure that you can have a profitable transaction after CAC. But let's say in our case, for instance, where there is a repeat engagement of the patient over a long time because they unfortunately are dealing with a chronic condition like diabetes or hypertension, then the upfront cost of acquisition is of course looked at from the prism of the lifetime value that Ashish was talking about. So we typically would look at a lifetime value to a CAC ratio and see if that is making sense for sustaining this business and growing it from a sort of cash that we are able to generate over a period of time from the customer. Now coming to what happened in the post-COVID era in healthcare or beyond healthcare, I think there was of course naturally a euphoria, and companies went ballistic trying to get a lot of customers, and perhaps many times went over the top with regards to acquisition cost, marketing spends, etc. But I think that discipline has been enforced now. Most of us, in the healthcare ecosystem are taking the cost of acquisition much more seriously than any of us perhaps was doing before, because there is a need to build over a period of time sustainable enterprises, and I think that realization, that reckoning has come. In terms of breaking down CAC, of course, digital health companies in most avenues looked at digital marketing, perhaps did not focus as much on in terms of organic growth, as well as looking at alternative go-to-market strategies which were perhaps offline, or bringing patients in or customers in. And I think a lot more thought is being given to some of those aspects which perhaps were not under consideration before, because you could simply just increase your marketing expenses and then still acquire some customers through digital means. But now if you're forced to look at more cost-effective measures, then as a business, to Prashant's point, you start focusing on fundamentals and naturally organic growth, as well as the fact that India was built on non-digital channels before, and traditional companies in healthcare as well have seen that growth. And it's now time for some of us also to start looking at those alternatives and balance that cost of acquisition.
Right.
Could I also jump in on this one, Sneha? I think just to build on, the panel earlier touched upon the physical and digital combined being important to build patient trust and deliver a better experience. But I think as we think about growing these businesses and customer acquisition or patient acquisition cost, I think we're also seeing companies think of this physical and digital media as being complementary channels to also acquire and retain patients, right? And what that means is we're seeing innovation on educate online, acquire offline, or some combination thereof. We're seeing people think about partnerships more meaningfully, right? So you don't have to do everything yourself. You work with enterprise partners, or you work with regional partners or channel partners to try and target corporates, target various health systems, etc. And we're seeing, I think, a lot more innovation in terms of how companies are thinking about acquiring patients, holding on to them. And so, I think this mix of physical and digital is actually quite beneficial, not just in terms of experience, but also in terms of strengthening the overall model, which also impacts, the cost of acquiring and retaining patients.
Right. Interesting. So Gautam said that, organic growth is what most founders are, it's back to basic kind of a thing. But this is also probably the best time where, some of the businesses, because the kind of valuation reset has happened, access to capital has been difficult. There are certain businesses, which are available. So are there any inorganic growth opportunities that, Prashant, do you see that way, there are categories probably you can add and scale up faster, the speed to market that these inorganic opportunities offer?
So I think market does have a lot of inorganic opportunities at this point, and having said that, it's one of those phases where you need to be very clear about what you are spending your capital on, and if that is a good opportunity for sustainable growth, then we would certainly be interested and have a look. Having said that, the other part of the reality is that most of the good companies actually have decent access to capital still. So you need to be very lucky to find that those companies that are really good companies just suffering from a timing perspective that they don't have access to capital today. And I think there is that subset, so we do get a bunch of things to look at these days, and we are trying to understand what would make sense, because all said and done, capital is very precious right now, so we will invest in any growth opportunities that really are compelling and make sense. I think the bar for what makes sense is right now pretty high. So you need full alignment and all of that. In my mind, healthcare as a sector, if the companies are actually doing well, there's no dearth of capital. So, and if the companies are not doing well, there is no availability of capital. So it's kind of, what do you buy? And it's not changed as dramatically as one would have thought.
Right. Ashish also mentioned, probably the kind of founders are looking at, educate online and acquire offline, right? So, that's the kind of thing that most BPC companies also follow. They say this content to commerce. Does that really translate into business? If Shashank, you can talk about that, are you seeing that those kind of conversions really happen where, people are now comfortable doing, telemedicine or online consultations? Is that really translating into business?
Absolutely. I mean, even before this whole thing was coined, content to commerce, I think both 1MG and Practo have benefited a lot from either medicine information leading to an e-commerce transaction or doctor information leading to a doctor appointment. And I think we've been at the receiving end of some goodness on that. I think the fundamental thing in content is that, there's a consumer need, does the content solve the consumer need in a differentiated manner, not a commoditized manner, and can that lead to trust, which gives you the right to provide that commerce that the consumer then subsequently needs. And I think if this equation is satisfied, I think it definitely plays true. I think the only challenge that happens, which one needs to understand, and it's true, is that content to commerce, the content portion of it is actually also an investment. It's a very significant investment. It's a long-term investment. It's not like you start content today and next quarter you're expecting results. I think if you really need to get content to commerce, right, at least from my point of view, it takes a couple of years of investment, and the results come over time, and because it kind of compounds, the content compounds, you learn back, the feedback loops compound, and then slowly leads to good success. So, but I think where the world has moved today and where we are also trying to move is that we were very good with textual content, static content, as you call it, web pages, web information, or what you get as a result. But today the world has already moved to video content, which is 10 times even more expensive, right, than even before. So the stakes are higher, and we're also moving there. We are now creating far more video content than ever before, and we are substituting that. And so clearly we see that's the only way to move forward. I think you need to move up the value chain. And so earlier discovery of commerce was the starting point. Now it's content is the starting point. I don't know what tomorrow's starting point is going to be, but today it's there. And today the content is also not static content. It needs to be video content. And so you need to be there at that point to lead the consumer your way. And if you capture that point, then it's all downstream from there. And just to highlight one last point I wanted to just add on was on the margin side. I think one good thing in healthcare that's there is, we spoke about patients always being there. That's true. The other thing is margins are also there. I think large portion of the healthcare is not commoditized. It is a trust economy that works, and education and healthcare are two that are, that grow at multiples of inflation in terms of pricing and in terms of things. And you'll see today, if you look at the provider EBITDAs, they're at an all-time high right now. And that's largely because of the fact that people value their health the most. The learning and health are two things that people value the most. And so margins are always going to stay. I think what is required is the patience to build the trust. And there are no shortcuts in healthcare. In fact, the only shortcut in healthcare is downwards. So if you need to build a really long-term business, then the only way to do it is through patience, and the margins will come.
Right. Interesting. So I think we have some time to take audience questions. If any of you want to ask some question to the panelists, please introduce yourself and then ask. And also tell us who you want it to be answered from. Anyone? Yeah. Ma'am over there. Can we get a mic to her?
Hi, thank you for that conversation and the discussion. My name is Nikita Singh. I'm from Fortis Healthcare. And as rightly pointed out, there is a certain amount of the ups and downs that we do see going on. So I'm just going to borrow from what I've been listening to in the previous sessions, and this would be open to all of you. One of the things, one of the first sessions that I attended was the conversation on insurance. And that was followed by the chat with Mr. Bali. And one of the things that struck me was how they all said that we need innovation and technology in insurance, because that is going to help bridge the divide that we see between healthcare and insurance. Now, considering that all of you are in health tech, and we also have someone who, Mr. Ashish, who invests. So have you seen something innovative come your way? Any thoughts on that space?
Ashish, you want to take it?
Yeah, I can start. And great question, I think, and a very valid one. My personal view is that I think technology will play a pivotal role in, I think, driving a payer transformation in India. We are seeing a number of companies. I think all of them are a bit early, and so it is TBD on which model will eventually prevail or evolve. But we're seeing companies trying to do managed care and essentially solve for underwriting at the point of entry. Also, very tightly manage certain clinical conditions, both outpatient as well as inpatient, with an end actuarial game of a lower loss ratio. So that is one model. We're seeing other companies establish closed networks for outpatient, work with best-in-class inpatient, and eventually reduce the cost of care delivery. So we're seeing actually quite a lot of innovation in this. I think it's an area where, I think the regulator is also, spending a lot of time on encouraging some of these companies to apply for insurance licenses, ensure that they're adequately capitalized and, well positioned to actually, transition into full service healthcare insurers. But I think long answer to your short question, we're seeing a reasonable amount of innovation. I think we as a franchise and I personally as investor feel we will see a meaningful, evolution in the way insurance is administered in this country. And there are at least, more than a handful of companies that are trying to address this in very innovative ways. They need to solve for regulation. I think they need to solve for, some business model tweaks along the way. And hopefully the the competition, because healthcare insurance isn't necessarily the most high margin, given some of the incumbents, are quite large and operate at a certain price point. So we need to see, I think, a little more scale on the retail side of things, because the enterprise is quite hard to crack unless you solve for your product offering upfront.
I'll just jump in here. I think we work with a bunch of insurance companies, and almost all of them are very actively looking at getting into better customer lifecycle management, if I were to put it, because it's a very simple thing and it makes so much sense that the interest is very well aligned. If the beneficiary stays healthy and does not need excessive spend on inpatient care, the insurance is clearly benefiting because their expense ratios go down materially. Now, how does that happen? That's where the disease management models have to prove themselves out, that better management of your condition, be it diabetes, be it any other chronic condition, you taking care of your health and insurance companies incentivizing it in multiple ways. Can that make you healthier? If that makes you healthier, you keep paying your insurance, they never have to pay you back, you are happy, they are happy. So it's exactly the direction to go. It's exactly where a lot of action is, that can we get into proactive health management for our beneficiaries? And that's where, how can it be done? It can only be done if you have all the context and information, because otherwise the ability to game the system and frauds become unmanageable. So closed loop networks that Ashish mentioned are a big part of how they are thinking about things. End-to-end data tracking, validation. So these are all digital networks with the simple focus on let's keep the person healthy so that the bill doesn't come, and that is a win-win for both entities.
Great.
Thank you so much. So curious about a couple of things that the both of you said. So I'll draw first. So two things. One of the things that I heard a lot of the people speak of was that, lack of awareness. People don't know, and this is continuing the insurance conversation, sorry. So there is absolute lack of awareness. People do not understand the importance of health insurance. Now, my thought is, why are we not looking at creating, because somehow it becomes a product. We look at reducing costs, we look at distribution, but we're not paying attention to the public that is going to actually consume this service. So possibly a thought, is it possible that we can look at creating, or innovating in the space where, we educate people? I think that is something that nobody has thought of, because the moment when you told me, as in whoever told me that mutual funds are great and SIPs are the way to go, I immediately understood, whether I'm 29 or 25, right? I understand that, or in college. But health insurance comes possibly when you're in your mid-30s, mid to late 30s, something like that. So that's something that I think we really can think about. And if all of you have some thoughts on that, that's wonderful. I know you work a lot in providing, information on diabetes, Mr. Chopra, so I'm aware of that. So, something like this, which would actually be beneficial, one question on that, yeah. And I seem to have completely lost track of the second one. Probably will come back.
You can ask again.
Yeah, but, maybe you can take it offline.
Yes, I will.
So Nikita, great question, first of all. I think, you're seeing this awareness build up. I don't know how many of you saw the World Cup, but there were a couple of insurance companies which had a very interesting play on the communication, where there was a person, walking with a fracture and took his cast off, etc. So I think people are trying, first of all. Unfortunately, in our insurance world today, there are two factors, according to me at least. And when we see, of course, from the cohort of people who have conditions like diabetes, one is, like diabetes, for example, also insurance, there is a perceived seriousness. You don't necessarily think कि आज मेरे को कुछ हो जाएगा, for a healthy human being. right? Where, let's say, a person who's 30 or 35-year-old may not be able to fathom that they will, encounter some severe condition over a period of time. The other thing is that also from an insurance perspective, we are still nascent and we are busy ensuring healthy Indians. But what perhaps we're not realizing is that that pool of people over a period of time is becoming unhealthy, as well as, I was talking to somebody in the US who run, these health management organizations, where we are today not able to, as in India, insure unhealthy or somewhat unhealthy people. So for example, in diabetes, a person who has an HbA1c of 8.5 is simply rejected to get an insurance product. But on the other hand, if this individual is well managed, their quality of life in terms of health, as well as, let's say, in terms of also longevity for life insurance, is as good, if not better, than any other individual. To add to that, the CAC on this, or cost of acquisition we spoke about, for a person looking out for a diabetes product or looking out for an insurance product and maybe a diabetic, is going to be next to negligible, because this is more like a pull approach than a push approach. So that's where the synergy between, let's say, a health tech company and an insurance company works, because you can work in tandem to be able to solve for both these things. And definitely, education and awareness counts, because let's say in our case, we are able to drive, clinical health outcomes for individuals, prove that to, of course, insurance companies. And now we have, in fact, we're working with a couple of them where there are very specialized products which can be offered to our own customers for insurance, where they find an entry much easier. That entry barrier is lower in terms of where their HbA1c or other health parameters will be, and we have the duty to be able to bring their health outcomes better managed, and eventually it's a win-win for everybody. So we have to play our part as well in terms of being, I would say, the folks who have to, the gatekeepers, I would say, for our own set of customers, and educate them and make them aware of the fact that long-term risk of complications need to be also looked into. But we have a duty not just towards the patients, but also towards working with insurance companies so they can price the product better and offer them to other folks beyond the healthy individuals too.
Sorry to add on, but you brought in a very interesting question last on. But I think I differ on few things here. It's honestly, I don't think the problem is how to do insurance or how to get the technology into insurance. I don't think the problem is the theory around the theory of it. The problem is that you use a very interesting example of mutual funds. Look at the balance sheets of mutual funds and the distributors of mutual funds, and look at the balance sheets of hospitals like Fortis and others, and look at the balance sheets of standalone health insurance companies. And one of the things that one needs to ask is, especially on the insurance side, is the unit economics that one talks about, right? Of course, the industry is growing very strong, and there is, long-term this thing. I think the challenge that one sees in insurance is how do you make money, right? And to the point that was being shared, that in corporate you really don't, and you have to really get the retail side to win. But what's happening is that we are seeing more and more people coming to the provider side of things, is because there is a margin pool that's available there, and that's what attracts it. Whereas in insurance, you're not seeing that. You're seeing the loss ratios being things that are pulling back investments from it. You're seeing, and so I think the challenge that I see is that it's to do with the state where we as a nation are right now. The places where insurance is really much bigger, like the US or in other countries, is where the per capita is far higher, and we are still getting there, and that's why in our country, providers really have the large market caps. The market caps of the top 5 healthcare providers or drug manufacturers are far higher than the insurance companies, standalone insurance companies today. But I think that might be much different later on. But when will that happen? When will the inflection happen is somewhere debatable, whether it's going to happen because of lack of technology innovation, or it's just a state where the per capita has to really grow. Because we are able to find, in the US and other places, the healthcare delivery is so expensive that the only way to traverse that is insurance. But in India, you get healthcare delivery at reasonably good quality at multiple price points. So there are some fundamental questions on the market. That's why I don't know it's awareness or technology the real answer there. I think there might be some truth to the market evolving as well.
Great. With that, sir, I would request you to take the questions offline. Yeah, our panelists are going to be around. You can, connect with them offline. We're already out of time, but thank you so much, Ashish, Prashant, Shashank, and Gautam, for taking time out. Really appreciate, you having me. Thank you so much.
Let's have a round of applause for this wonderful panel. All the questions that you still have will be taken offline. Thank you so much for joining us today, Mr. Ashish Venkatramani, Mr. Prashant Tandon, Mr. Shashank ND, Mr. Gautam Chopra, and of course, Ms. Neha Shah for moderating the session. Before moving on to the next panel discussion, I would like to once again express our gratitude to our associate partners, All India Institute of Ayurveda, Yashoda Super Speciality Hospital, Kaushambi, RG Stone Urology and Laparoscopy Hospital, Merrill Life Sciences, and Center for Sight. I would remind all our guests to once again fill in the feedback forms if you still haven't done that. The feedback forms are on your table. Also, there are QR codes placed on every table on the tent cards. Just scan it, fill in your feedback form, submit it. Your feedback means a lot to us. And I'm sure a lot of you are taking pictures and making videos of the sessions. Please post it on social media using hashtag Mint Healthcare Summit, and do tag us on Twitter. Our Twitter handle is LiveMint. And if you are not doing it yet, click more pictures, click the sessions that are happening on stage, make videos of it. Tell us what you think about this summit and the event or a particular session on social media. We'll be having our third panel discussion now, after which we will have a keynote address, followed by a fireside chat. All right, we are ready to begin with our next panel discussion of the day. And the topic is Indian Healthcare, Challenges and Opportunities of the Future. First up, I would like to invite the moderator for this panel discussion, Mr. Alokesh Bhattacharya, Deputy Managing Editor, Mint. May I now please invite the panelists, Dr. Mahipal S. Sachdev, Chairman and Managing Director, Center for Sight, Mr. Vivek Srivastava, Co-founder and CEO, HCAH India, Dr. Om Manchanda, Managing Director, Dr. Lal Path Labs, Mr. R. Raman Tandon, Managing Partner and Co-founder, Praxis Global Alliance, and Professor Tanuja Manoj Nisari, Director, All India Institute of Ayurveda. I'd like to thank all the panelists for joining us today for this session. Over to you, sir.
Thank you very much, Ushma. Let me get my papers right. This is a very broad topic, right? Indian healthcare challenges and opportunities of the future. We could go on for like more than the time that has been given to us, for sure. I hope all of you are enjoying yourselves. There's been quite a few very, very interesting sessions, and we have at least 3 more very interesting sessions coming up. So as you can see on stage, we have a very, very distinguished panel. All of them are, celebrities as such in their own right, and they have achieved, a lot in their careers. They also belong to certain niche areas of Indian healthcare, right? So specialized chains and specialized areas of healthcare which are different from your general hospitals that you see around us. They take away the pressure from the general hospitals, which are anyway overloaded, be they public or private, and they are very skilled. Where does this narrative fit into our healthcare ecosystem? What are they doing right, and how can they do better is what we are going to deliberate on today. I would first bring the consultant and the expert to bear on, it's a very broad topic, right, Aryaman? But maybe you could just tell us a little bit about where do you see the challenges? You know, we've heard a lot about supply side challenges, scale challenges, but taking this composition and this subject in mind of specialized chains and how they cater to Indian healthcare, what are the possibilities and what are the issues that you see?
Thanks, Lokesh, and also thank you for the Mint team for hosting such an exciting session. Of course, the question is pretty broad-ended, so I'll try and keep it as succinct as possible. See, in my mind, there are 4 or 5 things. The long list is pretty long. What matters is what are the 5 big needle movers in this. Biggest challenges from the single specialty care. The number 1 is insurance. I know we've spoken a lot about insurance in the previous sessions, but I have 2-3 slightly different points to make about insurance. Number 1, insurance in India, health insurance is a very dumbbell-shaped market, where on the lower end, with Ayushman Bharat, with CGHS, CSI, etc., you already reached a good insurance level, where the per capita coverage is close to almost $1,000 per year. The higher income people already have very high penetration of private insurance and group insurance through companies. The issue is the missing middle, which is mostly there in the urban areas, the middle to lower middle income people. Close to about 300 million people, in the urban India are uninsured. And these are the people who actually need insurance. The other thing is the coverage of insurance around wellness, coverage of insurance around other areas like our own Ayurvedic treatment methods, dental, etc. A lot of other categories and specialities which are not covered in insurance. And also finally, the amount of coverage that is actually given to these lower income and middle income people in urban India is abysmally low. It is close to about $400, $450, which is even lower than the coverage which is given to lower income people through the government schemes. And these are actually the people who are going to these single specialty chains in tier 1 and 2 and 3 cities and needing care. Because the higher income people are already going, to the corporate chains. And another thing about insurance is, see, we can talk about causality or, a correlation, but insurance is also a little bit a double-edged sword. Today in US, with a very high insurance coverage, out-of-pocket treatment has become completely unaffordable, right? So we also need to drive insurance in such a way that out-pocket also remains affordable, in any kind of hospital that you're able to go to. So that's one. Number 2 is the supply of hospital beds. So we do a lot of work in this area, and actually our point of view is there are close to about 2.7 to 2.8 million hospital beds in India, combining public and private both as of now. This number has gone up. A lot of the estimates that you see publicly available are actually older estimates. They don't cover what's happened in the last 3 to 4 years. Especially in the single specialty, mid-sized chains, a lot of supply has come in the last, close to 5 years. So we're at about 1.6, 1.7 beds per 1,000 people. WHO recommends, of course, a much higher number. A lot of developed markets are there close to 2 to 3, 2.5. US hovers around that. So we are actually, of course, short, but we've covered a lot of ground in the last sort of 5 to 10 years. What is the issue? 3 things. 1, supply is there where demand is low, and supply is not there where demand is there. Tier 2 cities, tier 3 cities are growing demand close to about 10% volume year on year, but supply is not growing at that rate. So that is 1. 2 is less than 1% of hospitals are actually accredited. So there's a massive shortage of quality beds. Though there are 2.8 million beds, our estimate is less than 25% are high quality, right? And the third thing is, in all these hospitals, majority, about 75% of the supply are small to medium-sized hospitals, which actually lack a multi-speciality or a full-stack care view, right? That's 2. So the whole supply bit, again, is a big shortage. The third thing is testing, and Dr. Manchada, you will speak a lot about it. But we do roughly 1 test per capita in India per year. This number is 10 times 1/10 of the number which is there in a lot of other international markets, developed or even some developing markets, which basically means, and we do about 3 to 4 consults per person per year. So less than 30% of consultations are actually being given out without a testing, which basically means the whole clinical outcomes, the treatment protocols recommended, are they even right? The medicines recommended. The fourth is, a lot of, when you talk about single specialty, right? A lot of the capex and a lot of the medical equipment which is actually being bought, about 70% of it is imported, which basically leads to a much higher cost of care. And finally, what I would say is, and this is probably a more mother-all statement, but I read this interesting research where if you look at the average life expectancy of in India is about 68, 70. It's of course in the 80s. If you go to developing markets, the early years of life, economy is created by consumption. The later of years of life, the economy is created by spend on illness, right? If the life expectancy and wellness, preventive care, health is addressed early on, and the incremental 10 years of life that you get, the overall economic impact of that is going to be about 20-25% higher, right? So that's why the focus on preventive care, wellness, general integrated care before people actually get sick, and how that gets integrated into insurance, also becomes a very important part. So I think those are 5-6 biggest challenges. Also, I'm a firm believer that whatever is a challenge is at the end a big opportunity in this space, are also big opportunities, right, for providers.
Right, absolutely. All challenges present opportunities in themselves, and I'm very happy I started with you. Aryaman, you've opened up this discussion on multiple fronts, and I'll come to all of you, but first to Dr. Manchanda. One test per capita, in a year, is that like, are we really so healthy that we don't need tests?
No, I think that's more to do with the prescription behavior of medical fraternity, and also affordability, because sometimes you go to tier 2, tier 3 towns, you may need a test, but the person can't afford test because that person has money only for consultation or medicine. So I think it's a combination of many things.
Right. And so, Dr. Manchanda, we were discussing, and apart from the challenges that Aryaman has outlined, there's also the fact that, like you were saying, that the biggest issue in India is not a clinical challenge, it's more a management challenge. And would you like to elaborate on that a bit?
So, many times in forums like this, one discusses that healthcare has challenge of affordability and accessibility, right? These two words I've been hearing for last many years. These are challenges, but my personal experience is that, of course, we can't solve this completely, but there is an opportunity for us to solve this problem. One, of course, is insurance, which everybody has been talking about. But my own experience is that one of the biggest sort of opportunity which is lying in front of us is to build a scaled organization. There's a very, very fragmented nature of the industry where, let's say example of diagnostic industry, there are 300,000 labs and one person is running one lab or maximum 2 labs. Now, similarly, I probably, people who are from hospital space, they can say that, but there are nursing homes, 20 beds, 30 beds, 50 beds. That actually is bringing a lot of inefficiency the way we deliver healthcare. My experience is if we are able to build scale, and scale with an organization which is focusing on operating efficiencies and capital efficiencies, you can actually bring down the cost of care drastically. So you are actually, one is of course you are addressing the other side of the equation, which is the payer's capability to pay. But I think on the provider side, we also must address this end of the equation where how do we bring down the cost of care itself. And I personally believe that there's a huge opportunity there. That's why I keep using the term that while there's a clinical side of healthcare, but there's also a management side of healthcare. Clearly, there's a need to build large-scale organizations which runs into, let's say, chain of hospitals. We have demonstrated by opening chain of collection centers and chain of labs, where effectively, if you study the data, our own data of pricing for the last 15 years, pricing actually has not gone up to the extent of inflation. is actually much below the inflation itself. And I can actually quote many prices of various tests which were there 10 years back, 15 years back, effectively are still lower. So I'm is that from a management perspective, organizations should always try to see that the care is provided by the lowest cost of your resource. Now, in our case, let's say labs, the brand experience is provided by the person who collects sample. Now, that's not the most expensive resource in my organization. But if you go to, let's say, high-end specialty hospital, first the whole establishment itself is expensive. Then you want to see the best doctor there where you have to pay highest fees. Now, is there any layer in between which is a missing link of primary or a self-care itself? Now, why do we need to rush immediately for a simple illness to a high-end specialty hospital? That obviously is going to cost you more. Now, to my mind, there is a layer which all of us can build, which is a primary care. Now, with a lot of e-commerce or teleconsult models coming in, self-care is there. We all tend to do our first line of treatment is on our own. It actually can be easily clubbed with primary care, which is very, very cost-effective way of doing it. So I think, to me, if we address this problem from a management perspective, I do get a sense there is an opportunity here. However, of course, the insurance play will always be on the other side of the equation, where how do we get more and more people ability to pay, etc., through insurance. And third, I think, dimension which other day I was in another conference, which is people also talked about, is about a healthy lifestyle. We should create a lot of awareness about what is a healthy lifestyle. Earlier, you had a lot of physical activities, but these days, sedentary lifestyles are growing, but our food habits are changing. I think we must create a lot of awareness in general public about following a healthy lifestyle very early.
Right, thank you very much. And of course, large organizations, building large-scale organizations also need a lot of money. So funding is an issue. Let me come to Dr. Mahibal on that. Dr. Sajdev, you run Center for Sight, which is a hugely popular eye care. How many hospital centers do you have now?
So we have about 80 of them across.
In how many cities?
32 cities, 15 states.
Right. Now, if we were to take on Dr. Manchanda's question of building a really large-scale organization, what would that be? Where will you get the money from? And do you think it is worth it?
I think the biggest private equity investments are coming into eye care. You have the biggest private equity funds like General Atlantic, Temasek, TPG, all of them are invested into eye care. We have Mahindra as our partner, started with Matrix. But just to tell you, if you look at single specialty and if you look at the largest eye care facility across the globe, that's a company in China called as Ayur, which is valued at about close to $30 billion US. And they control about 15 to 20% of eye care in China. So that's the scale that has been built up by eye care facilities. The mere fact is that, as Om was saying, I think it's economies of scale that come into play. And funding is not a problem. I don't think funding is a real problem, because funding comes in. One of the biggest problems is to get the trained manpower. If we look at ophthalmologists, in India today we have about 30,000 ophthalmologists, out of which I would say that maybe about only 50% are operating ophthalmologists, rest maybe they don't operate, etc. So if you look at the figures from the population of India and the number of ophthalmologists, leave aside ophthalmologists, the more difficult one is to get optometrists who do the checking of the glasses, etc. So I think trained manpower is one of the biggest problems that is there. But despite this constraint, India does 75 lakh cataract surgeries a year, which is the sum total of US, Europe and China put together. So that's the kind of phenomenal numbers that we are doing. I don't think scaling up is going to be a problem, because there are 4 or 5 players who are kind of scaling up. And the largest chain, I would say, would be about double of our size, which is about 150 or 160 centers. So putting up a center is not really that much of a problem, because it's an asset-light model. The investors love the ROCE, they love the break-evens, which are maybe 1 to 2 years down the line. It is not. And what is happening in eye care today is a large-scale consolidation. What Om talked about was mom-and-pop stores or people running one single thing. Unfortunately, or whatever, there are a lot of people who are doctors, their kids don't want to become doctors. Because somehow as a medical profession, it's not the cream. Like when we were doing our higher secondary and going out, the thing was either become a doctor or you become a engineer or a chartered accountant, and if you don't get anything, become a lawyer or whatever it is. But the point is that there are a lot of people who are willing to sell their practices, and they are getting good bargains for selling their practices. So there is a lot of consolidation that's happening, especially in eye care. I think it happened in pathology also, and that is going to help in scale. And scaling up is going to be there in a single specialty in ophthalmology, as you are talking in. And that economies of scale will come in. Just to go on from an economies of scale, you have, say, an Arvind eye care system. Now they have a backward integration where they make their own intraocular lenses, they make their own consumables, and they are even manufacturing slit lamps, etc. So there is a captive numbers that they can use. So that is a great, and that chapter is, I don't know, Om and all management people, there is that famous book of Prahlad, C.K. Prahlad, Fortune at the Bottom of the Pyramid. So they will do anybody free of cost if they want, or surgery, or they will take people who are paying. The gradual transition has been from non-paying, patients are coming to paying, and they are the most cash-rich organization today in India, and they have been chaptered in Fortune at the Bottom of the Pyramid. Even the patients, if you can manufacture a lens today at 150 rupees or 200 rupees because you have set up a facility and you have fellows who train, they get up 10th past girls from the villages, give them food, give them a place to stay, give them something to become vision assistants. And that keeps the numbers going. So basically we have to have, in scaling up, the support staff that comes, backward integration, and we need to have the economies of scale. And I am sure that this is something which is going to become the one of the most favored by the private equity, as if they have already become. So money is not a shortage, but this is all that you need to work in the infrastructure, and you will get economies of scale.
Are you planning backward integration yourself?
To some extent, yes. In the pharma and optical space, yes.
Okay.
And that's the most paying thing to do.
Okay. Backward integration, of course, has its own challenges as well. You know, sometimes it can become more cost centers than revenue centers and other things. We'll come back to that. But in terms of scale and reaching, you know, Professor Nisari, Ayurveda, and you are, of course, you know, it is one of the things that everybody knows in India, right? Everybody knows about Ayurveda, but do so many people actually take its benefit is the question. Because whenever somebody falls ill, any of us falls ill, Ayurveda is probably not our first go-to, you know, space. We would, so many people try homeopathy in their home. They consider themselves quasi-doctors, including me, right? I try my own medicines. And of course, like Dr. Manchanda said, many of us don't go to doctors till we are about to drop dead, right? That is a common affliction in India. What about Ayurveda? I mean, it's such a great science, but what are you doing about it, and how are you reaching scale? I mean, there are Ayurveda shops all over the country, but what is the AIIA doing about consolidating all of that into, you know, more action?
Thank you very much. At the outset, I would like to thank the entire Mint group for considering AIIA, the logo, the brown logo you see on the screen. So making us as an associate partner for this very, very important summit. So I thank and I congratulate also. And on behalf of all my senior colleagues and the leader and the dean, those who are present on this August auditorium, all our dean of research, academics, patient care, medical superintendent, and the specialist are present here. So on behalf of all the team, I am here to represent All India Institute of Ayurveda. And it's a very unique model under Ministry of Ayush. 2017, Honorable Prime Minister dedicated this to the nation.
And it was envisioned to have aims for Ayurveda. That means to create a tertiary care model where it is not only care with compassion, but care and cure model with the holistic and integrated setup. That was the envision, and that has been established. And I'm really happy to share that since last 6 years of its inception, we are NABH accredited, and we have been able to manage and completely cure. I mean to say it on this platform that we have treated all our committed experts, those who are, many of them present here. We have holistic and integrated model with that. We have treated 17 lakh patients, and those are success stories. I mean to say it because whatever my colleagues they are saying here, lifestyle, insurance, the confidence, and the backward integration, I think you are talking about Ayurveda. So I echo with all your words. Lifestyle is dinacharya, and everyone what we are unknowingly talking about Ayurveda, we are living Ayurveda as a knowledge system of health and happiness. What is imbibed in our culture is Ayurveda, and we are trying to find out science behind it. But I mean to say it, what different we are doing. We are not doing anything different, but we are doing it differently. Because as our Lal Pat mentioned that investigation, maybe people wants evidence as a proof dikhaiye, theek hua. So we have Dr. Rajaram and Jonas who are there. So maybe if you ask us, so we have the data of 70,000 patients. One of the colleagues was asking in the first panel that 70,000 patients of diabetes mellitus. And we have that data with HMIs. And how does that, why this data is very important? Because for each and every patient, we have the outcome measure, HbA1c. We have the blood parameters, glucose, and we have everything which the conventional medicine understands. Those scientific parameters of the investigation, radiology, imaging, we have that data. That's why we say that we treat with Panchakarma diet, lifestyle, yoga as a holistic, as a diet intervention, non-intervention and cure together. But we do assess and investigate each and every patient so that the people get a confidence. So this is our tertiary care model. And now coming to the academic part, because we are the NABH and NAC A++. In the first cycle of assessment, we received NAC A++. I think very few institutions receive because this is a postgraduate teaching and training center. So the mandate is create evidence and understand the science behind our traditional wisdom. And we have 1,500 publications, and many of our clinical trials are as gold standard. It is double-blind controlled clinical study with our 60 MOU partners with London School of Hygiene. We are creating the model and assessing for the prevention, because in the wellness and prevention also people want now evidence. Why गरारे करना क्यों करना? Why the warm काढ़ा क्यों पीना है? हल्दी वाला दूध? Where is the evidence? But we are creating the evidence for having this large cohort study. So this is what we are doing differently.
Right. So your evidence on preventive care is actually something that everybody in India wants. We talked about prevention earlier in the earlier sessions as well, and maybe less people will have to go to Center for Sight or to Lal Path Labs if they are, and prevention is done better. Yes, and for Center of Sight, I would like to inform Dr. Sachdeva that we have Manjusha and we have the specialty care, specialty unit for the holistic eye care, the ophthalmic care, and maybe from pediatric to geriatric, a different setup for the prevention and the eye care model, which is very, very specific to Ayurveda, and where we have MD, PhD research going on, so that very safe and evidence-based model can be integrated with Center for the Sight. Maybe wonderful. So that would mean that Ayurveda and allopathy can correlate to each other and learn from one another.
Yes.
Let me come to you now, Vivek. Basically, what happens is we all have spoken a lot about shortage of hospital beds in our country, right? 25 lakh beds, did you say, Aryaman? Is that what we have, right? And we are short by how much?
I mean,
we are short by about another 2 lakh. So, Vivek, your organization...
20 lakh.
20 lakhs. We are short by 20 lakh hospital beds. That's, imagine that, try and think about it. It's like, can't wrap your head around it. But Vivek, you have been trying to address this particular issue, you know, with your organization, and there are other organizations also like Porsche and others who are into this area of healthcare at home, which is something that you started with, and then you have moved on to also add more arms to it, right? How does your organization actually help take away some of the pressure from hospitals, and what are the areas in which you're working, and you know, what are the difficulties that you face?
So first of all, thank you for inviting me. And I think some of the points which both Ariman and Dr. Manjanda talked about resonated very well. So, you know, the first thing, as you mentioned, there's a significant number of shortage of beds in the country, right? And for a tertiary care bed to be made, right, there's about 1.5 crore rupees per bed. So if you want to build that kind of numbers, the amount of money required would be humongous, right? And hence you need ways to expand the capacity while reducing the capital required in that process, right? Which Sir also talked about. Om also talked about how do you scale and scale it at lower cost. So our bed capacity, you know, our centers where we do, you know, rehabilitation, or effectively think of it like hospitals are for saving lives in acute intervention, for improving quality of life, and to manage the patients. We are in the out of hospital space. And what we do is, we don't require super specialized infrastructure to deliver the care. That's one of the mantras which we have. And we don't require super specialized people to deliver the care. Something which Sir talked about, that, you know, that's constrains the capacity. The capital constrains the capacity, the talent constrains the capacity. But if you want to address challenges of access affordability in the country, you have to address without using these two things. And that's where we are coming on. So think of, you know, a similar example in a different industry would be if you make a burger in Oberoi, right? It will cost so much because you'll need a sous chef, etc., infrastructure. And the cost would be something like that, right? But if you scale organization like Om was talking about, you know, you could make McDonald's, which can go and deliver a reasonable, you know, product at scale, at cost, which are and at quality, something which Ariman talked about. And that's what we are trying to do. So our, you know, the way we are addressing is that our cost of setting up the bed itself is 10 lakh rupees, including capital and operating expenditure.
Right.
And there, the way we are using talent is the maximum we are going is MBBS. Most of the work we are trying to get down, you know, like Om was saying there, you know, the more number of people who are the lowest level who are addressing, if you can train them well, or Sir also talked about, you know, 10th class, 12th class. So we are trying to get the model in such a way that you reduce the cost, and then you'll be able to, one, address affordability, two, access, because you can then take this model to a tier 1, tier 2, tier 3, because you don't have to recover that kind of infrastructure, and you don't require that kind of talent to deliver the care. So that's something which we are doing in the out of hospital care. Of course, when you do it at home, the capital requirement goes down to practically zero, because the capital is in the you know, homes of the customers itself. And on quality, you know, we are going, while we have 50 bedded centers, but what we are doing is 50 bedded scaling into multiple locations and getting them NABH accredited, QAI accredited, and so on, so that the quality remains, and you standardize the process in such a way that you deliver similar outcomes with varied inputs, right? So that's something which we want to do it. So we have proprietary methodologies to do it. We are investing in technologies to do it. In fact, we in some cases, in some of our centers actually have integrated, you know, models to you know, stroke recovery, where we have Ayurveda and you know, yoga also integrated within our centers to deliver the care, right? So how do you bring all these things together so that you're able to address the access affordability and standardize outcomes problem, which is quality, at scale, because that's what is needed in the country. You can't depend upon the hospitals to spread, with the kind of capital infrastructure they require and the kind of talent they require. And they have a job to do, that's saving lives,
right.
and doing acute interventions. But this is one way to, address the challenges of the country.
So building scale, and I'm really happy that you and, Dr. Mahipal also spoke about less expensive, which is something that Dr. Manchanda set off here. So it gives a lot of hope because, MBBS and medical education is turning out to be really long drawn affair in our country and very, very expensive, right? So, and you really don't know whether you're going to succeed or not even after. MBBS is, we puchta nahi hai these days. So now the point is, Dr. Manchanda, if we are talking about scale is something that in our country, we need money to scale, or you need intelligence and you need a technique or a mechanism. So like, Dr. Mahipal was talking about backward integration. Have you thought about backward integration? Because Dr. Lal Path Labs uses huge amount of equipment and a lot of disposables also as well, right? So are you into that? You have already grown into a really large scale organizations, but I'm sure there is a lot of runway still left to go. So how would you, go down that runway?
So I think you have two questions. Maybe let me address the backward integration part. So personally, I'm not sure whether it's the right way to go forward because, when you are operating in a very fragmented, a small unit. Let's say I own a hospital of 20 beds. Then I want to do everything myself. I have a pharmacy, I have a diagnostics. I'm trying to actually accumulate profit from virtually every activity that I do. But as you become bigger and bigger, and I think that to me is actually a barrier to scale because you are trying to do everything yourself. It's like saying you work for a large company and 100% people are flying, you just don't go into airlines business, right? Because that job is somebody else. So I think it is important for a scale businesses to find out what their core business is. What is giving them that competitive advantage, where the customer is sticking on. Right. The rest of the stuff, you just leave it to somebody else who is specialist in that area. Right. So whether it is outsourcing, whatever it is, whatever in that place. So I probably I'm not really, if you build scale and do a backward integration, then you are spreading yourself too thin and not getting into your core areas. Okay. So that's a separate conversation. But I think the second question that you raise, a very important point, is that it's not a rocket science. It's nothing new about this. Everybody knows that you build scale, you will have operating leverage, you can bring down cost of production on a unit economics, right? But I think what is really, where the opportunity that I see today is use of technology. If you actually implement a lot of new solutions, let's say simple teleconsultation itself, can actually bring down the cost of care. But I know that it went up during COVID times, again it's going back. But just look at why it's going back, because it's probably there is a missing. People think the Zoom call is a teleconsult, right? But there is something much, much more than in a teleconsult, which technology can address it. Whether it's the e-pharmacy, now it has solved many problems in terms of delivery fulfillment rate that I see. In diagnostics, the average sort of a time you spend, now home collection has become a big thing in our business. There was a time when I walked into this industry nearly 20 years back. A large percentage of our business was actually a walk-in business. People, I'm sure all of you would have experienced that. You walk into a lab, you're waiting there for 20 minutes for your turn to come. Then you will come back in the evening to collect your reports. So your whole day is gone in this whole entire cycle. But today, with the help of technology, you don't even think of going to a lab, right? You just book online, pay online and say that, okay, 8 o'clock, somebody will come to my house and collect the sample. Now, all that is gone. So look at whole food delivery apps like Zomato and Swiggy and all that. Each category has used technology to its advantage. I think healthcare is a long way to go. My sense is if we all apply our mind and see how we use technology, can be a big sort of a...
Right. So Aryaban, how can we use technology to scale healthcare further? Of course, we have seen, Practo and there are other, health tech apps which have come which offer sort of consultation, teleconsultations and all.
Yeah.
But ultimately, if you have to test, you have to go to a path labs, or if you have to show your eyes for something like a uveitis, then you have to go to center for sight, right? So how do you use technology to scale to the maximum possible?
Yeah. I think, see, if we talk about technology and if we talk, let's say, about a single specialty chain or any delivery setup, I think there are 4 or 5 aspects which we need to look at. One is the patient side, other is the supply side, third is the whole ops and the patient experience, fourth is the clinical side of technology, which is deep on the whole operating system and the doctor training, right, and the protocols, etc. And finally, there's also a big implication on that financially, right? So if we talk about, let's say, on the patient side, right, there is so much technology innovation, and I personally feel that we've only scraped the surface right now in terms of what all technology that exists. Right from managing patient records, companies like, for example, Fortis, every year creates about 20 million patient records, right? Imagine the amount of analytics, treatment protocols, drug effectiveness that can be tested basis that. That is one. Two is the whole medium of delivery of care, which Dr. Manchanda, of course, spoke about. Teleconsult today, interestingly, has become more expensive, than a in-person consult. It is quite counterintuitive. You know why? But I think the way doctors perceive is that that's an incremental service that's been given to a patient, because you don't need to walk to a clinic and get a consultation done. So the patient should be paying for it. So it's actually become more expensive, right, than an in-person consult. Right? Chronic care, by the way, the amount of technology, and we saw in the previous panel where Beto, etc., and a lot of these chronic care companies have set up. I think chronic care is not just a business model, but it's a theme, which impacts everyone. All delivery, single specialty, multi-speciality. How can you embed, making sure that the testing is happening on time, making sure that the patients see the records, you integrate that with wellness. There's so much smartwatches, etc. We've seen 2,000, 3,000 crore companies set up in a matter of 2 to 3 years, with this fitness, wearables, etc. That's a big booming space. The amount of data that's available beyond the hospital, and any healthcare setup which is available to a delivery provider is massive. And using that to create care on the patient experience side. Today, if you go to a lot of hospitals, very few hospitals actually have an omni-channel play. You still need to stand in a queue to make a payment, even if you're having a big pain, right, in your stomach, right? You can't pay online and just quickly go and consult a doctor. Very basic things. I don't think we need to do magical stuff on the patient side. Very basic things, if we're able to solve, there's massive opportunity we can create. Then on the clinical, right, if we talk about any single specialty care, right, at eye care, for example, there are 3 or 4 major types of procedures, right? And one procedure is about 80%, 70, 80% of the volume. The amount of standardization of protocols that you could do, training of doctors on the clinical side, you can actually reduce the cost of care because you can bring in younger doctors and train them quickly using digital so that they're able to deliver treatment much more effectively. You've seen technologies like Cure, etc. They've raised a lot of capital which enable. I don't think you need to supplement the provider. You need to replace the provider. You need to supplement the care provider so that they get technology and they get more productive, right? At the end, you do. I don't think AI, at least right now, can completely replace, right? Then on the ops side, procurement. We've seen players like tech players like Medica, etc., all of it, which they've done. And there's massive amount of technology that can be embedded, technology providers embedded into your system. And finally, I would say, recently there's this, forgetting the name of the company, this AI-based HMS, provider which raised about 15, 20 million capital. Now, AI, etc., is creating a lot of productivity improvement in all spheres of businesses. So, and finally, the last leg of technology and digital is business models. Today, if we look at a Fortis, for example, which is, or Max or Apollo, Fortis itself has about 20 million patients a year, including their diagnostic business. Their presence in about 500 plus cities, the network of hospitals. The amount of assets and the amount of new business models that can be unlocked using digital, is massive right now. So it's not just about patient side, it's about new business models. It's about how to run ops more effectively and how to create better patient experience and clinical outcomes. You know, these 4 buckets of work where digital actually creates
Right,
impact.
wonderful, thank you. We are almost out of time, and we have the health secretary here with us who has joined us. So I will take that opportunity to ask you all, especially Vivek, Professor Nisari and Dr. Sajdev, if there is any policy prescription that you would like to see from the government to further your line of work, like how can Ayurveda be taken forward more? How can healthcare at home scale up more in a quality manner? And how can an organization like Center for Sight that obviously doesn't need funds, you have your own accruals and you have a lot of private equity activity and partners going on. But is there anything from the policy side that you'd really like to see? Dr. Maipal.
Okay, thank you. I think as regards governmental support, I think there is couple of things. The first and the foremost important thing is that in single specialty or in say an eye care, etc., the rules that govern us for getting a nursing home registration certificate is the same as you need for a nursing home where you have ICU, you have beds, you have everything. The fire safety norms are the same, where we don't have ICU or anything like that, and we have been banging our head with the government because it's a state subject for at least last 15-20 years. When Dr. Walia was the health minister, tab se, the paper is there, but it's not coming through, that why cannot you have different sets of norms for a dental or for an eye or for a IVF or for even dialysis. So these are a couple of single speciality where there, because nobody looks at it because we don't have that muscle power of a, say, an Apollo or a, this thing. So that is the first thing that you need to have, is that there should be an understanding that super speciality or single speciality, not super, single speciality, are doing a great service for various specialties, and people love to come to single specialty rather than go to a multi-speciality, because if a person wants to get a cataract surgery done at Center for Sight, the patient is in at 8 o'clock and the patient is out at 9:30. But if you have to go to a multi-speciality hospital, when I left All India Institute, I joined Apollo Hospital. The first thing would be that the sister would call me at 6 in the morning, कि sir आपने इस patient का blood group नहीं कराया. So मेरे को cataract surgery में blood group की क्या ज़रूरत है? But the point is that the system of a multi-speciality, the SOPs are different from what our this thing is, and it's a pain to get an admission into a multi-speciality and then get out of it. It would take the entire day. So we are geared up. The second important thing is that we don't get an infrastructure status. Though if you want us to go to the tertiary 2 or tier 3 or this thing, a multi-speciality hospital, everyone talks about beds. So it is इतने size का है, इतने bed है, तो आपको infrastructure मिलेगा. But why can't it be for single speciality? Because they are doing a very great thing. The third and the most important thing I would say is import duties, which was talked about. When Mr. N.D. Tiwari was the finance minister, we sight-saving equipment which are majorly imported came at zero duty. Today we have to pay 25-30% duty that is there. And the last and the most important thing is GST. You want affordability, but the government would still want to put GST, and we don't get any input credit. So at the end of the day, you put us at a 0% GST or a 1% or a 5% GST, so that at least we can get. So these are a couple of the things which are there. Ease of doing business is becoming really more difficult with all these fire and everything that is coming, biomedical waste. We have to really wait to get all these things really approved for getting even a new center set up. So that is what I would request from the government. So
these are prescriptive things which are, par for the course, and I'm sure they are being worked on. Vivek, I will come to Professor Nisari last, because Ayurveda is something that we cherish. Vivek.
So some of the things which Sir said work for similar things with us as well. But in addition to that, I think out of hospital care is something which has to be recognized as a part of the care protocol itself. Otherwise, what happens is you'll continue to have people in the facilities where the cost would be higher. There'll be government or private facilities which will be full, and patients who require will not get it. The cost will increase. So this becomes a care protocol which is there in the Western world as well. And then government push for payers encouraging these things, because it's a lot lesser in terms of cost. So I think I'll just keep those 2 points in this case.
Thank you very much, Vivek. Professor Nisari, you get the last shot.
To end the talk, I start with what Vivek has mentioned, because as we say that the primary, secondary and tertiary care, the home care can be the fourth arm for the entire care.
Correct.
And when you say as a home care model, Ayurveda has a lot to offer, because lifestyle, diet, care with compassion, because Ayurveda is a knowledge system of health and happiness,
Correct.
illness, wellness to happiness. So maybe a Prakriti specific, we have individualized approach. So maybe a model, a standard model for home care may be integrated with Ayurveda, what you have the existing. That is number one. And the second to this cure model is that the future of the medicine is a no medicine with nutrition, diet, lifestyle. But what I mean to say is the future of the medicine is integration. When we say as a cure model, because
Correct.
with the integration, even diagnostic, it is a point of care devices is the future of the diagnosis, because we have all continuous glucose monitoring, fibroscan coming to us. So that may have to be integrated. And the teleconsultation is not only for the patient and the doctor, but integrating all the pathy and the second opinion, maybe that is also very important. Maybe from the government side, because both health is not the subject, it is not the pathy centric. We have to join together, all of us together in the interest of the patient. So All India Institute is at Sarita Vihar and some is at the other end. So one patient cannot afford to go other. So every institution has set up of all. Like every allopathy hospital should have some Ayush, so that the patient should be able to have the choice. And all India Institute also, we have a very good integrated model. And the last submission, maybe to all the government, we are also part of that. But in PMJKY, because every patient and all Ayurveda, this year was Har Din Har Ghar Ayurveda. So everyone wants to use Ayurveda. Where is the insurance coverage? So maybe
Correct.
more insurance coverage should be given. PMJKY also should have the Ayurveda model where everyone wants to use anything and everything when it is required. Thank you.
Thank you very much, Professor Nisari. All very good thoughts, and I think we'll leave this discussion here, and lots of good points for everybody to think over. Thank you all very much for coming and sparing the time.
Thank you very much, panelists, for giving us a very, very insightful and wonderful session. That was the panel discussion on Indian healthcare challenges and opportunities of the future. I would once again like to thank Dr. Mahipal S. Sachdev, Mr. Vivek Srivastava, Dr. Om Manchanda, Mr. Aryaman Tandon, Professor Tanuja Manoj Nisari, and our moderator, Mr. Alokesh Bhattacharya. Thank you so much. Once again, I would like to express our heartfelt gratitude to our associate partners, All India Institute of Ayurveda, Yashoda Super Speciality Hospital, Kaushambi, RG Stone Urology and Laparoscopy Hospital, Merrill Life Sciences Center for Sight. I hope you're all enjoying the live sessions that we are having here. And if you are putting them out on social media, please use hashtag Mint Healthcare Summit and do tag us on Twitter. Our Twitter handle is LiveMint. And if you still have not filled in the feedback form, please do that. Scan the QR code that are placed on the 10 cards on every table. The feedback forms are also laid out. Give us your feedback, and we would love to hear what you have to say for us. And now, ladies and gentlemen, it's time to have a keynote address on the topic What Indian Healthcare Needs, the Policy Perspective. And we are extremely pleased to have with us Shri Sudhansh Pant, Secretary, Ministry of Health and Family Welfare. Let's give him a huge round of applause. Ladies and gentlemen, let us all once again hear it out for Shri Sudhansh Pant, Secretary, Ministry of Health and Family Welfare, to deliver the keynote address on what Indian healthcare needs, the policy perspective.
नमस्कार। मिंट द्वारा आयोजित हेल्थ केयर समिट 2023 में उपस्थित सभी मौजीज़ गणमान्य व्यक्तिगण, मिंट के मुख्य संपादक एवं डिप्टी मुख्य संपादक, मीडिया के सभी साथीगण, हेल्थ केयर सेक्टर से जुड़े सभी प्रोफेशनल्स, डॉक्टर्स, एंटरप्रेन्योर्स, हॉस्पिटल रिप्रेजेंटेटिव्स, इंडस्ट्री ट्रेड रिप्रेजेंटेटिव्स, हमारे मिनिस्टर डॉक्टर मनसुख मांडविया को आज यहाँ उपस्थित होना था कीनोट एड्रेस के लिए। कुछ unforeseen something came up, so he asked me to be present here and to address the policy issues, the perspectives of the government and what the government has been doing in the healthcare sector. सर्वप्रथम मैं बधाई देना चाहूँगा मिंट को एज अ मीडिया ग्रुप, एज अ पब्लिकेशन, जिन्होंने हेल्थ केयर जैसे सब्जेक्ट को चुना, उस पर एक एनुअल समिट किया और दोपहर से कई आप में से बहुत से एक्सपर्ट्स ने अपने व्यूज़ रखे। उनको सुनने का मुझे सौभाग्य प्राप्त नहीं हुआ, किंतु पिछले कुछ मिनटों में जो मैंने बातें सुनी और जो रोचक चर्चाएं हो रही थी, उससे स्पष्ट है कि दिन भर में बहुत सी बातें हुई होंगी, कई सुझाव आए होंगे, कई समस्याओं पे भी विचार विमर्श हुआ होगा। ये अवसर है, सबसे पहले हम याद करें कि किस प्रकार से पिछले 2-3 वर्षों में 2020 से लेकर 2022 तक पूरे हेल्थ केयर सिस्टम ने मिलकर, चाहे गवर्नमेंट हो, पब्लिक हेल्थ केयर सिस्टम हो, प्राइवेट हो, इक्विपमेंट सप्लायर्स हों, प्राइवेट हॉस्पिटल्स हों, ड्रग मैन्युफैक्चरर्स हों, प्रोफेशनल्स हों, सब ने मिलकर किस तरह से पैंडेमिक का मुकाबला किया। कई लोग बिछड़ गए इस दौरान, लेकिन आज ये मौका है कि सबसे पहले मैं उन सभी लाखों करोड़ों लोग जो फ्रंटलाइन में रहे या जिन्होंने पैंडेमिक मैनेजमेंट में अपना योगदान दिया, उन सबको मैं नमन करता हूँ। आई पे माई रिस्पेक्ट्स टू ऑल ऑफ देम। As far as the government is concerned, health is one of the top priorities of this government, and our Honorable Prime Minister, Shri Narendra Modi ji, is himself at the forefront, driving every healthcare reform which has happened over the last so many years. The biggest shift, paradigm shift, has happened in the primary healthcare space, which still is largely dependent on the public healthcare system, especially in our rural areas. So if you would recall, in the year 2018, the Ayushman Bharat scheme was launched by the Honorable Prime Minister. And today we realize why it has been a game changer. At that point of time, it had two main pillars. The first one was the Ayushman Bharat Health and Wellness Center, which has recently been renamed as the Ayushman Arogya Mandir. The erstwhile Health and Wellness Center has now become the Ayushman Arogya Mandir. And the second pillar was the PMJ, Pradhan Mantri Jan Arogya Yojana, which is the assurance scheme. So what happened at the rural area, at the grassroots level? Initially, we only had sub-centers at the village level, at the panchayat level. And a sub-center was manned by only a health professional of the level of an ANM or a GNM, and would only be and she or he would only be administering some counseling on family planning issues, maybe some immunization, maybe some maternal child care advice. But in 2018, when this concept of Ayushman Arogya Mandir, erstwhile HWC, came up, the shift happened from curative to preventive and wellness. Because every Ayushman Arogya Mandir was supposed to have a community health officer and one ANM and one other health professional for assistance, in addition to our great volunteers, the Ashas, as we call them, the volunteers, who do lots of things, who go around from one home to another. And for the first time, 12 basic screening and diagnostic facilities were provided right there at that level, including NCD screening for diabetes, hypertension, even basic cancer screening, including other tests. So for the first time in the history of the country, these kind of facilities were being offered at the primary level. And this is a huge number. Today, the number of these Ayushman Arogya Mandir is more than 1.62 lakh across the country. We have about 2.79 lakh, about 2.7 lakh gram panchayats in the country. So on an average, every 1.5 to 2 gram panchayats will have one this primary level care. So the shift was from curative to preventive, from selective care to comprehensive care, and to a continuum of care. Earlier only, even at the secondary level, which is our CHC level, corresponds to one CHC approximately in a block or tehsil, those of you who are aware of the administrative arrangement of the country. And then you have a sub-district hospital or a district hospital, and then you have the tertiary care, the medical colleges and others. So where the government struck first was at the primary level, where maximum number of patients, maximum number of people would be visiting. Not that the other segments were ignored, I'll come to that later. So this concept of wellness came in at the Arogya Mandir level. And even twice in a week, there are wellness sessions. There can be yoga classes, there can be Zumba, there can be cycling, there can be walks, there can be, and a lot of counseling on lifestyle, diseases, how to eat, what to eat, healthy diet, etc. So for the first time, a person, a common citizen in the village, got access to not only basic treatment, basic testing and diagnostics, but also some very good advice on healthy living and wellness. So this has been a game changer. Over the last 5 years, the kind of response these Ayushman Arogya Mandirs have evoked is mind-boggling. The figures are also mind-boggling. I'll just give you an example. We are still running an Ayushman Bhav campaign, which started from 17th of September, still continuing. It will go up to 31st of December. So in about 2 months, there have been more than 1 lakh camps, about 5 to 6 lakh camps in these Ayushman Arogya Mandir. And the footfall here has been, in just 2 months, it's been around 8 crore persons. 8 crore people have come and visited these Ayushman Arogya Mandir level camps. There have been camps at the level of community health center. Community health center normally will have some doctors, but not specialists. So the specialists from the medical colleges are coming and giving their services once a week only. Once a week these camps are there, either at the primary level or at that secondary level. And here too, the footfall has been about 1.5 to 2 crore in just a period of 2 months. And lakhs of surgeries have taken place at the secondary level, and 6 to 7 crore people have availed of the facility of free drugs and diagnostics and whatnot. So it's been a massive paradigm shift in primary health care. The second big pillar at that time, the Pradhan Mantri Jan Arogya Yojana, the PMJ, 5 lakh rupees of cashless treatment facility in empaneled public and private hospitals being offered to every beneficiary who's eligible in that list, which is now 12 crore families. Some states have gone beyond. They've gone beyond the beneficiary list. They've tried to cover many more families than what has been prescribed under this scheme. And they have supplemented with their own state budgets and state schemes. So 12 crore families being covered under PMJ translates into roughly 55 to 60 crore citizens, making it by far the largest ever health assurance scheme anywhere in the world by a big margin. Nobody can come close to this. And there are more than 27,000 empaneled hospitals, about 13,000 of which are in the private sector, about 14,500 are in the government public sector. There are hundreds of procedures which are being done. Poor people who could never even afford could never even dream of entering into these good private sector hospitals now can go there without spending a penny, get treated for all kinds of serious ailments. 5 lakh rupees per family per year is quite a sizable amount. So in these 5 years of its implementation, you will be very happy to know that about 6 crore persons have benefited. 6 crore hospitalizations have taken place. And the amount which has been spent which has been reimbursed or paid to the hospitals is nearly 75,000 crore rupees over 5 years. So you can imagine, a lot of these people would not have perhaps survived. Those who could never afford either private insurance or could afford this kind of treatment. So those people are alive. They're all giving their blessings to all those people who conceived of this scheme, who made it possible, the government who's supporting this scheme, paying so much. And of course, many of the state governments have chipped in, as I said. They've gone beyond the beneficiary base, paying from their own budgets. So what has happened in the last few years, again a remarkable shift or remarkable awakening awareness. All the governments, central governments, state governments, during pandemic, post-pandemic, some even before the pandemic, they realized the importance of the health sector. And the kind of money which is being pumped into the health sector today, even the government health sector, I'll just give you some figures later on, it is mind-boggling, it is unprecedented. So everybody has realized that if health has to be the focus of any nation. What India is doing today, I think even developed countries perhaps will not be able to match the kind of efforts which are going on in the country. We often talk about out-of-pocket expenditure, OOPE. You will be very happy to know that over the last 10 years, OOPE has actually declined from about 69% to 44%. And this figure, 44%, is for the year 2021 in our national health accounts. For 21-22, 22-23, we don't have the figures because there's a time lag. But the projections show that this 44% is going to reach about 35% by 25-26 in another 2 years' time. Because the real impact of PMJ scheme started in September 2018, actually got kicking in 2019. So the real impact of the scheme, more and more beneficiaries started availing of the treatment from 2021 onwards. So the real impact of the scheme will now have its effect on the accounts of 21, 22, 22, 23. So imagine from nearly 70%, 69, 70% down to 35%. Out-of-pocket expenditure reducing to half. And why has it become possible? Because the share of government health expenditure of the total health expenditure has correspondingly increased from about 22% 10 years back to a level of about 45% at present in 2021 and projected to go up to 55% over the next 2 to 3 years. So government healthcare expenditure as a percentage of total health expenditure has increased sharply. Rather, it has gone up by 60% over 10 years. And out-of-pocket expenditure correspondingly has gone down from about 70 to 35% by 25-26 as is projected. So what has happened only in the last 6 years, from 14-15 to 2021, of which we already have the data, the published data. The saving in out-of-pocket expenditure for the Indian citizens has been more than 5 lakh crore of rupees. Just imagine, because of all the interventions by the government, the increase in healthcare expenditure, the government healthcare expenditure, the increase in the number of schemes, impact of schemes like PMJ and other schemes, people of this country have saved 5 lakh crore rupees in their pockets, which would have otherwise gone for health expenditure elsewhere. So this is the impact which the government interventions have had in the last 5 to 6 years. Likewise, in the case of tertiary care, when we talk of tertiary care, tertiary hospitals, the medical colleges in the country were around 380, 390 in the year 2015. Today we have 707 medical colleges. The UG seats, undergrad seats were around 58, 59,000 in 2014-15. Today we have more than 110,000 undergrad seats, MBBS seats. The postgraduate seats around 29, 30,000 in around 2015. In 2023, we have more than 70,000 PG seats. Both UG seats and PG seats have increased more than 100%, about 120 to 130% in the last 7-8 years. That is the kind of focus the government has on medical education, not just doctor seats. I can give you statistics for nursing, for pharmacy, for dental seats. Everywhere there has been a tremendous increase, more than 100%, in some cases even 200% increase. The healthcare professionals, just the 4 categories, if you take doctors, dentists, nurses, nursing officials, and pharmacists. In just these 4 categories, between 2013 and 2022, in 8-9 years, number has increased from 38 lakh to 64 lakh. 69% increase in 8 years in the healthcare professionals, only in these 4 categories. Add to these about 15 lakh allied healthcare professionals, about 7.5 lakh of Ayush professionals, and about 10.5 lakh of our voluntary, the Asha workers. So total health workforce in the formal sector is approximately 94-95 lakh. So that is the kind of effort which is going in the development of the human resources in health, in development of the healthcare professionals. So whereas healthcare professionals is one aspect, the other aspect is also health infrastructure. Just in the government sector, every year 30 to 32,000 crore rupees over the last few years are being given under just one umbrella scheme, which is the National Health Mission, which provides for not only infrastructure development at the primary and secondary level, but also for supporting tests, free drugs, diagnostics, transport for medical services, ambulances, salaries, remuneration for healthcare workers at primary, secondary levels, all kinds, so many diseases, from tuberculosis to oral health, to blindness control, to cancer, to you name it. 21 to 24 disease programs are running separately, all being supported by the Government of India to the extent of 60% to 90%. In some states 60%, in some states 90% support goes from Government of India, and in some UTs it is 100% from Government of India. And post-pandemic, learning from our lessons of the COVID, where we felt we were lacking in certain critical infrastructure, including maybe oxygen, including having separate testing laboratories, having critical care blocks. In October 21, the government has come up with the largest ever infrastructure development program by the name of Ayushman Bharat, PM, Prime Minister Ayushman Bharat Health Infrastructure Mission, PMABHIM, which we call PM-ABHIM in short. 65,000 crore rupees just for development of infrastructure, right from the primary level, from the Ayushman Arogya Mandir, the erstwhile health wellness centers, to block public health units, critical care units at the block level, then district level critical care block units, then tertiary level critical care block units, each unit costing either 23 crore or 50 crore or 100 crore depending on the size of the city or the size of the hospital. Then having an integrated public health laboratory in every district, because many of you may recall, when we started with the pandemic in March 20, we had 2 laboratories in the whole of the country which could do molecular testing. One was in NCDC in Delhi itself, the other one was in NIV Pune. Within a few months, with the cooperation of all of you, the testing got ramped up and a few thousand laboratories could do that kind of test in every district, every town, in many larger villages also. So realizing the need for preparedness for the future, whether, if, God forbid, but if there has to be some other kind of, some zoonotic disease or some other outbreak, we should be much better prepared in terms of infrastructure, in terms of human resource, to tackle any kind of health emergency if it arises. So every district having an integrated public health laboratory for testing. Other than that, strengthening of the ICMR laboratories across the country. About 3,000 crore is being given to the ICMR for strengthening its laboratories. Strengthening of the NCDC, National Center for Disease Control, and its branch offices across the country. A few thousand crores going for that. So all put together, 65,000 crores to be spent over 4 years till 2026. The single biggest comprehensive healthcare infrastructure program ever in the government, anywhere, whether in the central or in the state government. So all this is being done with a plan, with a focus that our healthcare infrastructure, our healthcare professionals should be well equipped, well trained, all kinds of facilities should be available with them, even in the public sector. Private sector, of which many of representatives are sitting here, you're already doing your bit. All of you have gone beyond the call of duty during the crisis times. And I'm sure that even in normal times, you do contribute tremendously to the overall healthcare system of the country. Another very major initiative which has taken place 2 years back along with this infrastructure mission has been the digital mission. And the digital mission, what does it do? Or what does it propose to do? Every individual, every citizen in the country should have a unique Ayushman Bharat health account, which is ABHA, ABHA in short, an ABHA account number ID. So out of 140 crore odd, about 47 crore citizens already have an ABHA ID number. What is the point of having this unique number? But then when we generate our digital records, any prescription, any diagnostic report, any X-ray report, any ultrasound, MRI, whatever, any scan, everything will be digitized and linked with the ABHA ID. So what we foresee some years down the line, there will not be any paper prescription, there will not be any paper reports to carry, to preserve. Everything will be available digitally to every treating doctor, to every physician consultant, of course, with the consent of the person. Nobody can access his accounts, her accounts, without the patient's consent. Today, a patient has gone to a hospital in Lucknow. She has generated some record there. Tomorrow, if she comes to Delhi, to some hospital for advice, for consultation, for opinion, she does not have to carry the bulk of her records. Everything would be under digital thing. The treating doctor in Delhi would seek her consent, have access to her accounts, with her consent, with an OTP kind of arrangement, so that the data confidentiality and secrecy can be maintained. Only the desired person with the consent of the patient can have access to that particular data. So 32 crore for 32 crore citizens, all their health records are already linked. And this is an ongoing process. I solicit the support of all of you. Many of you must be running hospitals and other health establishments to kindly get more and more of these ABHA IDs generated through a portal. It's very simple. Next, the second component of the digital mission is registry of health professionals. It's called HPR, Health Professional Registry. Every health professional, from the senior most doctor to the humblest technician, allied healthcare professional, everybody has to get registered so that the country exactly knows how many of which category of professionals there are. Then the third is HFR, Health Facility Register. Again, whether it's a single person clinic, single doctor clinic, the smallest of diagnostic testing facilities, to the largest of the tertiary care institutions in the country, every health facility has to register with some details. It's all online, it's been made very simple, but unfortunately, just about 3 to 4 lakh of health professionals so far registered, just about 3 lakh plus of health facilities have so far registered. So there's still a long way to go. So this digital mission is going to transform the way healthcare is being imparted in the country. Already, the telemedicine thing has revolutionized. We have a scheme by the name of e-Sanjeevani. And it is available even at the primary level, even at this Ayushman Arogya Mandir, where there's not even a doctor, we have only a community health officer. Even there, the telemedicine facility is available. More than 18 crore, 180 million teleconsultations have happened over just the last 2 to 3 years. So just imagine the scope and reach and the scale of technology. Even at the remotest area, where no specialist would ever dream of going, that specialist advice can be available to that health functionary sitting in the remotest area at the primary level through technology on her mobile phone, tablet, or laptop, computer, desktop, whatever facility is there. So that is the transformative power of technology, and we are using it in health in a very big way. There are many other initiatives which are going on, but I think I could not keep track of time, but मैं यही कहना चाहूँगा कि आप हेल्थ केयर ऐसा सब्जेक्ट है जो एंडलेस है, हम जितना भी कार्य करें वो कम पड़ता है, और सरकार बहुत प्रयास कर रही है, बहुत ज़्यादा काम कर रही है, लेकिन फिर भी जो निजी क्षेत्र है, प्राइवेट सेक्टर, उसका पूरा सहयोग भी वांछित है, अपेक्षित है। और जब आपका सहयोग मिलेगा, कंधे से कंधा मिला के चलेंगे, तो देश के हर नागरिक तक वो स्वास्थ्य सुविधाएं उपलब्ध हो सकेंगी जो आज बड़े शहर में रहने वाले लोगों के पास है। तो कुछ राज्यों ने बहुत इनिशिएटिव भी अच्छे लिए। मध्य प्रदेश ने पीपीपी मॉडल स्वास्थ्य के क्षेत्र में किया है, उनके जिला चिकित्सालयों में, सीएचसी में, पीएचसी में बहुत सी चीज़ें उन्होंने आउटसोर्स कर दी हैं, डायग्नोस्टिक्स कर दी हैं, रेफरल कर दी हैं, स्क्रीनिंग्स कर दी हैं, इवन एमआरआई सीटी स्कैन तक कर दिए, एक्सरेज कर दिए, और 1-2 साल से वो प्रयोग चल रहा है और काफ़ी हद तक सफल भी रहा है। तो हमारा देश जनसंख्या के आधार पर सबसे बड़ा देश है, इतनी ज़्यादा यहाँ पर स्वास्थ्य की आवश्यकताएं हैं, कई क्षेत्रों में अभी भी उस हद तक सब प्रयासों के बावजूद नहीं पहुँच पाए हैं जहाँ होना चाहिए। तो जितना भी प्रयास निजी क्षेत्र भी करे, हम भी करें, तो जो आदर्श स्थिति है हम वहाँ तक पहुँचने में सफल हो पाएंगे। और हेल्थ केयर के बारे में ये समिट आयोजित हुआ। एक मैडम ने लास्ट में कहा था कि आयुष को और मॉडर्न मेडिसिन को का मिलन होना चाहिए, का इंटीग्रेशन होना चाहिए। तो आपको सूचित करते हुए मुझे हर्ष है कि ये प्रयास सरकार में काफ़ी गंभीरता से चल रहा है, और जो एम्स जो हैं हमारे, एक तो दिल्ली का एम्स है पुराना, उसके बाद 21 एम्स और हो गए हैं, 22 एम्स, न्यू एम्स कहते हैं। वहाँ पर करीब करीब सभी एम्स में आयुष ब्लॉक एक अलग से स्थापित है, बट वो पूरी तरह से इंटीग्रेशन नहीं है। पूरी तरह से इंटीग्रेशन तब होगा जब प्रोटोकॉल इस तरह से बनेंगे कि उसका कुछ हिस्सा ट्रेडिशनल मेडिसिन से ट्रीट होगा, कुछ हिस्सा मॉडर्न मेडिसिन से ट्रीट होगा। अभी हमारे ट्रीटमेंट प्रोटोकॉल्स इस तरह के नहीं हैं, बिल्कुल अलग अलग हैं। मॉडर्न मेडिसिन के ट्रीटमेंट प्रोटोकॉल बिल्कुल अलग हैं, ट्रेडिशनल मेडिसिन के बिल्कुल अलग हैं। कोविड में एक प्रयास अवश्य हुआ था कि जब कोविड ट्रीटमेंट प्रोटोकॉल जारी हुए थे, तो पहली बार एफर्ट हुआ था कि आयुष का भी कोविड प्रोटोकॉल और मिनिस्ट्री ऑफ हेल्थ का कोविड प्रोटोकॉल, मॉडर्न मेडिसिन का, दोनों को एक ही डॉक्यूमेंट में रखा गया था, लेकिन प्रोटोकॉल अलग थे, क्योंकि कोविड में बहुत से लोगों ने, करीब करीब घर घर में बहुत से लोगों ने देसी नुस्खा भी अपनाया, चाहे वो काढ़ा हो चाहे कुछ हो। तो आयुष और मॉडर्न मेडिसिन दोनों को मिला के आगे ले जाने का उद्देश्य है और उस पर बहुत तेज़ी से प्रयास भी चल रहे हैं। इस अवसर पर मैं और अधिक कुछ नहीं कहना चाहता। मैं यही आपको विश्वास दिलाना चाहता हूँ कि भारत सरकार पूरी तरह से स्वास्थ्य के क्षेत्र में समर्पित है। बहुत अधिक प्रयास हो रहे हैं, धन की किसी प्रकार की कोई कमी नहीं आने दी जा रही है। 22 एम्स आज बन रहे हैं, 15-16 स्थापित हो चुके हैं। एक एक एम्स में 1000 से 1500 करोड़ रुपए सिर्फ बनाने में खर्च होते हैं। रनिंग में बड़े एम्स में 2-3-4 हज़ार खर्च होते हैं। दिल्ली एम्स में एक साल में 4000 करोड़ खर्च होते हैं। छोटे एम्स में 1000, 1500, 2000 करोड़ खर्च होते हैं। इस तरह का इन्वेस्टमेंट सरकार स्वास्थ्य के क्षेत्र में कर रही है, क्योंकि हर एक नागरिक तक, अंतिम छोर पे जो खड़ा हुआ व्यक्ति है, गरीब से गरीब व्यक्ति है, उस तक अच्छी स्वास्थ्य सुविधाएं मुहैया हो सकें, इस उद्देश्य के साथ आगे चल रहे हैं। और मैं आशा करता हूं आप सभी जो बहुत ही बड़े प्रतिष्ठित डिग्निटरीज यहाँ पर हैं, आप सबका भी सहयोग स्वास्थ्य के क्षेत्र में, जो भी आपका क्षेत्र हो, चाहे मैन्युफैक्चरिंग का हो, अस्पतालों का हो, सर्विसेज का हो, जो भी क्षेत्र में आप कार्यरत हों, आपका भी सहयोग पूरी तरह से देश को मिलेगा, सरकार को मिलेगा। तो निश्चित रूप से जो आरोग्य और आयुष्मान का एक लक्ष्य लेके हम माननीय प्रधानमंत्री जी के नेतृत्व में जो अग्रसर हो रहे हैं, वो अवश्य साकार होगा। पुनः आयोजकों ने मुझे आमंत्रित किया, बोलने का अवसर दिया, उसके लिए मैं हमारे मंत्री डॉक्टर मनसुख मांडविया की तरफ से और स्वयं अपनी तरफ से आपका बहुत बहुत आभार प्रकट करता हूँ। धन्यवाद। जय हिंद।
Thank you very much, sir, for giving us your valuable time and sharing all the insights with us. Ladies and gentlemen, once again, let's have a round of applause for Shri Sudhansh Pant, Secretary, Ministry of Health and Family Welfare. Thank you so much for joining us today, sir. Now, ladies and gentlemen, we have a fireside chat about the next pandemic. Are we ready? First up, I would like to invite our moderator on stage, Mr. Utpal Bhaskar, Assistant Managing Editor, Mint. And for the fireside chat, I would like to invite our speaker, Dr. Kaushal K. Verma, Dean Research, AIMS.
Thank you.
Chat on the next pandemic. Are we ready? Over to you, sir.
It was quite a informative session, the one just prior to us, when the Union Health Secretary took us through what the government has done in all these years, basically talking about how this health infrastructure, the public health infrastructure in the country has been made pretty robust. Also, from where we were, in fact, I'm a reporter, so at the end of the day, I got my news point out of that, which was, we'll be ready for the next thing which is coming. It's also, I'm not saying that we are trying to be prescient here, but also there are a lot of these pressure points which have been building out there. And the big issue in the room, and which I'm going to ask you, Professor Verma. Professor Verma needs no introduction. He's the Dean of Research at AIIMS, Delhi, which is India's premier medicine research institute as well, while one part of it is obviously healthcare. There's a lot of research. They are at the cutting edge of research in medical research in the country. He has been associated, he was a student there, and he has been associated with AIIMS for a long period of time. I'll not take much of your time. In fact, the stage has been pretty much set up for this conversation. As I said, the earlier news point was, whatever will be coming, maybe the next, and I'm not trying to tempt fate here, but whatever next is going to come, we'll be ready for it. Sir, I wanted to start on that count. Your microphone is there, yeah. So I'll ask you a couple of stuff, and given that this room already knows the topic, so this room is filled with people who practice medicine, who are in the business of providing healthcare in this country, who have been running their own organizations. So this room absolutely is aware about the topic of the day. But my question to you is, given this unique position, he advises the government. He's also advised, and please correct me if I go wrong anywhere, but he has advised the government of Nepal as well. Professor Verma, my question is that obviously in everyone's mind there was this pandemic, and some of us have already forgotten about it. We don't use masks these days. We don't sanitize our hands and stuff. My question is, what have we learned from this pandemic, which absolutely made sure that we lost, as in, it was not only a huge economic loss for the global economy, it's also about we lost our near and dear ones. In your experience, from where you look at it, what have we learned, and where were we and where we have reached now?
So before I start, I must thank the Mint Healthcare for having invited me to this very distinguished gathering, these distinguished speakers and the very eminent the audience, and asking me as to the next pandemic, are we ready? That's what the question that we need to respond to. Now the question is that, is there some imminent danger? Is somebody knocking on the door? Are we scared of something? So we have to be ready. So, the pandemics do not have the calendar that they would follow a specific date or a time that, yes, the Mint Summit is going to take place on 29th of November. So the pandemic is going to come on, say, 3rd of December, or maybe the 20th of January. These are the things which can suddenly happen. And what happened during the COVID, that we all know, that nobody expected that something of this magnitude is going to hit the entire world. We had seen the pandemics in the past also, like the SARS was there in 2003, which alerted us to future pandemics. And then, there have been sequence, the Ebola, Zika, MERS, H1N1. So you cannot predict as to what is going to happen in the given situation, and specifically when there is also a conflict with the nature, the climate is changing, and also our interactions with the human interactions with the animals are also changing. So to say that when it will come, we don't know. It may be just ready to come. There is already a building scare in the China that, yes, the respiratory illnesses have started increasing. And what we learned from the COVID is that we were not actually prepared for this. We had never anticipated that something of this kind would happen. And we were quite confident also in the first wave, which we could successfully contain to a great extent, and we told the world that, yes, we are capable of handling a problem of this nature, of any magnitude. And what we did in the first wave, we become a little more complacent, and we thought now the problem is over and we can relax. But that didn't happen. Soon after, the second wave came, which in fact was far more dangerous, troublesome. It caused far more extensive damage in terms of the human lives, the economy. And you talk about anything or everything. We have gone through this. That yes, everything had to be stopped for a considerable length of time to contain this, to overcome this, and then possibly to save our own people, save our own life. But despite that, we lost many, enormous loss of the WHO says the reported loss of life was about 6.8 million. But what is the estimated one, which is not reported, which is not recorded? It is said to be something between 16 to 28 million, which is a huge number. So there has been a gap. And we also know that, yes, the people who died in the hospitals, they were recorded. There's some recording that happened at the cremation sites also. But there were several places like in the villages or in the remote areas or in the rural setting where there has been no recording. So the number is expected, and probably it was much higher than what is reported on record on the papers.
So sorry to interrupt your chain of thought. When you talk about this reported number being much higher, and obviously you're taking a global figure there. In your estimate, sir, what would be the unrecorded number? What would be the size of that universe that Indians lost their lives, sir?
We can't say this, but what is the data that is available is actually global. And there they say that as it has been, say, to the extent of about 2 to 3 times more than
what was reported.
But we don't know if this is true for our setting also, or we also had the similar losses. But possibly we might have also missed some which were not put on record.
True. So now you mentioned China, and there is this scare, and you absolutely hit the nail on the head. I do get it that pandemics don't follow our news cycle. We follow how happens out there. Do you think there is but whatever is building up in China, is it something to be worried about? Because obviously there are meetings which have been held within the government as well. WHO has issued alerts. From where you are looking at this, what do we need to do at this point of time, both as common citizens and also from a policy perspective, what needs to be done?
Something of this nature, when it is coming in one part of the world, and now we have no borders. The people travel so frequently and so many across the world from one place to another one. And we can go back to the previous, say, the example that we were citing. In Wuhan, the severe respiratory illness were noticed. And within a short period of time, that was probably December, and by February, it spread to 26 countries.
That was quite...
26 countries. And out of these 26 countries, the direct transmission that happened to about 23 countries from China. So the large number of people traveled from one place to another one and carried the virus. And the other 3 countries, they had the, say, person traveling to one country and then from there to another country. So if there is something building up in one part of the world, I think we need to be careful. That yes, given the current situation, the current disposition, it can easily go from one place to another, from one country to another country. So we have to be alert, we have to be careful.
Sir, are we prepared as a country? When I say medical infrastructure wise, in fact, that's a point that the Secretary was also making, that so given that and I'm sure everyone in this room was touched by the tragedy which had unfolded at that point of time. I'm sure people will remember a time then there were like oxygen cylinders were becoming like manna falling from heaven if someone could get it. There were all kind of medicines which became a kind of a common knowledge at that point of time. Are we prepared as a country? Something like this comes, can we confidently say yes? Of course, you can't predict one whenever it comes, but given that there's a scare which is already built up on our eastern flank, which has already built up in China, are we prepared? You are you're basically taking care of something which obviously people will ask you these questions, and whatever you say will give us a sense of comfort or will also make us alert about what needs to be done.
I think I'm not probably the right person. Also, the director was supposed to have been here, but he got busy with something else. So he asked me if I could go. So I am a choice. I am not the person by choice. I am person by compulsion or maybe by default to tell you. But there is no one straight answer. But I feel that yes, we are now better off in the sense that we have learned certain lessons from the COVID pandemic, and which we think we should not forget. Our preparedness in terms of dealing these kind of, say, the pandemics is certainly better than what it was at that time when the first wave came, or maybe when the second wave came. The third wave probably we could contain better. Mm-hmm. So if in such a eventuality, what happens when there is an emergency? You have to act to the best possible measures that you can take in terms of everything.
We are reacting most of the time.
Yeah. So yes, and that probably might be there, and the necessity then becomes that yes, you should have a resilient healthcare system, which would mean that yes, if such a situation arises, then you should be able to handle the problem which has come suddenly, while not compromising on the basic care which people needs to be given. So what happened during that period of time, when the COVID came, the all health sector resources, they were diverted to the COVID care. Our own hospital was almost completely converted into COVID hospital. Mm-hmm. Our trauma center, which is another center, was completely converted into COVID care. Our another center, which is in Jhajjar, Haryana, about 600 bedded, 700 bedded, that was also completely converted into COVID care. Mm-hmm. So in the process, what happened, the people who required the emergency care are the people who were having other problems, like somebody is having, say, heart disease or uncontrolled hypertension or the diabetes or tuberculosis. They suffered in the sense that so much of care, their care to a certain extent got compromised. We were admitting the serious patients even during that period of time also. Mm-hmm. But because of the travel restrictions, many people could not access the healthcare services. They could not reach the hospital. And for example, like let's say tuberculosis, where the treatment has to be given continuously. Mm-hmm. If you stop the treatment, there are two, say, great dangers. One is that the patient might become resistant to the medicines which are conventionally used. Mm-hmm. And the medicines which are to be used for the resistant tuberculosis are, say, about 10 to 15 times more expensive, and it requires much longer time also. So that's one. And the second is that, if they discontinue treatment, there is a risk that they might die also. Mm-hmm. So the resilient system needs to be built in the sense that you should be able to provide the needed care to the needy people, and at the same time should be able to meet the requirement of that emergent situation.
Right. So, not to sound like a scaremonger, but that's the topic of the here to be discussed. In fact, my colleague Priyanka, who happens to be one of the best health reporters in the country, she's not here, she wanted to ask this question in person. The next one, that's the pandemic, that whatever the modeling which would have been done, will it be a respiratory virus or another zoonotic disease?
Can't say, but the respiratory viruses, they spread relatively faster. Mm-hmm. Because they are airborne. Mm-hmm. And the zoonotic diseases, they are becoming slightly more often occurring in the community, as we have seen in the past also. For example, the SARS, the H1N1, and the MERS. So there is a danger, there is a risk that yes, the zoonotic diseases, when they come to the human, they become difficult to manage.
Right. So let me make you wear your research hat. Now, given that you are at the forefront of medical research in the country, please take us through what is your institute, which is, and obviously for everyone, AIIMS Delhi is a place of last recourse. It also gives people a lot of confidence that if you have reached AIIMS, maybe there are chances you might survive. And obviously, you're not driven by this this chase for average revenue per bed kind of a chase. My question then happens to be, please take us through some of the cutting edge research that AIIMS is doing and which you are heading at this point of time.
If you're talking about the research, what AIIMS is doing, we are doing research in almost every areas. We have about 56 departments in our institution.
Wow.
And there are 8 centers, those specialized centers, and each department is engaged into research. Some are doing the very basic research, the fundamental research, some are into the clinical research, some are into applied research, and some are into translational research that is needed in terms of, say, what the country needs, the world needs, and also in terms of for the advancement of the medical sciences. So there is not one area that I should specifically point out as to which area is being researched and people in which area people are working.
So take us through, at least give us a couple of examples that you think that will be able, given the country which is the most populous country in the world, at least take us through something, a particular area of research that you think holds the kind of a potential that will also not only take care of some of these diseases. I'm sure people will keep on asking questions about when will cancer be cured. That's not my question. My question being that, is there anything right now that you are at the forefront of it that you think that, obviously research takes time, it takes perseverance, it takes an amount of resources. It also takes patience in the sense that obviously the secretary mentioned around 4,000 crore being spent annually at AIIMS Delhi. The second part of my question there would be, of this 4,000 crore rupees being spent at AIIMS Delhi annually, how much of that goes towards research? So my first part is about, if you could tell us there's something at the cutting edge right now you're working at, your institute is doing, that would absolutely make life much more easier for most people in India and elsewhere in the world, obviously, because research doesn't get then contained, and also the kind of resources which gets deployed towards it.
I think we need to understand that the research is the person or the individual initiated in his or her area of interest. They choose a research area that I want to work in this particular area. Then they put up the research question. They develop the research hypothesis and the research project, and then they ask for the funding. So as far as the institution is concerned, we have a lot of research funds available. There has never been a scarcity in the sense that the funds were not available, so research could not be done. And then we have the other funding agencies also from the Government of India and the international organizations like Indian Council of Medical Research is funding research, Department of Science and Technology is funding research, Department of Biotechnology is funding research, CSIR is funding research. So as of now, we have, say, research projects which are running about 900 something, close to 1,000 research projects that we are handling now.
That's quite a number.
And we have the funding to the extent of about 200 crores, which are being spent on the research. So anytime when there is a necessity or the inclination on the part of the researcher, the scientist, the faculty, that they want to do a research in a specific area, the funds are there. We have the availability of funds.
Sir, and this is, and I'm sure you have had a long day. I believe you start your day at 7 in the morning. You have never missed a day of your OPD still, despite taking over as the Dean of Research at AIIMS. My last question to you would be, sir, given that, and particularly for a disease burden for a country like India, and anything which gets done in this country, it would have never been done on a scale anywhere in the world by the sheer size of our population. But the kind of a playbook that has been adopted by the medical fraternity in this country for disease management, and I'm not trying to ask you that on a scale of 1 to 10, where do you rank it, but do you think that we are at least up there? Of course, we want to become a developed economy, and health is being a very important component of that. Where do you see, would you rate our disease management system, the playbook here, and how much do you think that needs to improve going forward?
I think we are much better off compared to several other countries in the world. And in fact, in certain aspects, we are much better off than even the most developed nations in the world, also in terms of providing the healthcare, the disease control, and even to the patient satisfaction. For example, I'm a dermatologist. I'm not an epidemiologist who is talking about the COVID pandemic and the next pandemic and what will happen, or maybe I'm not a policy planner also for that matter. I'm a dermatologist. I'm a professor of dermatology. I'm heading the department of dermatology. In UK, if you have to see a dermatologist, you will have to wait for 6 months.
True.
In US, if you have to see a dermatologist, you will have to wait for at least 4 months. Here, AIMS, if you go through the proper channel, you can get an appointment in about 4 to 6 weeks' time. But if you have an emergency, you can access the dermatologist care anytime. And even in the routine cases also, if you make a request, maybe within a week. And we provide the world-class treatment which any country in the world can provide, despite having limitations. But yes, and that is why one of the reasons that we are attracting a lot of medical tourism, that yes, we provide the quality care at much economical cost. And also you will be surprised that AIMS does not charge anything. Even for the inpatients, it's all free. Unless you ask for a private room, then you obviously have to pay. But for the general patients, anybody who is coming to the hospital is not charged even a single penny. So in terms of, say, if you're talking about the healthcare as such, I think we are at a much, much better position than several other countries in the world. And that healthcare is so economical to the people. It's quite affordable.
So that's a very comforting thought. On that note, I'd like to open the room for a couple of questions. And anyone who would like to ask a question to Professor Verma, please raise your hand. Introduce yourself. Please make it a question. Don't. I would not like to preach to the pulpit. So if there's anyone who would like to ask a question, please raise your hand, introduce yourself and ask a question. I do not see, the microphone to the front, please. Thank you. Ma'am.
Very good evening, sir. Very enlightening thoughts. Jyoti Kaur from Yashoda Super Speciality Hospitals, Kaushambi. I would like to know that which, according to you, would be the 3 priority sectors or the subjects in which India should take forward, or the hospitals should take forward the research?
As far as the research is concerned, I think we have, say, in both the areas that needs to be worked on. What we were earlier concerned about was the communicable diseases, which were our major problem. But now we have the non-communicable diseases also becoming an equally difficult situation. They are equally problematic. And then, of course, what we are now facing is another challenge, is the climate-induced. Say the climate-induced diseases. And of course, cancer has always been a problem. We have made a lot of progress in that area. So I think all these 3 or 4 areas, they need still a lot of attention. We have not done away with malaria. We are not away from dengue. we have the cycles coming up every alternate year or maybe. Again, this is absolutely unpredictable. And what is happening now, the lifestyle diseases have started becoming a problem. Obesity, diabetes, hypertension. We are considered to be the capital of the diabetes in the world. So has started to having hypertension. And of course, the infections are tuberculosis. It's full. Even still, the country is full of tuberculosis. You might not be seeing in the urban setting, but in the rural setting, and even in the slums in Delhi itself, you have a lot of tuberculosis, lot of infectious diseases still there. So these all areas they need attention, and what needs to be done? Well, I think not just the research, the building the health infrastructure is most important. I think what the health secretary was also trying to emphasize, and the efforts are on that. Yes, the 22 new AIIMS or what we call AIIMS-like institutions are being set up. They're coming up, and I hope that yes, they would take care of some of the workload and the number of patients which are coming to AIIMS. You would be surprised that we get about 50,000 footfalls every day. If you come to the ROPD in the morning, between 7 o'clock and 9 o'clock, there are two roads which would be this wide, and they are basically meant for the cars. You cannot drive till it is 9:30 when everybody gets inside the hospital building when the registration opens. But we are still able to manage them. Thank you.
Would we get there's a supplementary there?
Sorry, taking too much time from everybody. Just as you mentioned about malaria, now the dengue research has brought about a vaccine in Singapore, but that itself is also restricted to about 45 years of age. Are we into a process here? Are we somewhere near to achieving something on the dengue front or the malaria front?
You mean the vaccine?
Yes, yes.
They are in the process of development. I think once they are getting available, then we
Yes.
would also have access to that.
And the age limits up to when you can take it, like there's a restriction in the Singapore one to 45 years.
I think that would again depend. You know, when the vaccine came for HPV, there was an age limit. So after this certain period of use and experience, it got lowered.
Okay.
So it can happen depending on the experience. Like when a new molecule comes, you're extra careful.
All right.
You're extra careful, that is, and you look at everything. But when it is put to clinical use, you develop the experience and confidence also. That yes, what we were doing earlier is not necessary. It's not required. It was not mandatory. Because your experience tells you that yes, this molecule is safe. It does not happen. But in the beginning, you are extra careful because you don't want to take chances. You don't want to take risks. For that matter, for example, I'll just give you one simple example. The molecules that we are now currently using, which are very recent one, are the biological agents. Biologics, what we call. You have to be extra careful that the infections are common. And these infections are common specifically in the Western population where the pathogens are limited. We get exposed to these pathogens anyway. So we develop immunity and the antibodies against them. So far in our setting, the infections are not so common. But in the beginning, when you're doing this, because the guidelines are set in such a way that you have to follow the guidelines. So you don't make a mistake. If you don't follow the guidelines, then there's a legal trouble also that yes, if something happens, then you will be questioned, why did you not follow the guidelines? But over the period of time, when you use it, you develop confidence, you develop your own guidelines, you develop your own experience, you say, no, this is not necessary. Like you screen for tuberculosis, everybody you screen for the tuberculosis and say, get the X-ray test done, Montu done, maybe get the CT done. But later on you realize, no, all three tests are, all tests are not necessary, maybe one is all right. And you don't have to do the very stringent, say, pre-administration workup. So it depends. Over the period of time, you develop the experience and you become more confident using it.
Thank you so much.
Thank you.
We are completely out of time. I think on that note, sir, we'd like to close the session. Thanks a ton for making out time for this. And absolutely a pleasure. And let's give a big round of applause to sir. Thank you.
And I would like to thank Mr. Bhaskar and the Mint Healthcare team once again for having given me this opportunity to be here amongst the very distinguished people and interacting with them. Thank you very much.
Ladies and gentlemen, let's have a huge round of applause for our last session. And thank you so much, Dr. Kaushal K. Verma, for joining us today. Thank you, Mr. Uttal Bhaskar, for moderating this fireside chat. Ladies and gentlemen, with this, we end today's summit. I want to thank each one of you for being a part of this summit and make it a success. Once again, I will take the opportunity to thank all our partners, our associate partners, All India Institute of Ayurveda, Yashoda Super Speciality Hospital, Kaushambi, RG Stone Urology and Laparoscopy Hospital, Merrill Life Sciences and Center for Sight. Thank you so much once again for joining us on this beautiful day and be a part of this summit. Please join us for cocktail and dinner and have a great evening ahead.
Foundation Day of All India Institute of Ayurveda. We are thankful to Honorable Minister Sri Sarvananda Sonowal ji, Dr. Mahendra Bhai Munjapara and our Secretary Vaidya Rajesh Koteja ji and all the senior officials for their ever